Good afternoon, everyone. My name is Nader Kamangar. I'm joined here today by Dr. Robert Su, who's the professor of radiology at UCLA, as well as the residency program director for the radiology residency at UCLA, as well as the director of interventional radiology there. This is an interactive session, so there are embedded questions that you're going to see, and we're going to be asking for you to actually use the audience response system as we go through these questions that will lead up to specific areas that Dr. Su will be highlighting. So please make sure when we get there to all vote. So without further ado, Rob?
Great. All right. Thank you all for coming. Thank you, Nader. All right, so okay, so when looking at a high-resolution CT, it's really important to keep the pathology-based terms clear and distinct compared to the pattern-based terms. So the pathology-based terms are really what's reflected on pathology. So these are going to be entities like UIP, NSIP, LIP, AIP, organizing pneumonia, desquamative interstitial pneumonia, respiratory bronchiolitis, interstitial lung disease, and Langerhans cell histiocytosis and lymphangioliomyomatosis. The pattern-based terms, on the other hand, are kind of a bird's eye or airplane view of what's happening at the pathology level, or what we're seeing on CT. It's just a reflection of what's happening on the pathology. So these terms are going to be a little bit vague, but for lack of better, these are kind of descriptive findings, such as reticulations, nodules, cysts. And there may be some terms like heterogeneous attenuation, so that there's alteration in the lung parenchyma. And you'll see terms, and we'll go over this, mosaic attenuation, airspace attenuation, or consolidation. And this can be in the form of heavy ground glass or just ground glass, and true airspace consolidation, where you can't see the underlying lung structures. So the patterns that we're going to discuss this afternoon are simply reticulations, nodules, cysts, and airspace disease, and some of the common entities that display these sort of radiographic patterns. So under reticulations, you have mostly the interstitial lung diseases, UIP, NSIP, chronic hypersensitivity pneumonitis, the nodules pattern or the nodular pattern, and we'll go through a number of these patterns, but clinical entities would be sarcoidosis, metastases, more of the airway-borne things like subacute hypersensitivity pneumonitis, cysts, as we kind of mentioned, those two entities, and airspace or predominant airspace disease in the form of organizing pneumonia and DIP.
So our first case is a 77-year-old man with a 3-year history of progressive dyspnea on exertion. The cases are intentionally kept brief so we can get through more. So you're going to see a few axial images. And a coronal there.
And then I'll go back through them.
So what is the most likely diagnosis here? Is this NSIP, asbestosis, idiopathic pulmonary fibrosis, or chronic hypersensitivity pneumonitis? Please vote. Great, 94. So you guys all have this down. I would just
Session's over.
Yeah. I think just although only 1% selected it, just to recognize that asbestosis could have very similar features. I mean, what are we seeing here? The predominant features we saw here is a reticular pattern that is more lower lung field peripheral predominance with reticulations, honeycomb changes, traction bronchiectasis and bronchiolectasis, and minimal amount of ground glass, asbestosis would not be inappropriate here if there were other features of asbestos-related lung disease like pleural plaques, rounded atelectasis, and a clear history. So that's the only other answer that could make sense with the appropriate additional findings.
Okay, so obviously we're in the first sort of gamut, which is reticulations. And again, we talked about, briefly mentioned UIP, NSIP, chronic HP, and the clinical entities that this may represent, IPF, collagen vascular disease, drug toxicity, or maybe in some cases asbestosis, or diseases that might give you reticulations. So when dealing with reticulations, it's important to look at the differentiating features. And so you'd like to know what the distribution of those reticulations are. Is it upper versus lower, central versus peripheral, segmental versus diffuse? Is it the pattern that you're seeing a heterogeneous pattern? Is it a more homogeneous pattern? When you compare right and left sides, do they kind of overlay or mirror one another, or are they very different? You also want to look for honeycombing, subpleural sparing, ground glass attenuation. And there may be some other clues on the film that give you maybe some idea or maybe a cue as to what the patient might have in terms of ancillary findings. So with asbestosis or asbestos exposure, you might look for pleural plaques. You might see arthropathy or dilated esophagus in some of the connective tissue diseases, as well as subcutaneous calcifications. In the setting of amiodarone toxicity, there may be a hyperdense liver or thyroid. And certainly, history is hugely important to help narrow the differential diagnosis or at least figure out what the pattern may be representing. So as you all know, UIP pathologically is characterized by temporal and spatial heterogeneity, and it's the characteristic or most distinctive feature here is the fibrogenic foci. Now, the CT features, the most common things that you'll see are going to be peripheral reticulation with a basilar predominance and honeycombing, if you see it, and you see it in generally 60 to 70% of the cases. There is not too much consolidation, but again, lower lung predominance, right? So here's just an example of a classic case of UIP, and this sort of classic presentation, or what we call consistent with UIP pattern, is seen in about 50% of patients. So here we see from top to bottom, you can see that the disease is predominantly subpleural, predominantly basilar. It's characterized by lines, reticulations, and certainly there's a huge degree of honeycombing. And honeycombing, if there's nothing else that you take away from this session, is that honeycombing is characterized by, again, these sort of thick-walled, polygonal, hexagonal structures, but within the actual area or the center of that is air density, not gray lung, but really black air density that's similar to the air that's, for instance, within the trachea or the larger bronchi. And that's really the true definition of radiographic honeycombing. So here we see just some additional images. And again, these are true honeycomb cysts. Again, very thick sort of inter and intralobular septa, irregular, and within the center of that area is clear air density, not more gray density of lung. And here we see the histopathology that goes along it. Again, the thickened septa. We see the fibrogenic foci and the honeycombing. And again, the gross specimen that the CT images reflect. Here's kind of the natural progression of what we see in IPF, UIP. And again, this is over 2 years, so it's a sort of a slow but stepwise deterioration over time. You see areas of coarse ground glass and reticulation ultimately becoming honeycombs, and with increasing architectural distortion and traction bronchiectasis and bronchiolectasis. So in 2009, Song looked at or tried to compare those patients with connective tissue or collagen vascular disease, UIP, versus those with idiopathic pulmonary fibrosis. They looked at 100 patients and found that the ones with UIP with collagen vascular disease largely were younger, women and non-smokers, and was associated with better survival. They had less fibrogenic foci, less honeycombing and honeycombing spaces, but had more germinal centers and inflammation, and they coined the term atypical UIP without honeycombing. The germinal center score was the best discriminative factor of distinguishing these two diseases, and age, total lung capacity, and honeycombing were independent sort of prognostic factors for improved survival. So here we just have a couple cases. All are path-proven UIP. And here we see a person with a dilated esophagus, and again, this is what I mean by looking at these ancillary findings for clues, but you see, again, a basal or predominant disease, reticulation, and honeycombing, and with a dilated esophagus, this was diagnosed as scleroderma. On your right, on the top, we see another patient with UIP, but notice, again, you see the dilated esophagus, but not quite the honeycombing, and you see a lot more ground glass in this case. And so again, not your classic UIP pattern, and the degree of ground glass may make you think it's something altogether different than UIP, but again, this turned out to be scleroderma lung disease with UIP. On the bottom, we see more ground glass attenuation, and you see that there's a lot more ground glass than the reticulation that we see here. And again, it is a subpleural predominant disease, and not much honeycombing, as you can see. And on the soft tissue windows, look what you see, a little pericardial effusion, and you see soft tissue calcification. So this is a patient with dermatomyositis, with lung disease, again, path-proven UIP. So the UIP that we see with collagen vascular disease may be somewhat different, or it often is very different than the UIP that we see with IPF. So let's look at some of these sort of more unusual features of UIP, IPF. So sometimes you'll see a ground glass predominance, as you see in this top image here. Again, the ground glass is a lot more than the reticulation, or outweighs the reticulation. There may be asymmetric involvement on this bottom image. You see that the left lung is more considerably involved than the right, and there's not so symmetric. You might see areas of focal air trapping, which again is not uncommon but unusual for UIP, IPF. You may see areas of pulmonary ossification, and so I don't know if it projects very well, but you see little hyperdense nodules within the densest areas of fibrosis on the bottom image, and these correspond to areas of pulmonary ossification. And these are the fibroblasts undergoing metaplasia from chronic inflammation to become osteoblasts and laying down bone. In 90% or more, depending on which series you look at, those patients with IPF, UIP have what we call small to medium-sized lymph nodes, and so these are diameters, short axis of 1 to 2 centimeters, and again, it's a reactive phenomenon. And in about 10 to 15% of patients with IPF, you have an accelerated deterioration or exacerbation. So here's a case that had just pretty much reticulations on the initial or baseline CT, but during the exacerbation, you can see an extreme amount of ground glass that has come about involving all lobes and almost all portions of the lung. This was a case of sort of AIP on top of the UIP that happened. Here we see sometimes when you're dealing with patients with very diffuse lung disease, common diseases are sometimes very difficult to tease out. And in this situation, the only clue as to the diagnosis here is if the sort of astute observation of small symmetric pleural effusions that you can see. And this was a case of somebody with idiopathic pulmonary fibrosis with a congestive heart failure exacerbation represented by the pleural effusions and small pericardial effusion. These patients, as you all know, are susceptible to infection. Here on the top image, we see a necrotizing pneumonia with a bronchopleural fistula and a pneumothorax, air fluid level within the destroyed lung. On the other side, in the left apex, you see a mycetoma. You see a more classic kind of consolidative pneumonia in this bottom patient, in the right middle lobe and in the left lower lobe. And as you all know, these patients are susceptible to lung cancer. And here's the same patient, a more superior image. You see a spiculated nodule in the left upper lobe, as well as one in the left lower lobe. This was a case of synchronous lung cancer in somebody with pulmonary fibrosis. And certainly, you can have air leaks or barotrauma. And so here you've got pneumomediastinum, and you have some a left pneumothorax, as you see in this case down below. That brings us to our next case.
So this is a 42-year-old with a 1-year history of progressive dyspnea with mild exertion as well as a chronic cough.
I just like the bigness of these images, right? Like so many talks, you see little images.
So what do you guys think? What is the most likely diagnosis here? Is this NSIP, asbestosis, IPF, or chronic HP? Please vote. Outstanding. So 2/3 of you got this right, and that 1/3 I think is not entirely wrong. But what we're seeing here on imaging was a reticular pattern with a considerable amount of ground glass attenuation. The ground glass attenuation and the reticulations, although more lower lung field, were actually very peribronchovascular along the bronchovascular bundles, or the axial interstitium as we call it, with actually some areas of subpleural sparing. There was also some degree of traction bronchiectasis as well as bronchial wall thickening. So chronic hypersensitivity pneumonitis would more often give you a reticular features with areas of mosaic attenuation and air trapping, and that Rob will go over in a bit. But really this was most consistent with NSIP.
Okay, so we're still in the gamut of reticulations, and so we'll talk a little bit about NSIP. So unlike UIP, the pathologic features can be divided into cellular and fibrotic NSIP, and again, unlike UIP, we're going to see a temporally and spatially homogeneous disease with a lot more inflammation without this characteristic fibrogenic foci. There's not too much architectural distortion, and certainly almost no honeycombing. What we see on CT is predominantly ground glass admixed with reticulation of variable severity, and it, in many cases, will spare the subpleural periphery, or the very edge of the lung, in about 66% of cases. And so this is what so here we see, again, we see a more axial disease, meaning the center of the lung is involved, or the center of the lobe. And we see a lot of ground glass, and the ground glass outweighs the degree of reticulation here, right? So what we're seeing is more of this sort of dense gray lung. And what you can see is by subpleural sparing, we mean that the entity comes up to the subpleural lung, but just has a ribbon of where the lung is not involved. And with NSIP, this is probably the most characteristic finding that we see, and we see it in about 66, 65%, depending on what study you look at, of the time. It's predominantly a lower lung disease, and as the fibrosis progresses, you'll see more architectural distortion, you'll see more traction bronchiectasis. Now here's a different case, and here we can again see the ground glass admixed with the reticulation, favoring the lung bases and posterior periphery. But note again that we see kind of that characteristic subpleural sparing. And so if you see this, it's very good for NSIP. if you look at a cellular NSIP case, it's often very steroid responsive because of the intense inflammation associated with this entity. And you can see that after corticosteroids, all that ground glass has pretty much resolved. I mean, there's still some areas. And then there are some more reticulations and coarse pattern, which is the underlying maybe fibrosis that has already ensued. So if you compare this to UIP, they're kind of two ends of the spectrum in terms of looking. NSIP tends to be more soft, homogeneous, it's a little patchier, and again, we have that characteristic subpleural sparing. But on the opposite end of the spectrum, we have IPF UIP, which is coarse, it's a lot of irregular lines, reticulation, and there's honeycombing, right? And rather than the subpleural sparing, the disease comes all the way to the lung edge. And so here we can see some nice characteristic images. Again, ground glass admixed with reticulation, subpleural sparing in SIP. Again, here we see reticulation, basilar predominance, subpleural involvement, and the characteristic honeycombing that we've come to expect with a UIP pattern. Now, just a note about chronic hypersensitivity pneumonitis. This is characterized by what we call very heterogeneous lung on CT. And so we've got areas of ground glass attenuation, reticulation, and then we have these areas of hyperlucent lung or black lung that look to be sort of groups or isolated secondary pulmonary lobules that are hyperexpanded. And ultimately, if you do expiratory imaging, these may, or you wouldn't be surprised if they trap a high degree of air. So this, at TLC, when you see the ground glass reticulation admixed with air trapping, this is what we call the head cheese sign. This can be segmental, the pattern can be segmental, there may be airway thickening because it is an airway process. You certainly will see reticulation. There may be a basilar predominance in about a third of cases. But the extreme lung bases may still be spared. And as you know, there may be some subacute findings depending on the chronic antigen exposure, and most of the time we don't know what antigen has caused this process. So here we see just a different case. Again, we can see quite a bit of ground glass associated with this, admixed with areas of fibrosis and what turns out to be lobular sparing or mosaic attenuation due to air trapping.
So our next case is a 45-year-old African-American male with a 3-month history of cough, dyspnea, and intermittent fevers. So what is the most likely diagnosis here? Is this subacute HP, stage 2 sarcoidosis, silicosis, or miliary TB? Please vote. Great. You guys are right on. This is indeed stage 2 sarcoidosis. What we saw here was a completely different pattern, a micronodular pattern of nodules less than 1 centimeter that are too numerous to count. Moreover, these nodules were really preferentially lining areas that involve the lymphatics, such as the pleura, the fissures, as well as the axial interstitium or the bronchovascular bundles. On the axial views, we saw that the distribution was slightly more preferential to the mid to upper lung zones. And if you paid some more attention to the nodes, you did indeed appreciate that there were, even though these were lung windows, some degree of mediastinal and hilar adenopathy. So this indeed was stage 2 sarcoid.
All right, so as you may have guessed, we're heading into a different gamut of nodules or a nodular pattern. Now, when differentiating nodular pattern of disease, it's really important to understand the structure of the secondary pulmonary lobule. And by that, here we have a unit, the secondary pulmonary lobule. It ranges in size anywhere from 1.5 to 2.5 centimeters. And you see that here's the pleura. You see interlobular septa. And within the interlobular septa, you have the septal vein. And each secondary pulmonary lobule is subtended by a lobular bronchiole and an arteriole, and that has a little bronchial artery, and also there are lymphatics that run all along this, as well as within the septa and along the pleura as well. And so here we see on CT just kind of what that secondary lobule, pulmonary lobule would look like. So when dealing with this nodular pattern, you're trying to figure out what the nodule's relationship to the secondary pulmonary lobule structures are. And that gives you maybe some insight as to what the distribution pattern overall is of where these nodules are caused by or where they're locating. And so what really you want to look at are the relationship of these nodules to the fissures, the pleura, the septa, and make the observation, are these nodules clustered or are they kind of just diffuse and random? And we'll go over this. So if you're dealing with a small sub-centimeter nodular pattern or a lot of them, first question you want to ask yourself, are these nodules on these lymphatic pleural surfaces? Are they on the fissures? Are they on the pleura? Are they on the septa or on the peribronchovascular lymphatics? Next question you want to ask yourself, are these nodules clustered, or are they sort of isolated and you see one at a time? And when you decide on localization, these are the patterns of distribution. So you think of perilymphatic patterns of nodules, random patterns of nodules, centrolobular, meaning it's the center of the secondary pulmonary lobule, or is it more of a small airways pattern? So let's break this open a little bit. If we see most of these nodules congregating in areas that contain lymphatics and pleura, the fissures, the septa, and the pleura, as well as the peribronchovascular lymphatics, if we see that, we're really dealing with a lymphohematogenous process. This could be isolated to just a perilymphatic process, sarcoidosis, silicosis, lymphocytic carcinomatosis, or it may be that it's a random pattern, meaning that, for instance, METs and miliary infection are seeding those lymphatic structures, but they're also going elsewhere within the lung. If we don't see this sort of lymphatic pattern, then we're really dealing with the kind of an inhalational process. So the agent is coming in through the airways. It could be more generalized in a central lobular pattern, meaning it's hitting all sorts of airways at one time, as in the case of smoking-related lung disease, hypersensitivity pneumonitis, or it may just be isolated to the airways and kind of clustered and focal, and in cases of cellular bronchiolitis and panbronchiolitis. Now, if we add the clustering, meaning that these nodules are clustered on surfaces, if they are clustered and we are dealing with the perilymphatic process, you're really talking about sarcoidosis for the most part. And if you see them clustered but not in a perilymphatic way, and none of those surfaces are involved, you're really talking about a small airways process. So in addition to the distribution localization, sometimes the morphology of the nodule is important. The density. How dense is it? Is it small, dense, or soft tissue as opposed to more ground glass? What are the edges like? Are they sharp, ill-defined? And what's the morphology? Are they branching or what we call tree and bud? So let's look at the perilymphatic pattern. And up here you see a diagram. Again, we see the secondary pulmonary lobule, the subtending lobular bronchus, and the artery. And first of all, you notice that these nodules are small and very dense with sharp margins. Next, you know that, look, they're involving all these lymphatic structures that we talked about, the septa, the pleura, the peribronchovascular lymphatics. Now, some would say that you need at least 10% of the nodules going on those surfaces to call it that these surfaces are involved. Others would say greater than 90. And again, you see that they're clustering to the lymphatics. And so really, again, this is characteristic of perilymphatic disease, sarcoidosis, silicosis, and to some degree lymphangitic cancer. So here, again, we see some cases, different case. We see, again, look at where all these sort of well-defined soft tissue nodules are. They're on the fissures, they're on the pleura, and they're on the septa and along the peribronchovascular lymphatics. Here you see the specimen of loosely formed granulomas and interstitial thickening, which is characteristic of sarcoidosis. Here we see in a different patient, again, you see nodules, but you see that the nodules are again on the septa, you see them on the pleural surfaces, the fissures, and along the peribronchovascular lymphatics. So this is a perilymphatic process. First and foremost, you think of sarcoidosis. Here we just have another image. Again, look at the fissures, just beaded with nodules, right? You see septal thickening and nodularity, pleura, and again, some beading of the peribronchovascular lymphatics. Now, here we see a case where you got larger irregular nodules, but that really shouldn't dissuade you from thinking that it may be sarcoidosis, because look at where these nodules are. Again, along the fissures, along the septa, right, and along the peribronchovascular or septal lymphatics. And so again, this is another case of sarcoidosis. Now, with sarcoidosis, sometimes you'll get architectural distortion, meaning that the lay of the land is not quite what it should be, and areas of lung look to be stretched, others sort of distorted and cicatrized, and that's because this is a chronic inflammatory process. You may see this, what we call peribronchovascular beading. And so when we look at the bronchus, the bronchioles and the bronchi, as well as the arteries, they look like they have little nodules or studding along the surface. As that fibrosis sets in with the chronic inflammation, you may see sort of this angulated bronchovasculature because of the distortion and fibrosis associated with it. If you were to look at this patient in maybe three, sort of divided them into thirds in a coronal situation or plane, you can see that characteristic of sarcoid, the apico-posterior segments are the first and most severely involved, and it's a middle third disease here. See that in two different cases. And as you all know, these areas of fibrosis are going to gravitate to the mid and upper lung. And again, coronal, sagittal reformats, as well as chest x-ray, really help you in cases of diffuse disease to see where the concentration or predominant portion of the disease is. And here, in some cases, you might see honeycombing, even in cases of sarcoidosis. Rare presentations or features of sarcoidosis, you may see ground glass attenuation or even airspace attenuation, as is in this case of alveolar sarcoid. You might see septal thickening, as you can see here. Now, a lot of times, if you see a lot of septal thickening, rather than lung infiltration itself, you might want to think of a cardiac involvement of the sarcoid with heart failure. And on some occasion, you can have what we call bullous sarcoidosis. And so this is due to air obstruction and cyst formation, as you can see in this case. And on rare occasions, you may see pleural effusions, but again, that may be in the context of more cardiac sarcoidosis with heart failure.
All right, moving on. 28-year-old male presenting with a 6-week history of fevers, night sweats, non-productive cough, and 25-pound weight loss.
I think every year we say that we want music,
Yeah.
but we forget to do it.
So what is the most likely diagnosis here? Subacute HP, stage 2 sarcoid again, silicosis, or miliary TB? Please vote. Great. The majority of you got this indeed right. This is miliary TB. If you just go back, Rob, we did see nodules that were too numerous to count. They were clearly involving areas lined by lymphatics. We clearly saw fissures were involved. The pleura was involved, but there were also nodules that were not involving those areas, nodules that were kind of randomly dispersed without predilection to the perilymphatic structures, and that's what we call random. And certainly in this case, it would be a hematogenous infection that would work. Hematogenous Mets would be a possibility here. Certainly, usually there would be variation in the sizes, as Rob will point out. Occasionally, papillary thyroid cancer can give you very, very small millet seed nodules, not dissimilar, but often there too there is some variability and not necessarily these millet seed nodules as we see here with hematogenous spread of tuberculosis.
All right, so now we're kind of talking about random nodules and moving away from perilymphatic. And so here again, you can see nodules fairly well defined, well marginated, and carry a little bit of soft tissue density, or at least more than just simple ground glass. Now, again, when you ask this question, are they involving the lymphatic surfaces? Yeah, you have a few on the pleura, you might have a few on the septa, you might have a few along the peribronchovascular lymphatics. But then you have other nodules that, hey, I don't know, they're just kind of floating in space within that secondary pulmonary lobule. And so when you see this sort of kind of distribution involving the perilymphatic surface a bit more, and you can't place some of these nodules, this is what we describe as a random pattern. When you're dealing with random pattern, really you're only dealing with sort of this lymphohematogenous spread of malignancy or infection. So again, clustering, not so much clustering like we saw with the perilymphatic diseases with all the nodules on the lymphatic surfaces or structures. So this is what random looks like. You can certainly see nodules on the pleura. You can even see some nodules lined up along a septa, but other nodules are just kind of thrown out there, and what you have is a fairly homogeneous perfusion. Like if you move your eyes from the lateral part of the lung to the medial part, you kind of see an evenness to this distribution of nodules. So with random distribution, they're fairly uniform. They're not clustered. They may be low or low predominant because if they came in via the bloodstream, it's going to go where the blood flow is the most. They're solid density with sharply defined margins. Now, some of these nodules may share similar size depending on the gradient. So, for instance, if they're all getting to the lower lung by blood flow, sometimes the earliest metastases may be all very similar in size and larger down in the lower lung than in the upper lung. There may be a feeding vessel sign owing to the fact that they're vascular borne. They may cavitate, and if it's, they may involve lymphatics as they sort of take up residence in that area. So when you're dealing with metastases, we're dealing with renal, testicular, thyroid, and melanoma. With miliary infections, we're talking about tuberculosis, but other fungal infections like cocci, histo, and even pneumocystis, and sometimes occasionally viral infections. Again, you see that, again, the lymphatic surfaces are certainly involved, but you see a lot of other nodules that seem to just be floating within the lung parenchyma itself. And here, again, in another case, we see some effusions. But look at all these nodules. I mean, like when you look from the medial lung to the lateral lung or top to bottom, it looks all fairly homogeneous. But the nodules are all over, fairly equal throughout the lung. Now, just a few words about lymphangitic cancer. Again, this is a perilymphatic process. It's characterized by smooth or regular or sometimes even nodular septal thickening. And it's a much more linear disease or a reticular disease than a nodular disease per se. There may be some, frequently there's axial involvement. Generally, there's no architectural distortion because cancer in itself doesn't necessarily scar unless it's been treated. There may be adenopathy in about 30% of cases, maybe pleural effusion. And the entities that we're talking about are the adenocarcinomas, the unknown primary, but certainly lung, breast, colon, and pancreas. And again, compare and contrast what we saw with the other, for instance, the perilymphatic sarcoid. Here it's a much more septal disease. It's more linear. Yes, we see some nodules, but that's really not too much of the feature. And for the most part, you see preservation of the architecture, and the secondary pulmonary lobules are not very distorted. And here we just see another case of lymphangitic cancer. Again, a lot more lines or septal thickening. There are a few nodules here and there, but again, it's a more linear disease. And on the soft tissue windows, you can see the mediastinal and bilateral hilar adenopathy in this case.
So our next case is a 23-year-old female non-smoker with a 3-month history of increasing dyspnea and dry cough. I think that these are a little bit harder to see. That's why we have it magnified here, just to get a better sense of things. So what is the most likely diagnosis here? Is this RB-ILD? Is this subacute HP? Is this pneumocystis jirovecii pneumonia? Or is this pulmonary coccidiomycosis? Please vote. Great. It looks like the top two choices are the ones that are most correct. What we see here are, again, nodules that are too numerous to count. And nodules, if you look carefully, they did not have a perilymphatic distribution. They were actually not involving areas lined by lymphatics. They were not involving the fissures, the pleura. And the morphology of these nodules is very poorly defined or ground glass, and they're rather diffuse. There is no clustering, it's rather diffuse. So this takes us into that inhalational category and that more diffuse involvement that we call a pure centrolobular pattern. And of the two choices, the reason why subacute hypersensitivity pneumonitis, first and foremost, is probably more correct here, is because in that little brief one-liner we did say a non-smoker. Certainly RB-ILD, that occasionally tends to be a little bit more patchy, would be expected in a smoker, whereas subacute HP would be in a non-smoker, as in this case.
Okay, so here we have the secondary pulmonary lobule, and when we call centrolobular, we're talking about something within the center of that secondary pulmonary lobule. And the core, often these things gravitate or surround the core structure, which again consists of a arterial, a bronchial, lymphatics, and a bronchial artery. Now sometimes you'll see, if you know what the cause or how the nodule or the pattern got there, if we really think it's an airway process, we may use the term rather than centrolobular, but call it bronchocentric or bronchialocentric. If we think that it's more hematogenous, as in the case of maybe METs, then we will call it angiocentric and so forth. So centrolobular nodules can be solid, but more often they're going to be this sort of ground glass. Generally they're going to be bigger, maybe 5 millimeters or larger, fluffier looking. They may be branching, and they may be tree and bud, which are these sort of kind of jacks, or they look like jacks. And again, if you impose or superimpose the secondary lobular structures, you see all these nodules are in the center or cluster to the center of that secondary pulmonary lobule. So let's look at this on the diagram that we've been looking at. And here we see, again, a fluffier, less dense nodule, generally bigger in size, less density, ill-marginated or fluffy, right? You see that none of the perilymphatic structures that we've been talking about are involved by these nodules. The fissures are spared, the septa are spared, the peribronchovascular structures are spared. So there is no perilymphatic or lymphatic structure involvement. There's no clustering, fairly homogeneous within the secondary pulmonary lobule and, for that matter, within the lung itself. So there's no clustering, no lymphatic structure involvement. Brings us into this centrolobular pattern or inhalational pattern, more diffuse things like cigarette smoke causing RB-ILD or antigen exposure to organic agents, most commonly in the form of subacute hypersensitivity pneumonitis. HP can be acute, subacute, chronic, depending on the length of time and exposure. Acute tends to be more ground glass attenuation or even airspace attenuation. As the granulomas form, you might start seeing centrolobular poorly defined nodules. Subacute is much more of the nodular pattern that we see. There may be also air trapping at this point, as you can see here, which are these areas of parenchymal lucency or blacker lung. And then certainly in the chronic phases I've already shown you, you're going to see the fibrosis. Here again we see a more involved case of subacute hypersensitive pneumonitis. Look at these nodules. They're ground glass. They're bigger. They're in the center of the lobules such that you almost see kind of a separation from clusters of nodules because that's the outer part of each of those lobules, right? And with regards to respiratory bronchiolitis, interstitial lung disease, again, this also has a very similar, if not almost identical, centrilobular pattern favoring the upper lobes. There may be also some airway thickening. This is seen exclusively in smokers. And basically, it's a smoker with a symptomatic, who becomes symptomatic with shortness of breath and cough, maybe a mixture of PFTs. And this is what this disease is basically an overproliferation and infiltration of the parenchyma and around the airways with this pigmented macrophages, or the alveolar macrophage. Some people feel, or most people feel, that this is on a spectrum of disease, our respiratory bronchiolitis being the least sort of severe, going all the way to DIP. Here we see again, you can see that there's just a diffuse ground glass pattern. None of the lymphatic surfaces are involved. There's no clustering. And so this is an inhalational process. The two things that should come to mind are subacute hypersensitive pneumonitis and RBILD.
So case 6 is a 63-year-old Japanese female with a 3-month history of chronic cough, weight loss, and subjective fevers. So what is the most likely diagnosis here based on the brief clinical history and the radiographic features? Is this Mycobacterium avium intercellulare or complex? Is it pulmonary TB with associated endobronchial involvement, metastatic bronchogenic cancer, or pulmonary coccidiomycosis? We have to always bring that up. We're in California. Please vote. Okay, there is a little bit of a spread here, and let's just quickly go over this. What we saw here were a number of features. There were macronodules that were cavitating, and they were thick-walled cavities there. And then there were also adjacent micronodules that had a patchy distribution that were clearly centrilobular. They were not involving areas lined by lymphatics, and they had a Y-shaped or tree and bud morphology. That constellation here really makes TB with endobronchial spread more likely. Now, the endobronchial or cellular infiltrates can be a feature of MAC, but with MAC you'd often expect more localized disease, more bronchiectasis. The macronodules here is really what points to this perhaps being TB with endobronchial involvement causing those micronodules that are tree and bud and patchy in distribution.
Okay, so we're kind of moving on to small airways disease, and the small airways are those without cartilage, and these are generally 2 millimeters or less, and they represent bronchioles, or in some cases very small bronchi. And so the bronchioles that we're talking about are the membranous, terminal, and respiratory bronchioles, and this has sort of changed over the years with better CTs, and we can probably resolve these bronchioles even maybe 1 centimeter from the pleural edge. So the direct signs of small airway disease are going to be the things that involve the small airways. And so, again, we talked about ground glass nodules. We see branching nodules. We see what we call tree and bud, or the sort of jack sort of shaped nodules. And we may, as the process becomes more chronic, we may even see bronchiolectasis, or dilation of those very peripheral small airways. And so these are all forms of sort of direct signs of airway involvement. Now, if we go back to our diagram, we see that, again, unlike the centrilobular pattern of nodules, we see that, again, these nodules still are going to be air-spaced or maybe ground glass, or but maybe overall carry slightly more density. They are clustered, but not necessarily on a lymphatic surface, but within the secondary lobule itself. And so here again, we don't have any perilymphatic or lymphatic structure involvement. They're clustered, not very dissimilar to the more ground glass centrilobular pattern that I showed you just before this. So when we see this clustered pattern, centrilobular nodules, we're really focusing on the small airways process. And this is generally going to be a cellular bronchiolitis, of which most commonly is going to be an infection, or panbronchiolitis. So here again we see, notice that we see the clustered nodules here isolated to the center of the secondary pulmonary lobule. You don't see any sort of nodules on the lymphatic surfaces or structures, and you see that it's kind of patchy. It's not all the way throughout the lung. It's sort of isolated to this area, that area, other areas. And what's maybe helpful if you see it is that maybe the airways that are subtending that area are maybe thickened as well, indicating or indicative of an airway process. Here we see just a little bit more involvement. We see, again, these sort of little denser nodules. Some are kind of ground glass, little fluffy. Some have a tree and bud look to it. We see that, again, the lung is not homogeneously sort of involved with these nodules, and none of the lymphatic structures are. We also see more centrally that the airways are quite thick. Again, suggestive that this may be an airway process, which indeed it is. And we also see a little hyperinflation, which may indicate air trapping. So panbronchiolitis is seen in Asians, mostly Japanese. It's a diffuse pattern or cellular bronchiolitis. They can get colonized with Pseudomonas, and it's accompanied by pancytositis. With HRCT, we see small centrilobular nodules in a tree and bud fashion often. And again, as the disease progresses, we see more large airway involvement. In the later phases, we may see cysts, bullae, and air trapping. Here we see 2 cases of panbronchiolitis. Again, you see, first and foremost, you see dilated airways with thickening, and then you see small clustered nodules, tree and bud, again, within the lung or in the center or central portions of the secondary pulmonary lobules, but none on the lymphatic surfaces. And again, it's a patchy disease, not like an inhalational process where it's much more homogeneous. So there are some indirect signs of small airways disease, and you may come across the term mosaic attenuation. And mosaic attenuation is when you see hyperlucent and hypolucent lung or gray lung sort of juxtaposed to against one another, and they're in a geometric fashion corresponding to either isolated or clusters of secondary pulmonary lobules. So here we see gray lung and black lung simply, and again, it's a very geographic pattern, and you can kind of imagine that these areas correspond to clusters of those secondary pulmonary lobules. Now, when we see this pattern on inspiratory CT, we ascribe the term mosaic attenuation. Now, the other thing that you want to take note is that the dark areas often are devoid of vasculature or small, or they're attenuated or smaller in caliber, and that's because these areas are generally going to be perhaps air trapping or obliterated, and they're shunting blood to the more gray areas of lung. Now, on expiration, when this pattern becomes much more pronounced, meaning that the gray and the black lung become much more obvious, and you can see a more obvious gradient, on expiration, that's what we call air trapping, okay? So if you see mosaic attenuation, these are the 3 things that you think of. It's an obliterative small airways process, obliterative vascular process, or maybe you just have an infiltrative process in the lung that fortuitously is giving you this pattern, okay? And I'll show you, again, you want to analyze it a little further, and if those areas of very black lung have very small or sparse vessels, then you can kind of take this process out for the most part, and really it comes down to one of these two things. And the way that you differentiate between obstructive small airways versus an obliterative vascular process is, you guessed it, to do the expiratory imaging. So what does normal expiration look like? And here we have a patient on inspiration and expiration, and so as the patient expires, the lung becomes grayer. And it becomes grayer with a dependent gradient, meaning that as you go to the more dependent area, it becomes grayer because of blood flow. And you may have small areas of air trapping, but notice that, again, it's not really very profound, certainly not any more than about 25% of a lobe or even on that one cut, and certainly not a lot of air trapping in the non-dependent lung. So on top you have a normal inspiration and expiration, and down below you have inspiration and expiration in a different patient. Now, first of all, you notice on the image on the lower left, you can see that, wow, there's this crazy mosaic attenuation, right? Now, when we look at the gray lung and the black lung and compare, notice that the black part of the lung has almost no vasculature, right? When you see this, this is really called mosaic hypoperfusion, and what you're thinking here is not of an infiltrative process, but first and foremost, obliterative small airways disease or a obliterative vascular process. Now notice on the expiration, right, it almost looks the same, if not the black areas look even more pronounced. The gradient between the black and the gray lung is preserved and even accentuated. And so in this case, this is due to air trapping. Now here's another case. Here we've got on top, we see again, mosaic lung attenuation on inspiration. But notice how the black lung almost has no vasculature, or what the vessels that we see are very attenuated. And so we're really focusing on these two processes. When you do the expiration, that gradient becomes really pronounced. So rather than thinking of vascular causes, you steer yourself to a small airways or air trapping process. Now look at this case. Here we have a patient with large sort of central thromboemboli, and you can see that again there's mosaic oligemia or mosaic attenuation with gray and black lung. The dark lung, the vessels are again attenuated and smaller. But now let's do the expiration. So on top we have the patient with thromboembolic disease. We have the inspiration and expiration. And notice that these black areas become grayer, right? Because they're not holding on to air or not air trapping. And so the hypoperfused lung, because the clot won't let blood perfuse that lung, becomes grayer and can expel air and becomes grayer. And the more hyperperfused lung also becomes grayer, and so that difference between those two areas, or that gradient, does not become more accentuated, okay? Unlike the case we have below. So let's think about it in a sort of cartoon sense. So we'll take the case of air trapping. So here we've got, again, black lung, gray lung, right? So this is on inspiration, and then what do? We have them expire. What happens? Well, the areas that trap air stay black or become blacker, and the areas that are gray, because they're not trapping air and can force the air out, become grayer, so that gradient between the two becomes accentuated. Now let's look at this case of no air trapping as in the case of chronic, in the PE case. So again, we have a little bit of a gradient to begin with, because we've got black lung because it can't get perfused because the PE is in the way or the emboli are in the way. We have gray lung that is hyperperfused or shunted too. Now on expiration, well, there's no obstruction here from the airway, so both can expire air. The hyperperfused area becomes grayer. The underperfused area becomes grayer too. The gradient really doesn't become accentuated. All right.
All right. Case 7 is a 29-year-old African-American male with a 2-year history of progressive dyspnea and cough. Moving on to a different pattern here. Okay. What is the most likely diagnosis? Is this lymphangioliomyomatosis, or LAM, or is this pneumocystis jirovecii, Langerhans cell histiocytosis or granulomatosis, or lymphocytic interstitial pneumonitis? Please vote. All right, so slight majority got this right. I think the key here, this is a cystic lung disease. They're clear, defined cysts. They're walls that are appreciable. Moreover, the intervening lung that separates these cysts was not normal. The unaffected lung actually had slight nodularity and irregularity, and that's really one thing that, as Rob will talk about, will help distinguish a disease like Langerhans cell histiocytosis, where the intervening lung is often nodular because the disease often starts off with nodules that cavitate and then form cysts, versus LAM, where the intervening lung is almost pristine. So really, if you think about those two as being the primary processes in a differential here, you can clearly see that the unaffected lung here, I mean, this is a very advanced case. This patient actually ended up going for heart-lung transplantation because he actually had group 5 pulmonary hypertension from the Langerhans. But nonetheless, the intervening lung was very abnormal here. There was really no normal lung.
Okay, so now we've moved on to the category of cysts, and as Nader mentioned, the two foremost diseases are Langerhans cell lymphangiomyomatosis, but there are other cystic diseases that we'll talk about. So cysts are round parenchymal molucencies, usually thin wall, typically containing air, but sometimes they can contain fluid or even soft tissue. Cavities develop within sort of nodules or areas of consolidation. So when you're dealing with predominantly a cystic pattern, then again, there are some questions you like to sort of ask yourself. First of all, is there a perceptible wall to these cysts? Yes or no? And what is the relationship of this cyst to the central lobular core structure that we talked about? Does it look like the core structures, or like the arterial, the bronchial, are going through the center of the cyst? Or does it look like they're sort of embedded and sort of plastered against the wall of the cyst? As Nader mentioned, you also want to see or look for nodules, yes or no? And is there an upper, lower lung predominance of these cysts, if anything? So these are kind of the questions that you like to ask. And when you're dealing with cystic lung disease, these are probably the most probably the first four most common. Central lobular emphysema by far, Langerhans cell lymphangiomyomatosis, lymphocytic interstitial pneumonia, and the Burt-Hogg-Dubé. I know we kind of always talk about it, but we don't see it that often. So let's look at the case of central lobular emphysema. So first of all, here we see kind of in a mid cut here, we see these little holes in the lung throughout. And the first question you ask yourself is there a perceptible wall? I think you can pretty much see that although you see the cysts, you don't really see a wall around them. That's very obvious. And when you ask your next question, what's the relationship with the core? And again, you look at some of these, and it looks like the central lobular core structures are going right through the center. And I have some better images of this, but look at this. Looks like that structure is going right through the middle of the cyst, and that's because these cysts are clustering around it. There's obviously no nodules, and it's favoring the upper lung. We're talking about central lobular emphysema. So this is what I meant about this core structure going right through what it looks to be going through the center of that cyst. And again, that's because the lung destruction is occurring all around the core structure, affecting the respiratory bronchioles in the center of the secondary pulmonary lobule. So let's look at, for instance, compare and contrast with LAM. Okay, so here again we see cysts, right? Dark little air-containing foci. But the difference when you compare that to emphysema is that all of these cysts have a little bit of a wall, right? 1 to 2 millimeters. And if you look closely, the core structure looks like most of these cysts don't have anything seeming like they're running through the middle of it. And if you look at the core structures, they look like they're embedded or plastered within the wall itself. certainly no nodules, and again, and I don't show you all the images, but I guarantee that this is a more diffuse process. This is lymphangioliomyomatosis. So as you know, this occurs in women of childbearing age. In 30% of these cases, you can have renal angiomyolipomas. And what this represents is an abnormal proliferation of smooth muscle affecting the peribronchovascular structures. If it's affecting the airway, it causes obstruction and cyst formation. If it's affecting the lymphatics, you get chylous pleural effusions in almost in as much as 3/4 of those patients. Again, here you can see the gross specimen that kind of goes along with the CT. You can see that the cysts are going to be numerous, they're thin-walled, and in between those cysts, unlike Langerhans cell, you have fairly normal intervening lung. You may see nodules, but that's so exceedingly rare that you almost never see that. And because it's a cystic lung disease, in 30 to 40% of these cases, the presenting sign may be a pneumothorax. And here we see just a number of different patients with LAM of varying severity. And you can see that, again, look at that. The cyst and the core structure looks like it's embedded in the wall. You don't see any of these cysts have something going through the center of them, and they all have a thin perceptible wall, normal intervening lung, no really zonal predilection for these cysts, but fairly diffuse. And these are cases of LAM. So tuberous sclerosis can also give you cystic pulmonary disease that's identical to LAM, with the exception of the chylous pleural effusions. The triad, as you all know, associations or other sort of ectodermal issues, angiomyolipomas, cardiac rhabdomyomas, retinal phacomas, osteomas, and subungual fibromas. And again, when you look at the lung disease pattern, it looks identical to LAM. All right, so moving on to the next entity, we're going to talk about a little bit about Langerhans cell. And again, you ask your question, you see the cysts, so you ask your question, do I see walls on these cysts? And I think everybody can certainly see walls on these cysts, right? And then you look at the core structure and the relationship to the cysts. And again, you don't see anything really going through the heart of the cyst or the center of the cyst, right? It looks like the core structures are all, again, plastered or embedded in the wall of the cyst. And here, I don't show you too many nodules, but this entity certainly has a much more predominance of nodules than certainly LAM. So this goes through stages, starts with a bronchocentric or centrilobular nodule. That nodule grows and cavitates, then becoming what we call these thin-walled bizarre cysts. These cysts may coalesce, and you get areas of pseudoemphysema and fibrobullous disorganization and destruction and intervening fibrosis. In the early stages of disease, you won't have fibrosis, but later on there is. There generally is a sparing of the extreme lung bases as well as the tips of the right middle lobe and lingula. And again, here we can see just how many nodules. These are all small little nodules, and you can start seeing down on below some of these nodules starting to cavitate and become cysts. And as the disease progresses, you can see, again, more fibrobullous changes, more extensive cysts. Look at the intervening lung is just highly abnormal, and then you get sort of this fibrobullous disorganization in the most severe cases. Okay, moving on to cystic LIP. You see, again, cysts, maybe not so numerous, with a perceptible wall. With regards to the association with the core structure, you may see some cysts with things going through the center, as I'll show you, or embedded in the wall. There may or may not be any nodules, and localization is usually just kind of scattered cysts as opposed to the more diffuse proliferation of cysts as we've seen. So at least Jacot looked at the radiographic features of LIP, found that ground glass attenuation was the most common and that was tied with centrilobular nodules in almost all of their cases. They sometimes see perilymphatic nodules in a high number of cases because this is kind of a lymphocytic or lymphocyte process. And that's what you see, these small little ground glass centrilobular nodules. And here again you see more lymphatic base nodules in another case, and maybe some septal thickening, indicating a lymphatic process. And here we see the kind of cyst that we're talking about in about almost 70% of cases. Again, you see a wall that's perceptible. And in some of these cases, you can see that kind of the structures are against the wall. And here, you can see the core structure kind of in the center with a number of cysts sort of clustering around it. And so with LIP cysts, or the cystic variant, these cysts generally tend to be 3 centimeters or less. Sometimes they're this multiloculated or lobulated or multiseptated cysts. And generally, you can count them. They're not so many and numerous as in the other cases of cystic lung disease that I've showed you. And collectively, they may only have 10% or less lung involvement of these cysts.
Case 8 is a 53-year-old female with a 1-month history of persistent non-productive cough, dyspnea with exertion, and some weight loss. So what is the most likely diagnosis here? Is this MAI, acute interstitial pneumonia, metastatic bronchogenic carcinoma, or organizing pneumonia? Please vote. Great. So we've moved on here to the last category, which is airspace disease. And as we see here, we saw airspace disease that was mostly bronchocentric as well as peripheral. We had areas of patchy airspace disease along with bronchial wall thickening. There was also some areas that you could vaguely say there was maybe a reverse halo sign or atoll sign that was, it's only found in about 20% or so of patients with organizing pneumonia. But clearly, this is an airspace disease, and as Rob will talk about here, clinical history is really important when you're dealing with airspace disease because the differential is often very broad.
Okay, so again, these are some of the other entities that we see that's predominantly characterized by airspace disease, acute and chronic eosinophilic pneumonia, acute interstitial pneumonia, and diffuse alveolar damage, and pulmonary alveolar proteinosis. So with organizing pneumonia, the pathology is patchy organizing pneumonia with intraluminal fibrosis involving the bronchioles and air spaces. And there's often these sort of endoluminal granulation tissue polyps or mesome bodies. And there may be some interstitial infiltrates or inflammation associated with this as well. This sort of honeycombing architectural distortion associated with fibrosis is not very common with organizing pneumonia. The CT features are predominantly consolidation with a lower lung predominance. Sometimes there may be ground glass opacities. And the distribution, again, within the lobe itself is going to be subpleural and sort of peribronchovascular. So it's a combination. Other less common features, you might see bronchial dilation. You may see a non-septal linear or reticular pattern. There may be more obvious nodules and masses in 15% of cases. And overall, as you know, fibrosis is fairly uncommon, and certainly honeycombing is not a feature of this disease. So here we see some of the common things. Here we see a consolidation, airspace attenuation. We see that after treatment, there's a little residual ground glass that ultimately probably will resolve. And here we see more extensive ground glass in a different patient. We see the bronchial dilation in the areas of heavy involvement and even a little peribronchial thickening, which is not unusual. In this bottom case, we see more reticular pattern. Yes, there's ground glass, but you see a lot of lines here, and this is what we call kind of the non-septal reticular opacities. In this pattern here, you can see that the ground glass or the sort of thickening is confined to the edges of the secondary pulmonary lobule. And this is what we refer to as a perilobular pattern. And this is seen, at least in one article, 57% of the cases of organizing pneumonia here. And again, if you think back to that diagram I showed you with all the secondary pulmonary lobules, you can see almost make them all out here. The only difference of the septa being, rather than the septa being thick, it's more kind of consolidation outlining the edges there. There may be, as I said, more obvious nodules and sort of mass-like consolidations in 15% of patients. Again, it's a subpleural peribronchovascular kind of combination. And rarely and uncommonly, you may get to this point where there is actually fibrosis caused by this, this entity. This is what Notter was referring to as the reverse halo sign that you see in almost 20% of patients. So what you have is basically an area of dense consolidation, and within the center of that consolidation, you see ground glass attenuation. And so this is supposedly like an atoll, which is an isle in the ocean, right? And here, just a different case of radiation-induced organizing pneumonia. Again, you see that very dense leading edge, and within the inside of that leading edge, you see ground glass attenuation. Moving on to a little DIP. Again, this is characterized by ground glass opacity that you see here. It often favors the lower lobe, subpleural lung, can be patchy or diffuse, as I've shown you. In 10% of cases, you may see small little cysts here, and that's due to airflow obstruction. And they also may just represent fortuitous or intercurrent emphysema as well. And again, with this entity, you really don't see too often honeycombing. Now, with any airspace disease, you want to try to differentiate the sort of the features and tease them out. Again, looking at the distribution, whether or not there's architectural distortion accompanying lymphadenopathy. If you have it, is this an acute or chronic process, whether it's clinically or radiographically? Has there been a history of treatment response? What's the patient's occupation, immune status? Are they on any new medications or drugs that are associated with lung disease? And ultimately, you may just have to get biopsy results. Here are just some other airspace entities. Here we see a peripheral lung involvement favoring the upper lobes. This is a chronic eosinophilic pneumonia. Here we see, again, more of a kind of ground glass in the right lung, more dense airspace consolidation in the other lung. And this is a case of the mnemonic form of bronchoalveolar cell carcinoma. Here we see these cases are what we call crazy paving, and you may run into this term. And what we mean by crazy paving is that you see ground glass attenuation, and within that area of ground glass, you see this linear pattern of interlobular septal thickening, as well as intralobular septal thickening, resembling sort of pave. Okay, so here again, you see that everywhere you see ground glass, you see the inter and intralobular septa being thick. Crazy paving has been associated with primary alveolar proteinosis, but can be seen in a number of things, and it certainly is not pathognomonic for just PAP, but certainly you can see it in pneumocystis infection, mucinous BAC or adenocarcinoma in situ, that's the mnemonic form, even hydrostatic pulmonary edema, pulmonary hemorrhage, and lipoid pneumonia. So these are kind of the categories that we talked about: reticulations, nodules, cysts, and airspace disease, some of the common entities. Again, when you're dealing with a nodular pattern, and you're dealing with multiple or numerous subcentimeter nodules, first question you want to ask yourself is, are they involving the lymphatic structures? If that's the case, then you're really dealing with a lymphohematogenous process, whether it's perilymphatic or random. If not, you may be dealing with a more inhalational process. Then the next question you want to ask yourself is there any clustering of these nodules? If they are involving lymphatic structures and clustering, you're really talking about perilymphatic processes, primarily sarcoidosis. And if you're dealing with a more inhalational category, then you're dealing with small airways disease. And remember the morphology of the nodules as well. So here, I just put side by side all of the nodular diseases. So again, these are the patterns across the top, the pleural or lymphatic structures, perilymphatic, random, yes, they involve those. Central lobular, small airways, no. The clustering, as we talked about before, perilymphatic and small airways, not so with the random and central lobular. And the morphology of the nodules, perilymphatic, solid, sharp, random, solid, sharp, central lobular, as we get to more inhalational or airway processes, these nodules become more ill-defined, right? Or even branching in tree and bud. The cystic lung diseases that we talked about, emphysema, LAMS, LCH, and LIP, again, you want to ask yourself, is there a perceptible wall? And again, emphysema, no, but the other three entities, yes, as you've seen. What's the relationship with the central lobular core? Is if it looks like it's going right through the center of some of these cysts, that means that the cysts are surrounding that core fairly evenly, and that's what you see with central lobular emphysema. If it's eccentric, you're probably dealing with one of these two entities, and if you have kind of both and these nodules or these cysts are much more finite, you may be dealing with, as is shown here, LIP. Presence of nodules, again, the only two diseases that have nodules, as I've shown you, are LCH and LIP. And localization, emphysema, as you know, is in the upper lung, LAM sort of diffuse with no zonal predilection, LCH sparing the bases, right middle lobe and lingula tips, and LIP, usually, again, a finite number of cysts, representing less than 10% of lung involvement, and they're kind of randomly scattered. Aerospace disease, again, I think history is first and foremost most important. And so that brings us to kind of, we'll ride out with a bunch of quiz questions.
All right, so just no history here. You guys are experts. What is the most likely diagnosis here? Is this UIP, NSIP, metastatic CA, or organizing pneumonia? Outstanding. Clearly, most everyone got it right. The degree of honeycombing that's present here, you would not expect to see honeycomb changes with NSIP. The disease would actually have a rim of subpleural sparing that we don't see here. The disease here goes all the way out to the pleural surfaces. It's very reticular, very coarse, very minimal ground glass. So UIP, as most of you got, is the right answer.
All right, the next case. Go ahead and vote.
Great. So here we had back to a micronodular pattern. Too numerous nodules, too numerous to count. Clearly, the nodules look like they are involving the perilymphatic structures. Moreover, they are clustering along those areas, as Rob talked about. So if you look along the fissures, the pleural surfaces, and the axial interstitium, it looks like it's being riddled by micronodules. So it is a very perilymphatic disease. Moreover, these nodules are clustering in areas lined by lymphatics. So the best answer here would be sarcoidosis.
All right, next case. So on your left is inspiration, on your right, expiration. Same patient.
Fantastic. So there is quite a bit of ground glass, but as Rob talked about earlier, there is this mosaic attenuation that gets exemplified during exploratory scans. So you have these areas of lobular air trapping that is really pathognomonic of with hypersensitivity pneumonitis, in this case, case of subacute HP.
So let me just give you, so these are, the image on your far left is one patient, And the image in the middle and the magnified image are from the same patient, but a different patient. Please vote. Go ahead and vote.
Please vote.
Oh. Yeah.
There you go. All right, a little bit of work to do here. So what we're seeing here are cysts. They're lucencies, but without clearly defined walls. If you really try to draw an outline around these lucencies, it's very difficult. You don't see that thin 1 to 2 millimeter wall. Moreover, if you look carefully in some of the magnified views, you see that the central lobular core, the cyst surrounds that central lobular core, and that is pathognomonic for smoking-related central lobular emphysema. Langerhans cell histiocytosis or granulomatosis, you would actually have a perceptible wall and the central lobular core is eccentric or pushed against the wall, and that is not the case here. So this is central lobular emphysema. How about this?
Go ahead and vote.
All right, so a majority got this right. This is clearly Langerhans. What you're seeing here are clearly defined cysts with perceptible walls. We're seeing two axial cuts, mostly mid and upper lung zones. And what we see is that the intervening lung is slightly abnormal. There are some slight nodularity to the intervening lung outside of the cyst. Moreover, the central lobular core structures look like they're eccentric or pushed up against the wall here. So this would be most consistent with Langerhans cell histiocytosis.
All right, the next case, please go ahead and vote. All from the same patient.
All right, great. 2/3 got this right. What we're seeing here are somewhat ill-defined nodular opacities that do not have a predilection for the perilymphatic structures. Moreover, they're clustering, and in some areas they do, especially on the sagittal and coronal views, have a tree and bud morphology. This is consistent with a cellular bronchiolitis and infectious bronchiolitis, and clearly the differential is pretty broad, would include things such as aspiration, Mycobacterium avium infection, TB with endobronchial spread, particularly if you have a foci like a large cavity, as well as atypical fungal infections such as cocci. So this is an infectious bronchiolitis. How about this case?
Think about the wall of the cyst.
Great. So here, in some ways, this is not too dissimilar from that central lobular emphysema Rob pointed out, with two distinctions. Number one, there is a perceptible wall. You can actually draw a nice outline, whereas with the central lobular emphysema, it was just kind of poorly defined lucencies. Secondly, the central lobular core here, unlike central lobular emphysema, is not in the center. The cyst is not surrounded, but rather it's eccentric or pushed up against the wall. And then what kind of differentiates this from Langerhans is the intervening lung here is pretty pristine. There is no involvement or abnormality of the intervening lung not involved with cysts.
And then the last case is this. So go ahead and vote.
Great way to end the day.
Right.
There you go, 97%. So this is clearly organizing pneumonia. You see areas, airspace opacities that are somewhat patchy, involving the peribronchial vasculature as well as periphery with associated bronchial wall thickening.
All right. Thank you very much. Give yourselves a hand. I think you're the highest correct answer percentage of all the audiences Nader and I have the privilege to teach. Have a good evening.
Now, I'm going to begin by briefly reviewing anatomy of the secondary pulmonary lobule. Some of the abnormalities we identify because of abnormalities of the pulmonary lobule. And this is a radiograph of a lung slice of two adjacent pulmonary lobules. And what we can see are the lobules being marginated by connective tissue interlobular septa. These contain pulmonary vein and lymphatic branches. In the center of the pulmonary lobule is a branching centrilobular artery, and it is large enough to see on high-resolution CT, and adjacent to it is the centrilobular bronchiole, which is too thin-walled to be seen in normal subjects. Pulmonary lobules range from 1 to 2.5 centimeters in diameter and characteristically have this polygonal shape. Now, this is the high-resolution CT finding of interlobular septal thickening. What we identify is a reticular pattern, and we can identify this reticular pattern as due to interlobular septal thickening because the lines we see outline what we can recognize as pulmonary lobules because of their characteristic size and shape. And one of the ways we recognize these as lobules is the centrilobular artery, which is usually visible as a dot or branching structure in the center of what you think is a pulmonary lobule. And then within the interlobular septa themselves, we often can make out septal veins, and these may be dot-like or occasionally branching. Interlobular septal thickening, in this case, it is due to interstitial pulmonary edema, certainly a common cause of that abnormality. Well, what do you do if you see interlobular septal thickening on high-res CT? Well, first of all, you ignore it unless it is the predominant abnormality, because a little bit of septal thickening will be very common in almost any diffuse lung disease you see, and unless it predominates, it's of no value in differential diagnosis. Interstitial pulmonary edema is a common cause. Lymphangitic spread of neoplasm, a common cause. There are some other infiltrative diseases that result in interlobular septal thickening, but they're relatively rare, and I'm not really going to go into those in detail. An example would be amyloidosis, something of that sort. And patients who have diffuse lung fibrosis can show interlobular septal thickening, but it is characteristically irregular in contour, and usually we have other findings of fibrosis that we rely on to make the diagnosis. Well, this is simply a chest film in a patient who has pulmonary edema, and you can see curly B lines. Curly B lines are the plain radiographic appearance or plain radiographic correlate of interlobular septal thickening as we see it on high-res CT. Now, here is another patient. A high-res CT shows smooth thickening of interlobular septa. You can see a number of thickened septa within the right lung. The left lung looks relatively normal, so this is at least asymmetrical and probably unilateral in distribution. That would be quite unusual for interstitial pulmonary edema. Here, a lower scan in the same patient. Again, we see thickening of interlobular septa within the right lung and not on the left. Also, a right pleural effusion is evident posteriorly. This is the other common cause of interlobular septal thickening we see, lymphangitic spread of carcinoma. This is a patient who has lung cancer, and the septa are thickened because of lymphatic infiltration. This is a lung slice in a different patient who has lymphangitic spread of carcinoma, but you can see thickening of the interlobular septa by tumor cells, and this results in this characteristic appearance of asymmetrical or unilateral septal thickening. The next finding I'm going to talk about, another reticular abnormality, is honeycombing, and I think you can recognize this as honeycombing. It's a very nice example. And this is a patient who has usual interstitial pneumonia, UIP, due to the lung disease idiopathic pulmonary fibrosis, IPF, and we'll talk further about both of those. Now, I'm going to digress for a moment and talk about the idiopathic interstitial pneumonias. They're an important group of lung diseases that you need to know about. These represent reactions to lung injury. The interstitial pneumonias are pathological responses of lung to injury. They are not diseases per se, but they are ways in which the lung can react when it is injured. They occur in several patterns with variable inflammation and fibrosis. They have a variable response to treatment, and they may be idiopathic or may be associated with collagen disease, may be associated with drug treatment, inhalation. There are a number of other causes as well, but keep in mind that these idiopathic interstitial pneumonias may be idiopathic or they may not. They may be associated with some other disease. Now, these are the interstitial pneumonias or idiopathic interstitial pneumonias as currently accepted. These are UIP, usual interstitial pneumonia, NSIP, nonspecific interstitial pneumonia, OP or organizing pneumonia, DIP, desquamative interstitial pneumonia, quite similar to another entity termed respiratory bronchiolitis interstitial lung disease, and then LIP, lymphoid interstitial pneumonia, and AIP, acute interstitial pneumonia. Now, the first four of these are common, and we see these first four on a regular basis in our clinical practice. The last two are not so common. LIP, often associated with collagen disease, and I will show you an example of that in my last slide. And AIP, acute interstitial pneumonia, is basically idiopathic ARDS. If someone is in the ICU with ARDS and they don't know why, it may be AIP. And generally speaking, AIP is something that's evaluated with plain films in the ICU on a daily basis and not with high-resolution CT. Okay, now the American Thoracic Society, ATS, and European Respiratory Society got together and classified these interstitial pneumonias in 2001 and agreed on some terminology because we tended to use different terms in the United States than were used in England and Europe, and this is what they agreed upon. First of all, they made a distinction between the histologic pattern of the interstitial pneumonia. Remember, an interstitial pneumonia is not a disease, it's a histology. And then the idiopathic clinical syndrome associated with that interstitial pneumonia. And the histologic pattern of UIP, when it is idiopathic, is called IPF, or idiopathic pulmonary fibrosis. The histologic pattern nonspecific interstitial pneumonia, when it is idiopathic, is called idiopathic NSIP. The histologic pattern organizing pneumonia, when idiopathic, is called COP, or cryptogenic organizing pneumonia, although sometimes in the US we refer to it as idiopathic BOOP. The histologic pattern desquamative, or DIP, desquamative interstitial pneumonia, when idiopathic, is just called DIP. Now, what this classification did not emphasize, but I'm going to emphasize now, is that each of these histologic patterns may be associated with a given disease or various types of diseases. UIP may be a result of collagen diseases, drugs. Asbestosis is basically a UIP pattern. NSIP, very commonly associated with collagen diseases, may be a drug reaction, other causes as well. Organizing pneumonia has lots of causes. It may be post-infectious, collagen diseases, drug reactions, inhalation of fumes, may be seen with hypersensitivity pneumonitis. And in the vast majority of patients, DIP is associated with cigarette smoking. So these may be idiopathic or they may be associated with disease. Okay, we'll start by talking about usual interstitial pneumonia. This is quite common in clinical practice. The histology is heterogeneous lung fibrosis. What we see on high-res CT is reticulation, a finding called traction bronchiectasis, and honeycombing is seen in about 70% of cases. And this combination of findings is typical of this pattern. Ground glass opacity is very uncommon as an isolated finding. That means in areas that don't show findings of fibrosis. The abnormalities have a basal, posterior, and lower lobe predominance. That's very important in diagnosis. Idiopathic UIP is IPF. It has a very poor prognosis. Also, the differential diagnosis, as I have mentioned, collagen diseases, asbestosis, drug fibrosis, end-stage hypersensitivity pneumonitis may be associated with UIP on histology. Now, this is a lung slice, a sagittal lung slice in a patient who has UIP associated with idiopathic pulmonary fibrosis. And what you can see on this path specimen is honeycombing with a posterior lower lobe predominance. This is a lung slice in a patient who has honeycombing, and just to emphasize what this means, honeycombing indicates the presence of cystic lucencies. These are air-containing, these are empty holes, so they should look absolutely black on high-res CT. 3 to 10 millimeters in diameter most of the time, but may be larger or smaller. They must be seen, and I emphasize that, must be seen in a subpleural location, or you can't be sure they are honeycombing. Unless you see these subpleural, they may be something else. Early on, you will only see a few isolated cysts. Later on, cysts occur in several layers, and cysts share walls when numerous. And these have a tendency to occur in clusters, and they're not simply black holes, they have a recognizable wall surrounding them, which is fibrotic. This is the plain film appearance of a patient who has UIP-IPF. What we tend to see is a decrease in lung volumes. The lungs look small, and at the lung bases, you see an increase in reticular opacities, although usually you can't figure out exactly what it is you're looking at. This is the lateral view, and again, you can see reticulation that predominates at the bases and in the posterior costophrenic angle. Another example of honeycombing on high-res CT, again, we're seeing black holes. These look to be a little less than a centimeter in diameter. They're occurring in clusters and layers. They have thick, recognizable walls. This is a very good, definite example of honeycombing in a patient with UIP-IPF. Another example with a posterior lower lobe predominance of reticulation, traction, bronchiectasis, and a little bit of honeycombing, UIP-IPF. Differential diagnosis of honeycombing is basically the differential diagnosis of UIP. The histologic pattern usually associated with honeycombing that we see on high-res is UIP. Differential is IPF, idiopathic pulmonary fibrosis, collagen diseases, particularly rheumatoid and scleroderma, drug-related fibrosis, methotrexate or something like that, chronic hypersensitivity pneumonitis, asbestosis, uncommon in clinical practice these days. End-stage sarcoid can be associated with honeycombing as well in a few patients. And I should say that fibrotic, nonspecific interstitial pneumonia, NSIP, the different interstitial pneumonia, may also be associated with a little bit of honeycombing, but it typically has a different appearance. Now, I mentioned that reticulation and traction bronchiectasis is a finding we see in UIP. It's a finding that indicates the presence of fibrosis. This is what I mean by traction bronchiectasis. These bronchi are very irregularly dilated. They appear corkscrewed because of fibrous tissue that's pulling on their walls and making them dilate. This is not airways disease. It is fibrosis causing the bronchi to dilate, and they have this very, very characteristic irregular appearance and will be associated with reticulation, as we see here. And this is a lung slice in a patient who has UIP-IPF. And we can see a very nice example of traction bronchiectasis in the posterior lung, and also this patient has honeycombing, which you can see in the subpleural region. So this finding of reticulation and traction bronchiectasis also associated with this disease and with lung fibrosis in general. Now let's talk about IPF. It's a very common disease, and it's the most common cause of UIP. If you have this disease, if you have IPF, then your histology must be UIP. Patients are usually older than 50 at diagnosis. They have progressive dyspnea. Mean survival only about 3 years, 5-year survival 25 to 40%. Having IPF is basically like having lung cancer. It's a disease that is very difficult to treat and not very responsive. Now recently, the American Thoracic Society, European Respiratory Society, Japanese Respiratory Society, and Latin American Thoracic Association got together and they decided on criteria for making a diagnosis of IPF. And this is very important because this is a common disease. And these are the criteria that they came up with, and this was just published this last year. Number 1, exclusion of known causes of ILD. That means exposures, connective tissue diseases, drug toxicity, things of that sort. So basically, this first criteria means that the disease is idiopathic. Number 2, a UIP pattern seen on high-resolution CT. That is all you need to make a diagnosis of IPF with this current classification. It's idiopathic and high-res CT looks like UIP. The diagnosis is IPF. Lung biopsy usually not performed in that situation. If a lung biopsy is performed, and as I said, it's not usually done, then various combinations of high-res CT and histologic patterns are used to reach a final diagnosis, and I'm not going to get into that. What I want to emphasize is idiopathic disease, UIP on high-res CT, the diagnosis is IPF. Now, this is what they mean by a UIP pattern on high-res CT. UIP pattern, a subpleural basal predominance of abnormalities. Okay, we've seen that. Reticular abnormalities, we've seen that. Honeycombing, and then no inconsistent features, and I'll tell you what those are in a second. If those 4 criteria are met, then it's definite IPF, or definite UIP pattern. Possible UIP pattern is exactly the same thing, but without honeycombing. Okay, so honeycombing necessary to make a definite diagnosis of a UIP pattern. Now here's an example of a UIP pattern on high-res CT. There's reticulation in the upper lobes and in the mid-lung zones, but the disease predominates at the lung bases in the posterior subpleural lung. There's reticulation. We can see little irregular reticular opacities here and there, and then we see honeycombing. There are no atypical features, so this is a UIP pattern. If this person has no known associated diseases, this is IPF, period. Now here is a patient with a basal posterior subpleural predominance of reticulation, but no honeycombing. This would be diagnosed as possible UIP using those same criteria. And usually a person like this would have a lung biopsy for final diagnosis. This was early UIP IPF. Now, what are the inconsistent findings? What are the findings that tend to rule someone out? Well, these are findings that tend to go with some other disease. An upper mid-lung or peribronchovascular predominance. That's not what you see with UIP. Extensive ground glass opacity. That's something like hypersensitivity pneumonitis. Profuse nodules, sarcoid or something. Discrete cysts, well, that'll be histiocytosis or LAM or something of that sort. Mosaic perfusion air trapping, that's some sort of airways disease or hypersensitivity pneumonitis. And then consolidation, which is a BOOP finding or organizing pneumonia finding. So these inconsistent features are things that are typically seen with some other disease. Well, here are a couple examples. This is a patient who has great honeycombing. It's subpleural predominant. There's a lot in the lung bases. So this is a UIP pattern, but this patient has rheumatoid arthritis. So this cannot be IPF because he has an associated disease, and we would call this rheumatoid lung disease. Here is a patient who shows a great example of honeycombing in the lung bases, so that looks like a UIP pattern, but also recognize that he has calcified pleural plaques and he is asbestos exposed. So because he has this exposure, this cannot be IPF, but it is a UIP pattern, and we would call it asbestosis. Okay, nonspecific interstitial pneumonia. This is less common than UIP, and this is a specific entity despite its name. You may have heard at AFIP that NSIP does not exist. That is wrong. NSIP is a real disease. It is a specific pattern despite its name. The histology is homogeneous inflammation or fibrosis, unlike UIP, which is heterogeneous. It occurs in 2 forms, cellular and fibrotic. It's common, very common in patients with collagen vascular disease. Also occurs with drug reactions or may be idiopathic and has a good response to treatment with 5-year survival, 80 to 90%. What we tend to see on high-res CT is ground glass opacity and reticular opacities in some sort of combination, but ground glass is often a predominant feature. If you see ground glass opacity alone in patients with this disease, it is the cellular form. If you see ground glass opacity plus reticulation, it's either cellular or fibrotic, you can't be sure. If you see traction bronchiectasis in association with reticulation, since that's a finding that tends to go with fibrosis, fibrotic NSIP is likely. And if you see a little bit of honeycombing, then it's fibrotic NSIP. And I should mention that in distinction or in contradistinction to UIP, honeycombing is quite uncommon in fibrotic NSIP, and when present is quite minimal in extent. So you don't quite see the same appearance you do in UIP. It also has a lower lobe posterior and peripheral predominance, but it has a specific finding that is extraordinarily helpful in making this diagnosis, and that is sparing of the immediate subpleural lung, which is present in 20 to 60% of cases. Now here an example, a 43-year-old woman with dyspnea for 3 months. Prone scans show ground glass opacity with a peripheral lower lobe predominance, but notice that the immediate subpleural lung is less abnormal than lung a couple centimeters away. That is subpleural sparing. That is a finding that is very, very highly predictive for NSIP. And this is concentric lower lobe ground glass, subpleural sparing, nonspecific interstitial pneumonia. Another patient looks just the same. A little bit of reticulation and ground glass opacity in the peripheral lung and posterior lung, but notice subpleural sparing. Classic NSIP. Now here is a patient who shows reticulation and traction bronchiectasis. So the reticular opacities here, these little holes, are dilated bronchi seen in cross-section. That's traction bronchiectasis. I'm not calling this honeycombing because it's not subpleural. Maybe that's one honeycomb cyst right there, but honeycombing is inconspicuous in this disease. Notice that there is relative subpleural sparing. The lung immediately adjacent to the pleura is less abnormal. This is a classic example of fibrotic NSIP. So we're seeing reticulation, traction bronchiectasis, not so much ground glass opacity, subpleural sparing. And here another example, reticulation and traction bronchiectasis with subpleural sparing, fibrotic NSIP. Now these are survival curves on top for NSIP, survival curve over 9 years, and this is the survival curve for comparison for UIP-IPF, and you can see that IPF has a much worse prognosis than NSIP of all sorts. And if you distinguish cellular NSIP from fibrotic NSIP, cellular NSIP much better than UIP, fibrotic somewhere in the middle. Now here are two classic examples of the two interstitial pneumonias I've talked about so far, UIP and NSIP. These are the appearances you should look for in trying to distinguish these two diseases. On your left, honeycombing at the lung bases, classic UIP pattern, likely IPF. On your right, we're seeing ground glass opacity with subpleural sparing, classic NSIP. Okay, the third interstitial pneumonia, respiratory bronchiolitis and desquamative interstitial pneumonia, almost all cases related to smoking. Respiratory bronchiolitis is a very common histologic abnormality in smokers. If you have a patient who's a smoker who's getting a lung biopsy, you can bet that they will have RB on biopsy, because all smokers do basically. If that histologic abnormality is associated with symptoms, it is called respiratory bronchiolitis, interstitial lung disease. If the disease is much more extensive, it's usually called DIP. It's a similar histology, but much more extensive in distribution. DIP, much less common than the other interstitial pneumonias I've talked about so far. I don't see very many cases. Treated with steroids or smoking cessation, and prognosis is good. And you can almost count on the fact that someone who has a diagnosis of DIP will continue smoking and take steroids. Respiratory bronchiolitis and DIP, histology is intraalveolar macrophages with very little fibrosis. Ground glass opacity is what we see. Patchy or centrilobular nodules tend to predominate in patients who have the entity of respiratory bronchiolitis, interstitial lung disease. And ground glass opacity is more diffuse in DIP, maybe patchy or subpleural in distribution. It's variable. This is a 56-year-old smoker, and you can see here there's sort of patchy ground glass opacity. Maybe if you use your imagination, you can see that some of these ground glass opacities have a centrilobular predominance. This is respiratory bronchiolitis. Here's a patient with much more extensive ground glass opacity. And these little cysts tend to occur in people that have DIP. I'm not sure exactly what they are, probably areas of air trapping or little nematoceles or something like that. but this is a typical appearance of DIP in a heavy smoker. So if you know your patient is a smoker, these entities are something to consider, but they're not very common, and they don't generally pop up in my differential unless I know the patient is a heavy smoker. Okay, back to high-res CT findings. We'll talk first about consolidation. Consolidation means increased lung opacity with obscuration of underlying vessels, and that is distinguished from ground glass opacity, where the lung is increased in attenuation, but you can still see vessels within the abnormal lung regions. So if it's entirely white, it's consolidation. If you can still see anatomy in the abnormal region, it's ground glass. Differential for consolidation depends on the duration of the patient's symptoms. It's a very simple way to approach it, but it's the way I do it. If the symptoms with consolidation are acute, then you think of pneumonia, pulmonary edema, pulmonary hemorrhage, or diffuse alveolar damage, which is the histology of ARDS. If you see consolidation in patients with chronic symptoms, and by that I mean 6 weeks or more, then I think of organizing pneumonia, chronic eosinophilic pneumonia, and what we used to call diffuse BAC, bronchial-alveolar carcinoma, but the name is in the process to being changed to invasive mucinous adenocarcinoma. That is a change that's occurring. BAC is not a term we're going to be using in about a year. I'm not even using it anymore now. Mucinous adeno. So here a patient with lupus, acute dyspnea. The finding is consolidation. Symptoms are acute. Differential diagnosis is pneumonia, edema, hemorrhage, something of that sort. This was pulmonary hemorrhage. 73-year-old with pneumonia and fever for 6 weeks on treatment. So these are chronic symptoms. The finding here is consolidation. Differential diagnosis is going to be different, and the things I think of first are going to be organizing pneumonia, chronic eosinophilic pneumonia, which is basically the same as organizing pneumonia, and then diffuse bronchial alveolar carcinoma, invasive mucinous adenocarcinoma of the lung. And this was organizing pneumonia with patchy consolidation, a very typical finding. Okay, we'll talk about organizing pneumonia for a second. The histologic pattern is granulation tissue polyps and bronchioles associated with patchy organizing pneumonia. Organizing pneumonia is associated with a syndrome often known in the US as BOOP. The ATS-ERS prefers organizing pneumonia or COP as terms to use. I generally say organizing pneumonia unless I'm among friends, and then I love to say BOOP, as you know. Quite common. Idiopathic infection, drugs, collagen diseases, fume inhalation, or various causes. Several months of cough, dyspnea, and low-grade fever are typical. These patients often appear as if they have a pneumonia that hasn't been adequately treated. It responds well to steroids, has a good prognosis, 5-year survival, basically 100%. High-res CT findings, patchy airspace consolidation or ground glass is seen in most. Large nodules or masses, peripheral and peribronchial distribution is typical. These areas of consolidation are in the subpleural lung or around the central airways. The opacity is often quite irregular in shape. Findings of fibrosis uncommon and mild. And there's a finding that is particularly suggestive of this entity, and it may be called the atoll sign, but more typically or commonly referred to in the literature as the reversed halo sign, common with organizing pneumonia. This is a patient with amiodarone treatment who has progressive dyspnea. What we're seeing are areas of consolidation which are peripheral and peribronchial, very irregular in shape. This is a great example of organizing pneumonia as a drug reaction. And this is the atoll sign. What we see here are areas of consolidation that are rim-like, and then ground glass opacity in the center, or here crescents with ground glass opacity. Here a very funny shaped one with ground glass opacity in the middle. This is the halo sign, which I'm sure you've heard about, a dense central nodule surrounded by a halo of ground glass opacity, commonly seen with angioinvasive aspergillosis. And this appearance is sort of the exact opposite of the halo sign, which is why it has been referred to as the reversed halo sign. But also, I think it very strikingly resembles an atoll, and this term actually appeared in the literature first, although it happened to be in Italian. But This is an atoll, and I have this down for my own residents because only about half know what an atoll is. A ring-shaped coral reef enclosing a lagoon and surrounded by the open sea. And the atoll itself often has a few breaks in it so the tide can go in and out, and these often have breaks in them. And this looks whiter than it does on the outside, which is what an atoll sign looks like as well. But as I said, my residents don't generally know this. Apparently, they don't spend quite as much time in Hawaii as does the faculty. Organizing pneumonia. If you see this atoll sign, very, very highly predictive for organizing pneumonia, although it can be seen with a few odd infections as well. And these are pictures from the literature of the reversed halo sign in COP, or cryptogenic organizing pneumonia, and in this study that was seen in about 20% of cases, but you can see these little atolls quite nicely. Now, chronic eosinophilic pneumonia may be idiopathic or associated with a known antigen. Peripheral eosinophilia usually present. Symptoms are about the same as for organizing pneumonia. Asthma is a common association. It is basically identical to organizing pneumonia in CT appearance and symptomatology. We see peripheral ground glass opacity or consolidation. This tends to have an upper lobe predominance and rapidly responds to steroids. And there's a good deal of overlap histologically and clinically in everything between organizing pneumonia and eosinophilic pneumonia. Some pathologists think they are the same thing, basically, one with eosinophilia and one with less eosinophilia. But keep in mind that this is a different thing that can look exactly the same. This is a patient with 2 months of cough and dyspnea. We see these areas of consolidation, peripheral and peribronchial. Some of these look like they're showing an atoll sign, but this person has a peripheral eosinophilia, and this is chronic eosinophilic pneumonia. Looking exactly the same as organizing pneumonia, and again, these are probably the same thing. And here a patient with months of progressive cough and shortness of breath, a lot of consolidation here on both sides. This is invasive mucinous adenocarcinoma of the lung, again formerly known as BAC, with consolidation. And in patients who have this tumor, what's going on is the tumor grows along alveolar walls with a pattern termed lipidic growth. But the tumor cells produce mucin and fluid, and that fills the alveoli and causes the consolidation that we see on CT. It's not the tumor that causes the consolidation, but the mucin. Okay, this is ground glass opacity. Now what we see again is increased lung opacity, but vessels remain visible in the abnormal regions. Air bronchograms may or may not be seen. This happens to be Goodpasture syndrome with pulmonary hemorrhage. Now this is an appearance of normal alveoli, and ground glass opacity may result from alveolar wall thickening, partial alveolar filling, decreased alveolar air. Each of those can result in ground glass opacity as we see it on CT. And here, courtesy of Photoshop, I have done that. Here I have thickened the alveolar walls. That will result in increased tissue within that voxel. That will appear as ground glass. Here I have filled some of the alveoli with a pink proteinaceous fluid. That will result in increased attenuation in ground glass. And here I have shrunk down that piece of lung to a smaller volume. That will also result in increased attenuation. Now, I approach the differential diagnosis of ground glass opacity exactly the same way I approach consolidation, based on the chronicity of symptoms. If the patient has ground glass on CT with acute symptoms, differential is pulmonary edema, pulmonary hemorrhage, atypical pneumonias, diffuse alveolar damage. Basically the same differential, but you consider different sorts of infections, atypical instead of bacterial. Patient with acute dyspnea, sort of a parahilar bat wing appearance to ground glass opacity. This is diffuse alveolar damage due to cocaine or crack lung. Chronic symptoms with ground glass, the differential diagnosis is a lot longer and more complicated. It includes interstitial pneumonias such as NSIP and DIP, hypersensitivity pneumonitis, a very common disease, organizing pneumonia, chronic eosinophilic pneumonia, mucinous adenocarcinoma, again, lipoid pneumonia, rare due to aspiration of lipids, and alveolar proteinosis. Here, a patient with 3 months of progressive dyspnea, so chronic symptomatology with these multiple areas of ground glass opacity, hypersensitivity pneumonitis, again, a very common disease. Now, hypersensitivity pneumonitis is caused by inhalation of various organic antigens. The responsible antigen, however, can only be identified in about half of cases, even if you try really hard. It occurs in acute, subacute, and chronic stages. Repeated exposures cause fever, chills, dry cough, and dyspnea. Symptoms are progressive over months or years, and chest radiographs just totally unhelpful in making this diagnosis. Now, typically patients with hypersensitivity pneumonitis present in the subacute stage, and the appearance that we see on high-res goes along with the histology that is present. It's a very nice correlation. These patients have an alveolitis with alveolar wall infiltration, and that appears as diffuse or patchy ground glass opacity. They have peribronchiolar granulomas that are very ill-defined, and those result in the appearance of ill-defined centrilobular nodules of ground glass. And they also have a cellular bronchiolitis that causes mosaic perfusion, and that's patchy lucencies with air trapping. These may be diffuse or predominant in the mid-lung zones and involves the entire cross-section of lung and does not have a subpleural predominance, as do some of the other interstitial pneumonias. So here we see a patient with dyspnea for months. We see these patchy areas of ground glass opacity. We see lucencies that probably represent mosaic perfusion due to air trapping. The disease involves the entire cross-section of lung, geographic ground glass opacity, hypersensitivity pneumonitis. 66-year-old bird fancier with progressive dyspnea, a very, very similar appearance. We see a rather diffuse ground glass opacity appearance, but then these lucencies, these areas of mosaic perfusion or air trapping, this one looking just like a pulmonary lobule. Hypersensitivity pneumonitis, very typical appearance. This is an expiratory view in the same patient, and you can see air trapping within these pulmonary lobules because of the bronchiolitis that is associated with this disease. Now, in patients who have chronic hypersensitivity pneumonitis, typically we see reticulation and traction bronchiectasis, maybe a little honeycombing. There is no subpleural predominance, and upper lobes are often most abnormal, and that's quite distinct from the appearance you see in UIP or the other interstitial pneumonias, again involving the entire cross-section of lung. Now, this is an unusual appearance of ground glass opacity, but I'll show it to you because it's quite typical. Patient with 6 months of progressive dyspnea, so ground glass with chronic symptoms. It's from that second list I showed you. This person also shows the appearance of crazy paving, where interlobular septal thickening is associated with the ground glass. And I should say as a disclaimer that you may see crazy paving in any cause of ground glass opacity, acute or chronic. But the appearance of crazy paving has become associated with alveolar proteinosis because it is a very typical appearance in alveolar proteinosis, but it is a non-specific high-res CT finding. If I see it, I might suggest this diagnosis. Otherwise, I would almost never suggest alveolar proteinosis as a diagnosis in any case I see. Just so rare. This is the histology of alveolar proteinosis, and it goes along with the CT. What we see is filling of those alveoli with a proteinaceous material causing the ground glass, and then that same material accumulates within interlobular septa and causes the crazy paving appearance. Okay, diffuse lung nodules. Now, when we see nodules as the predominant abnormality on CT, we can characterize the nodules into one of three specific patterns, and that helps with differential diagnosis. And the three patterns are perilymphatic, random, and centrilobular. This is the appearance of a perilymphatic distribution of nodules, and with this pattern, nodules occur in relation to lymphatics. They predominate in three places: in the subpleural lung adjacent to fissures and peripherally, adjacent to central bronchi and vessels, or peribronchovascular, and lastly within interlobular septa. So this is the typical distribution and location of nodules with this pattern. Because it occurs, or the nodules occur only in these specific regions, the overall appearance tends to be patchy. Differential diagnosis, sarcoid, almost all, 95% of cases at least are sarcoid. Lymphangitic spread of tumor, silicosis and co-workers pneumoconiosis uncommon, amyloid rare, lymphoid interstitial pneumonia rare. Again, 95% of patients who have a perilymphatic pattern have sarcoid. This is a nice example. Subpleural nodules peripherally, subpleural nodules adjacent to the fissure. This is a photograph of the surface of a lung in a patient with sarcoid, and you can see these subpleural nodules quite easily. Here, peribronchovascular nodules, another typical finding with a perilymphatic pattern and with sarcoid. A lung slice in a patient with sarcoid, the nodules predominate around the central bronchi and vessels. Mediastinal nodes are seen in up to 90% of patients with sarcoid. Hilar nodes also very typical. The nodes are symmetrical and are described as having a 1-2-3 pattern on chest film. I'll show you that. Lung disease is seen on chest film in about half of cases, many more on high-res CT. What we typically see are perilymphatic nodules, most subpleural and peribronchovascular, with an upper lobe predominance. We see upper lobe masses, big conglomerates of sarcoid nodules associated with little nodules around their outside. Those are satellite nodules, and that has been called the galaxy sign. And later, upper lobe fibrosis, fibrotic masses, and traction bronchiectasis result, along with cysts and emphysema in some patients. So this is the characteristic 1-2-3 pattern of sarcoid, right mediastinal, bilateral hilar. Sometimes you see nodes in the AP window that is sometimes called a 1-2-3-4 pattern, but typical adenopathy in sarcoid. In patient with sarcoid here, we can see a lot of lung disease as well, many nodules in the upper lobes in addition to hilar prominence. A patient with sarcoid here, extensive subpleural and peribronchovascular nodules and masses, and these are conglomerates of sarcoid granulomas. This appearance with large masses and little nodules around the outside or satellites has been called the galaxy sign and is quite suggestive of this diagnosis. In people that have end-stage sarcoid, basically where you have the active nodules, it all turns into fibrous tissue, and you often get these fibrotic masses in the upper lobes with traction bronchiectasis. And here on plain film, typical appearance of sarcoid with fibrosis, bilateral, symmetrical, upper lobe fibrosis, some cyst and emphysema, but these irregular masses of fibrous tissue in relation to the hila. And sarcoid has a propensity to be associated with aspergillomas, very common association. And here a patient with fibrotic sarcoid and these upper lobe masses of fibrous tissue with traction bronchiectasis. And here a cyst or an area of emphysema on the left with an aspergilloma inside it. Now the appearance of sarcoid can be mimicked by silicosis or co-workers pneumoconiosis. And here a patient with simple silicosis showing subpleural nodules and peribronchovascular nodules. This is a patient with complicated silicosis where fibrosis has occurred in relation to these nodules, and you get these upper lobe masses that look very much the same as fibrotic or end-stage sarcoid. Complicated silicosis, and here the CT that could be associated with that appearance. Again, these masses of fibrous tissue associated with traction bronchiectasis in the upper lobes in patients with complicated or progressive silicosis. And here's some calcification occurring in relation to those. So sarcoid and silicosis can appear quite similar in the active stages or in the fibrotic stages. And another finding you may see in either sarcoid or silicosis, but is more typically or classically seen with silicosis, is eggshell calcification, where you see this little rim calcification of mediastinal or hilar lymph nodes. The second pattern of nodules is termed random. Random distribution relative to lung structures. They occur anywhere and everywhere. You see subpleural nodules in this pattern, but there's no predominance in the subpleural regions, an overall uniform distribution. Differential diagnosis is hematogenous disease, miliary tuberculosis, miliary fungal infection, hematogenous METs. And sarcoid, when the nodules are extremely numerous, can mimic this appearance of a random pattern. Now here a good example, diffuse nodules, uniform lung involvement, subpleural nodules present, miliary TB. this a lung slice in a patient with miliary TB. It's just this very diffuse distribution with nodules also seen at the pleural surfaces. And on plain radiograph, these numerous small discrete nodules typical of miliary TB. Another example, miliary coccyonades, diffuse lung distribution, subpleural nodules present, but diffuse and uniform lung involvement. And here a patient with an adenocarcinoma that is metastatic to lung. There are nodules at the pleural surfaces, but diffuse and uniform lung involvement. So random pattern is hematogenous disease. Now the third pattern of lung nodules we can see is centrilobular. And with this pattern, the nodules are occurring in relation to the centrilobular bronchiole or artery. The most peripheral nodules you see adjacent to a fissure or adjacent to the chest wall are about 5 millimeters away from the pleural surface. That's where the centers of the lobules are. Now, because lobules are about the same size, the centrilobular pattern appears diffuse and uniform. But keep in mind that with this pattern, you do not see nodules at the pleural surface as you do with a random pattern. And the overall appearance in different diseases, diffuse or patchy. Now, a very quick algorithm that lets you distinguish these three patterns. Multiple nodules, no pleural nodules present, it's a centrilobular distribution. Differential diagnosis, small airway or small vessel diseases. Subpleural nodules present with diffuse and uniform lung involvement, it's a random pattern and hematogenous disease. Subpleural nodules with a patchy or non-uniform distribution, perilymphatic, usually sarcoid. Here's a patient with diffuse nodules. What is the pattern? Well, the lung is involved in a diffuse and uniform manner. Pleural surface is spared, so this is a centrilobular pattern. The nodules are of ground glass opacity. That's very typical appearance for hypersensitivity pneumonitis. Centrilobular nodules of ground glass opacity. And the histology associated with that, here an interlobular septum, a centrilobular bronchiole, and then a nodule or nodules of ill-defined granulomas surrounding the bronchiole. Differential diagnosis of this pattern, well, it's a little bit longer than the others. Any form of bronchiolitis, infectious or inflammatory, endobronchial spread of tuberculosis or mycobacteria, bronchopneumonia, any cause, hypersensitivity pneumonitis, respiratory bronchiolitis, interstitial lung disease, endobronchial spread of tumor, again, mucinous adenocarcinoma instead of BAC. Pneumoconioses can do it, silicosis in an early stage. And then vascular disease is much less likely, but pulmonary edema, pulmonary hemorrhage, or some vasculitis. Here a patient with bronchopneumonia, shortness of breath and fever. We see centrilobular nodules here of soft tissue attenuation. So infection is certainly on the differential diagnosis high on the list when you see centrilobular nodules. 27-year-old with cough, shortness of breath, and fever, a few cavities in the lower lobe, centrilobular nodules. This is endobronchial spread of TB. Here, invasive mucinous adenocarcinoma or diffuse BAC with centrilobular nodules due to endobronchial spread. So that's the differential diagnosis. Okay, very important finding, and it's something I think Brett will probably talk about in the next presentation, is tree and bud. Tree and bud refers to an appearance we see when there is dilatation and impaction of centrilobular airways. Resembles a budding tree. If it did not resemble a budding tree, it would be a very stupid name, but it does. These opacities tend to be centered 5 to 10 millimeters from the pleural surface because they're basically centrilobular. The branching opacities we see with this pattern is more conspicuous than you see with normal branching vessels in the lung periphery, and often tree and bud is associated with centrilobular nodules as well. Now, this is what tree and bud looks like. In a drawing, this is what tree and bud looks like. In a patient, we see this branching structure in the lung periphery that represents a dilated, impacted centrilobular airway. Sometimes you see a little cluster of nodules, or you see the buds better than the tree branches. Basically is the same thing. Here, another nice example of tree and bud in between the two. Now, basically, if you see tree and bud, as we see in this case, it's going to be an infection. We reviewed a number of these a few years back, and every case we looked at with tree and bud had some sort of infection. very uncommon in non-infectious airways diseases. So if you see this appearance, and it's a very characteristic appearance, you can bet that the patient has some sort of airway infection. A patient with AIDS-related airways disease due to chronic infection. Beautiful examples of tree and bud in the right lower lobe. If I see that, I know I'm looking at an infection. This is a lung slice in a patient who has this sort of bronchopneumonia. You can see these airways impacted with material in the peripheral lung causing this tree and bud appearance. So differential diagnosis, endobronchial spread of TB or MAC, infection, 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 infection. Aspiration occasionally does this, not very common. I've seen 1 or 2 good cases. Allergic bronchopulmonary aspergillosis or asthma with mucoid impaction, not very commonly associated with this. And very occasionally it's reported with BAC. I have not seen a good example myself. Generally speaking, if I see tree and bud, my diagnosis is infection, and that's all I'm going to consider unless I have information to the contrary. Nice example here of multiple trees and bud in the lower lobes on a prone scan, beautiful branching opacities. I'm going to think this is infection, and it's Pseudomonas bronchopneumonia. Okay, emphysema. We're almost done. Emphysema occurs in 3 forms: centrilobular, panlobular, and paraseptal. And they have different appearances. Centrilobular emphysema is nicely shown in this patient, and what you typically see are these black holes that are spotty and involve the upper lobes in a sort of spotty fashion. That's a good way to describe it. They generally do not have recognizable walls, although you may see very thin walls in some patients. This is the appearance of centrilobular emphysema on a plain film. We see upper lobes, again this is an upper lobe predominant abnormality, that are much too hyperlucent, may be increased in volume as we see here, and have vessels that are very small or spindly. The second type of emphysema is panlobular emphysema. This results in almost total obliteration of pulmonary lobules themselves. And we tend to recognize this as lungs that are too big, too black, and have vessels that are too small. We do not tend to see the same sort of focal abnormalities, focal holes, like you do in centrilobular emphysema. So this may be difficult to diagnose in early cases. Everything just looks too big, too black, vessels too small. On plain film, what you tend to see is emphysema that is diffuse or has a basal predominance. This often associated with a basal predominance on plain film. You can see the lower lobes are quite lucent. And this is the type of emphysema that's associated with alpha-1 antitrypsin deficiency. The third type of emphysema is paraseptal, and this occurs in the lung periphery, and you have these focal areas of emphysema that basically represent pulmonary lobules. They have walls that you can see, and those usually correspond to interlobular septa. This type of emphysema may be idiopathic or may be associated with smoking and centrilobular emphysema, as we see here. But if you see this subpleural emphysema, you call it paraseptal. The last finding I'm going to discuss is lung cysts. Now, lung cyst is usually defined as a localized air-filled lesion. I mean, you have bronchogenic cysts and things like that that have fluid in them, and they have that specific name. But in general, the term lung cyst refers to something that is air-filled. It has a thin but visible wall. It has a wall that's recognizable, usually allows it to be distinguished from emphysema, and is well circumscribed. Now, the differential diagnosis, well, honeycombing is a cystic abnormality. So when you say somebody has honeycombing, you are saying that you see multiple lung cysts in a subpleural location with a thick wall occurring in clusters or layers. Emphysema, if you have a bulla in a patient with emphysema, it has a thick and recognizable wall. That is a lung cyst. So the term cyst can be used with these diseases. If you have a patient with pneumonia who develops pneumatoceles, like PCP, that is, the pneumatoceles are lung cysts. It's just a very general term. Hypersensitivity pneumonitis in some patients may be associated with cysts due to air trapping. But there are several lung diseases that are characterized by lung cysts as the primary or only abnormality. And these are quite rare. These are histiocytosis, lymphangiomyomatosis, LAM, and the lung disease of tuberous sclerosis. Those are quite rare. And Sjogren's syndrome or other collagen diseases associated with lymphoid interstitial pneumonia or LIP, also relatively rare. But these are cystic lung diseases, and I'm distinguishing these from these more common causes of lung cysts that we can usually diagnose as what they are. Now, this, first of all, is a patient who has these patchy areas of ground glass opacity, and then multiple lung cysts in the upper lobes, and obviously a pneumothorax, because one of the cysts has popped. And let's say this person has acute symptomatology, which he probably does because he has a pneumo. But if we see ground glass opacity in association with acute symptoms, we think of pulmonary edema, pulmonary hemorrhage, atypical pneumonia. And this patient has AIDS, and this is pneumocystis with nematoceles. So this is a disease we're going to be diagnosing not based on the cyst, but based on the clinical presentation and other findings that we see. This is histiocytosis, again, a primarily cystic lung disease. Thick-walled cysts are seen in this patient, and they're quite typical. And you can see that the cysts are fewer in number and smaller in size at the lung basis, and that's quite typical of histiocytosis. And the cysts also have very irregular shapes, which is characteristic of this disease. So cysts irregular in shape in histiocytosis, thick or thin-walled in different stages of the disease, and you can see that these are thin-walled at the base. There's an upper lobe predominance in size and number. In early cases, you may also see nodules in association with the cysts, and this is a smoking-related disease. Only people that have, in adults who develop histiocytosis that looks like this, the disease is associated with cigarette smoking. Here's another patient, Langerhans histiocytosis. Notice on a plain film we're seeing some upper lobe lucency. The pulmonary hyla are large because this person has pulmonary hypertension associated with this. These are the CT scans. You can see cysts being irregular in shape and larger in the upper lobes than at the lung bases, although the bases are also involved. Langerhans cell histiocytosis. And this is this patient's lung, removed at lung transplantation, and you can see that there are numerous cysts in the upper lobes. Cysts predominate in size and number compared to the lower lobe. This is a 21-year-old smoker with cough. Notice that in this patient we're seeing nodules and we're seeing thick-walled cysts that are rather small in size, and we're seeing a few things you might call cavitary nodules. This is Langerhans cell histiocytosis in an early stage. This is when you're seeing nodules and before the cysts, or just as the cysts are starting to develop. So there's the progression in Langerhans histiocytosis, nodules, cavitary nodules, thin-walled cysts. 35-year-old woman, lungs are large and lucent. This is a high-res CT seen through the upper lobes in this young woman. This is lymphangiomyomatosis, or LAM, with cysts. Lower lobes, cysts are just as big and just as numerous. So characteristic of cysts in LAM, they're round in shape, not irregular like histiocytosis. Usually thin-walled, as we see here. The wall's pretty thin. Diffuse in distribution, both upper and lower lobes. These occur only in women of childbearing age. I have seen one man with LAM. It was associated with tuberous sclerosis. Otherwise, these are all women that are childbearing age, sometimes older. This is not going to go away if you go into menopause. You occasionally present later on, but usually childbearing age. 1% of patients with tuberous sclerosis show this sort of appearance, rarely in men. And here, the cysts at baseline, 2 years later, they're bigger and more numerous, and this is her lung at lung transplantation, diffuse lung involvement. And the last case, a 72-year-old woman with Sjogren's syndrome and lymphoid interstitial pneumonia, excuse me, LIP. We see thin-walled cysts, usually in people with this disease, LIP, lymphoid interstitial pneumonia with cysts. The cysts are countable, usually limited to a couple dozen. If I made a resident count these, it would be possible. Not possible with histiocytosis, not possible with LAM, but you can count the cysts typically in a patient with LIP, in association with collagen disease. Cysts round in shape, thin-walled, diffuse, limited in number. A few dozen is quite typical. In the first presentation this morning, I discussed UIP, nonspecific interstitial pneumonia, and organizing pneumonia. They're the three most common interstitial pneumonias I see in clinical practice. The other two diseases that I see very commonly and commonly get confused with interstitial pneumonias because of presenting symptoms are sarcoid and hypersensitivity pneumonitis, and I will be discussing both of those in this talk. Sarcoid results in the presence of microscopic non-caseating granulomas that occur in clusters, and it's the clusters we can see on CT, not the individual granulomas. Symmetrical lymph node enlargement or calcification also may be seen. 60 to 70% of patients have characteristic plain film findings that can lead you to the diagnosis. 10% or so have normal chest radiographs. And high-res CT is abnormal in most patients with sarcoid who have normal chest radiographs. Usually in that situation, nodules are seen on high-res CT. Lymph node enlargement occasionally seen, but many patients with normal chest films and abnormal HRCTs in sarcoid don't have adenopathy. The high-res CT findings we see include small nodules, which are usually well marginated, sharply defined, and appear solid. They're not of ground glass opacity. They appear solid on high-res CT. There's an upper lobe predominance in most patients who have sarcoid, and often the abnormalities involve the lung in a patchy fashion. The nodules show a typical perilymphatic distribution, and I will describe for you in some detail what a perilymphatic distribution looks like. And typical lymph node enlargement or calcification is suggestive of the diagnosis in association with the other abnormalities, but is not necessary for diagnosis if you see typical nodular lung disease. Now, this is a demonstration of the distribution of perilymphatic nodules typical of sarcoid. And nodules with this distribution are called perilymphatic because the nodules are occurring in relation to lymphatics wherever there are lymphatics in the lung. And lymphatics occur in specific locations. They are subpleural. So you see subpleural nodules in the periphery and subpleural nodules adjacent to fissures in patients with a perilymphatic pattern. You see nodules in relation to central bronchi and vessels. Lymphatics travel in association with the bronchi and vessels. So peribronchovascular nodules are part of that pattern. And nodules in relation to interlobular septa, which contain lymphatics. Now, because the nodules are occurring specifically in relation to these areas or structures, the overall appearance of nodules that you see when you look at the CT is patchy or non-uniform. Now, this is a very typical CT in a patient who has sarcoid, sort of bad sarcoid, but a nice example. We see nodules in the periphery at the pleural surface and nodules at the pleural surface adjacent to the fissure. Subpleural nodules typical of sarcoid and this pattern. And this is a photograph of the surface of a lung in a patient who has sarcoid, and you can look down through the pleural surface and see these clusters of nodules or clusters of granulomas as these subpleural nodules. Now, also notice there are nodules in association with the central bronchi and vessels, peribronchovascular nodules, and this the cut surface of lung in a patient with sarcoid showing clusters of these nodules or granulomas in relation to a central bronchus. So this also a very typical location for nodules in sarcoid. Subpleural and peribronchovascular is a typical perilymphatic distribution, and it's very typical of sarcoid. The differential diagnosis. Well, sarcoid accounts for at least 90% of patients I see with a perilymphatic distribution of nodules. It's a very, very common cause of this. Other causes, silicosis and co-workers pneumoconiosis, lymphangitic spread of carcinoma, lymphoid interstitial pneumonia, one of the interstitial pneumonias I didn't talk about this morning, and amyloid. So there's a sort of a list of uncommon diseases here with exception of, now here's some more examples, perilymphatic nodules in sarcoid, peribronchovascular and subpleural nodules. Those arrows are pointing at nodules in relation to central bronchi and vessels. And here, nodules at the pleural surface adjacent to the fissure. So patchy nodules, peribronchovascular and subpleural. typical perilymphatic, typical of sarcoid. Sarcoid with peribronchovascular and subpleural nodules with an upper lobe predominance. Again, upper lobe predominance is quite typical of sarcoidosis. Centralobular peribronchovascular nodules may be seen. Nodules in a centralobular location. There are a few examples. I will describe a centralobular distribution in a few minutes, but centralobular nodules may occur in sarcoid because bronchi and vessels occur in the centers of lobules, and sarcoid likes to be peribronchovascular, so the nodules may be seen in relation to small vessels and bronchi in the lung periphery. The histology that would be associated with that, a small centralobular bronchiole, and adjacent to that, a number of these small nodules, small sarcoid granulomas that result in a larger nodule we can see. Now, interlobular septal thickening or interlobular septal nodules are not as common as a finding of sarcoid, but may be seen. These are scans in the lung base in a patient who has sarcoid, and you can see some interlobular septa that show nodular thickening. It's part of a perilymphatic pattern, but not particularly common in this disease. Now, some additional findings may be seen in sarcoid: large nodules or masses in up to a quarter of patients. These are usually bilateral. They are upper lobe predominant because that's where sarcoid is predominant, and parahilar in location. Air bronchograms may be seen in relation to these nodules or masses, and you can often see small nodules or clusters of nodules adjacent to the periphery of these larger masses. Those are called satellite nodules, and that whole constellation of findings with the big mass and the surrounding satellites has been termed the galaxy sign of sarcoidosis. So that's something that can be helpful when you see these large masses. Now, these masses generally represent a confluence of smaller interstitial granulomas. There are just so many peribronchovascular granulomas that they form these larger masses. And then if fibrosis develops, these masses may end up representing fibrous tissue, but early on, they represent confluence of granulomas. This has been termed alveolar sarcoid, but this is a misnomer because all these granulomas that result in these masses and the air bronchograms are actually interstitial in location. Now, ground glass opacity may also be seen in sarcoid. Again, this represents a confluence of small granulomas that simply result in a hazy increase in lung attenuation. And satellite nodules may be seen in relation to these areas of ground glass as well, helping you to make the correct diagnosis. Now, here's a patient with sarcoid and subpleural and peribronchovascular nodules, and some of the nodules, when confluent, form these larger parahilar central masses, and you can see in relation to the periphery of these some satellite nodules, and you could call that the galaxy sign if you wished. Sarcoid, again, with confluent parahilar nodules, some air bronchograms, and then adjacent to the periphery of these masses, you can see satellite nodules, and taken together, again, that is called the galaxy sign. A patient with sarcoid and clustered small nodules resulting in the appearance of ground glass opacity. If you sort of sit back and look at this, it looks like the patient has patchy areas of ground glass, but if you look inside these opacities, you can see the numerous small nodules representing clusters of sarcoid granulomas. And then adjacent to the periphery of these areas of ground glass, you can see individual discrete nodules or satellites that help you decide this is a granulomatous disease and not something like a atypical pneumonia or pulmonary hemorrhage or something of that sort. Now, sarcoid may also be associated with airway abnormalities. These may result in obstruction of large airways. You can have masses of sarcoid granulomas that will obstruct a main or lobar bronchus. You can have small endobronchial granulomas, and small airway obstruction may result from these bronchiolar or airway abnormalities, resulting in mosaic perfusion and or air trapping on expiratory scans. So sarcoid can result in both large airway and small airway abnormalities. Now, here are two examples. On your left is a lung slice in a patient with sarcoid. We're looking at a large bronchus here, and you can see all these little knobby things within the bronchial lumen. Those are clusters of sarcoid granulomas, and these may result in airway obstruction or lobar collapse, something of that sort. Here we're looking at a cross-section of a small airway in the lung periphery, a very small bronchiole, and you can see the wall is abnormally thickened by numerous granulomas. This may cause small airway obstruction, and then secondary to that, mosaic perfusion or air trapping. Now here a nice example. This is a 45-year-old patient who presented with dyspnea. CT shows a mass within the left hilum obstructing the left upper lobe bronchus. At a lung window setting, you can see that there is significant left upper lobe atelectasis. Notice, however, there are one or two other nodules that are visible in addition to this collapsed lobe, but you would have to consider lung cancer as a likely diagnosis. This is a scan that was as part of the same CT that extended down through the upper abdomen, and you can see a number of low attenuation lesions within the spleen. This has a differential diagnosis, of course, but one of the causes is sarcoid. This is a typical appearance for sarcoid involving the spleen. So in the differential diagnosis of this case, we suggested, well, it could be lung cancer with splenic mets, or it could be lymphoma, or it could be sarcoid. Well, he had a bronchoscopy, and sarcoid was diagnosed. There were endobronchial granulomas that were causing the left upper lobe bronchial obstruction. He was treated for sarcoid, and a year later came back with a CT scan that's more typical of cases of sarcoid we see, with some patchy nodules that are peribronchovascular and subpleural, sort of typical appearance of sarcoid on high-res CT. Here a patient with sarcoid and small airway obstruction with air trapping, an inspiratory scan in the upper left-hand corner. You can see a few scattered nodules here and there. On the expiratory image in the lower right, you can see marked air trapping involving a number of different lung regions, lobules, and multilobular areas of air trapping. This sarcoid with small airway involvement. But seeing air trapping like this is not uncommon in patients with sarcoid if you do expiratory imaging. Now later on in patients with sarcoid, as the disease becomes chronic and as fibrosis develops, nodules decrease but often remain visible. Reticulation develops with lung distortion occurring in the regions that showed granulomas or nodules during the active stage of disease. So we tend to see peribronchovascular fibrosis because that is where the granulomas were when the sarcoid was active, usually upper lobe, which is quite unlike idiopathic pulmonary fibrosis and usually allows the two diseases to be distinguished rather easily. But the peribronchovascular fibrosis can result in those same sort of parahilar upper lobe masses. Conglomerate masses of fibrous tissue may result. Traction bronchiectasis is often seen in relation to these masses, and subpleural honeycombing may be seen in a few patients, and on occasion an individual scan in a patient with sarcoid will look like IPF or UIP, but the distribution is different, upper lobe versus lower lobe. Emphysema and cysts often develop in late-stage disease, and these may lead to the formation of mycetoma. Now here are a few examples. Sarcoidosis with fibrosis, peribronchovascular reticulation involving the upper lobe. So we are seeing fibrosis here in the peribronchovascular regions, in the upper lobes and mid-lung zones, because this is where the active disease was when the patient had granulomas. And you can see reticulation and distortion of lung parenchyma and a little bit of traction bronchiectasis within the abnormal mass of fibrous tissue. Another example, sarcoid with peribronchovascular conglomerate fibrosis, traction bronchiectasis within those masses of fibrous tissue, and lung distortion. Another example looks much the same, peribronchovascular conglomerate fibrosis, and here on an expiratory image in the same patient, you can see patchy areas of air trapping. Again, air trapping quite common in patients with sarcoid, and the air trapping persists even in patients with late-stage disease. You can develop, or patients with end-stage sarcoid can develop cystic lesions in the upper lobe. Sometimes these represent dilated bronchi, and sometimes they're simply cysts, but this appearance not uncommon in end-stage sarcoid, and because of these, mycetoma is reasonably common in patients who have end-stage sarcoid with lung fibrosis. Okay, the second topic, or second half of this presentation, has to do with hypersensitivity pneumonitis. Now, hypersensitivity pneumonitis is a very common disease. It's caused by inhalation of organic antigens. However, I should emphasize that the responsible antigen is identified in only about half of patients. Even if you have a patient with biopsy-proven hypersensitivity pneumonitis, you send a visiting nurse to the home to search through the home for pets and air ducts and mushrooms and whatever. You can't find the responsible antigen in at least half of cases, even though you know there's something going on, even though you know the diagnosis, you can't always figure out what the cause is. Hypersensitivity pneumonitis occurs in 3 stages: acute, subacute, and chronic. Usually patients are initially diagnosed or at least come to initial attention during the subacute phase. They have progressive symptoms over months or years. Repeated exposures to whatever the antigen is produces fever, chills, dry cough, and dyspnea. Now, in the subacute stage, the histology, well, first of all, in the subacute stage, what we typically see are ill-defined central lobular nodules. 50 to 60% of patients show that. These are usually of ground glass opacity. And the histology sort of predicts the high-res CT findings. These ill-defined central lobular nodules represent clusters of poorly marginated granulomas that are occurring adjacent to airways as a result of a reaction to the antigen they're inhaling. Patchy ground glass opacity, up to 90% of patients. This is associated with lung infiltration as the process becomes more generalized. Patchy mosaic perfusion or lucent regions due to air trapping may be seen if you do expiratory scans. Air trapping is very common in this disease. This occurs because of the bronchiolitis that is associated with the centrolobular or peribronchiolar granulomas. And if you see a combination of patchy ground glass opacity and lucent regions of mosaic perfusion, which is quite common in this disease, that has been very eloquently termed the head cheese sign by me. And it's a finding that is very helpful in suggesting the diagnosis, something that's pretty easy to recognize and can lead you quite quickly to the correct diagnosis. I'll show you all about that. Now, this disease tends to be diffuse or predominates in the mid-lung zones. Unlike IPF, it involves the entire cross-section of lung. If you're looking at the CT scan, it does not predominate in the periphery, does not predominate in the central lung, and involves the entire cross-section of the lung you're looking at. No subpleural predominance. Now, central lobular nodules, typical of this condition in many patients. What do they look like? What is their appearance on CT? Well, these nodules are occurring in relation to the central lobular bronchiole in this disease, but may also occur in relation to the central lobular artery, as Paige showed you in patients who had pulmonary veno-occlusive disease. The most peripheral nodules you see when you are dealing with a central lobular pattern are about 5 millimeters from the pleural surface, because that's where the centers of the most peripheral lobules in the lung are. So nodules with this pattern do not involve the pleural surfaces as they do with a perilymphatic pattern. They stay away from the pleural surface. And because lobules are all about the same size, these nodules appear evenly spaced if you look at the overall CT scan. Now, here's a nice example: subacute hypersensitivity pneumonitis with central lobular nodules of ground glass opacity. Notice that the most peripheral nodules are a few millimeters from the pleural surface. The nodules are not arising at the pleural surface. There's a little black line adjacent to the pleural surface where the nodules are not visible. And here at a lower level, the same sort of appearance: central lobular nodules sparing the pleural surfaces. Notice adjacent to the fissure, you also see that little black line because the nodules are not involving the pleural surfaces. Very typical of a central lobular pattern and typical of subacute hypersensitivity pneumonitis in many patients. Now, this is histology that would go along with that appearance on high-res CT. What we are seeing here is a central lobular bronchiole. If I can find my arrow, there it is, the central lobular bronchiole, and then poorly marginated granulomas in relation to the central lobular bronchiole that give these central lobular nodules. Now, the differential diagnosis of central lobular nodules, well, usually it's going to represent some sort of a bronchiolitis, infectious or inflammatory. It may represent an infection with endobronchial spread. Hypersensitivity pneumonitis, one of the common causes of central lobular nodules. Endobronchial spread of neoplasm, used to be called bronchiolo-alveolar carcinoma, now is mucinous adenocarcinoma.
Pneumoconioses, silicosis, for example, can give central lobular nodules because the dust is first deposited there. And then vascular causes, pulmonary edema, pulmonary hemorrhage. But most of the causes of central lobular nodules are small airway diseases, and one of the common ones is hypersensitivity pneumonitis. Another example of subacute hypersensitivity pneumonitis with poorly defined, ill-defined central lobular nodules of ground glass opacity, and then also focal lucencies representing mosaic perfusion due to air trapping. Here another level in the same patient, the poorly marginated, hazy, central lobular nodules of ground glass opacity, very typical of subacute hypersensitivity pneumonitis and something that should be high on your list if you see this appearance. Now here's subacute hypersensitivity pneumonitis with patchy areas of ground glass opacity. That's one of the other common appearances of this. And mosaic perfusion, I'm just going to define because I'll be talking about it for the next few minutes. Mosaic perfusion represents inhomogeneous lung attenuation, usually geographic, due to differences in lung perfusion. About half the density of lung is blood. If you reduce perfusion to a specific lung region, its attenuation will decrease as well. With vessels appearing relatively large in the dense lung regions, reflecting the difference in perfusion. Airways disease is most frequent as the cause. The low attenuation regions are often lobular in patients with airways disease as a cause of mosaic perfusion, and air trapping is visible if you use expiratory scans. Vascular obstruction, less common as a cause of mosaic perfusion. Page showed you a nice example of that in his pulmonary hypertension talk. Now, mosaic perfusion or air trapping may be an isolated abnormality in several different diseases, bronchiolitis obliterans, asthma, and hypersensitivity pneumonitis. Now, this is an example of mosaic perfusion here in inspiratory scan. Notice that there are patchy areas of lucency. Here is a single pulmonary lobule that appears lucent, and that is because there is less perfusion of that lobule because of a airway abnormality. And here on the expiratory image, you can see air trapping, and specifically in that one lobule, again, air trapping because of an airway abnormality as the cause of this discrepancy in perfusion. Now, in hypersensitivity pneumonitis, we often see this combination of patchy areas of ground glass opacity and patchy areas of mosaic perfusion. And this combination together represents the head cheese sign, and it's very typical of hypersensitivity pneumonitis because hypersensitivity pneumonitis results in both lung infiltration resulting in the ground glass and airway obstruction resulting in the mosaic perfusion. So that combination is the so-called head cheese sign. Ground glass opacity equals lung infiltration. Lucencies or mosaic perfusion equal the bronchiolitis and air trapping that occurs. Now here another nice example of the head cheese sign in subacute hypersensitivity pneumonitis. And this is why I call it the head cheese sign. My grandfather came from Germany at the age of 16. Actually, he arrived in the United States on the same day as the San Francisco earthquake. But in any case, he lived nearby and spent time with him in the summer. And he always had head cheese. Now this is what head cheese looks like. It's made of the chopped and boiled parts of the head of an animal, usually a hog. And this picture I have is from the days before digital cameras. And I went down to the deli and I bought some head cheese and I brought it back and I put it on my flatbed scanner. I don't recommend it, but in any case, when I was done scanning and getting this nice picture, I peeled it off. And I made the second mistake at that point, and I made it into a sandwich and ate it. And it sort of tastes like it looks. But in any case, head cheese has this very geographic appearance with some areas that are sort of white and some areas that are sort of black and some areas in between. And if I morph this head cheese to black and white, I think you can see the similarity in appearance between hypersensitivity pneumonitis and head cheese. And this is why it is called the head cheese sign, and very, very helpful in recognizing this disease. Here a patient, again, with hypersensitivity pneumonitis and patchy areas of ground glass opacity and areas of mosaic perfusion, so the head cheese sign again. And here expiratory images in this patient showing areas of air trapping in those lucent lung regions as we would expect. Here another example of the same thing, ground glass opacity and lobular areas of mosaic perfusion. Here, air trapping on expiration, as you would expect to see, typical hypersensitivity pneumonitis. Same thing again, 66-year-old bird fancier with progressive dyspnea, subacute hypersensitivity pneumonitis with both ground glass opacity and these lobular lucencies or areas of mosaic perfusion with air trapping on the expiratory images. Now here a patient with an inspiratory scan that looks basically normal to me. I'm not sure I could read this as abnormal. This is biopsy-proven hypersensitivity pneumonitis. The expiratory scan shows air trapping, even though the inspiratory scan didn't show much at all. So this is something you may see on occasion. Now, how about the chronic stage? Patients who have long-term or repeated exposure develop irregular fibrosis consisting of coarse scars and traction bronchiectasis and honeycombing in some patients. The fibrosis is patchy, and unlike idiopathic pulmonary fibrosis, it lacks a subpleural distribution most of the time. It is diffuse or predominant in the mid-lung zones, just like the subacute stages. The fibrosis occurs where the active disease is, and that's usually diffusely, or the mid-lung zones. Again, that's different than the interstitial pneumonias. Upper lobe involvement is quite common, and that would be very atypical for IPF. Superimposed findings of subacute hypersensitivity pneumonitis are present in some patients with fibrosis, so you can see ground glass opacity or central lobular nodules mixed in with fibrosis. And basically the head cheese sign with findings of fibrosis is what you might see. So here are a few examples. Hypersensitivity pneumonitis with progression to fibrosis. On your left, you mostly see ground glass opacity with some patchy areas of mosaic perfusion. On your right, you can see fibrosis is developing with some traction bronchiectasis, perhaps even a little honeycombing, but the ground glass opacity is still visible. And notice that the entire cross-section of lung is involved. It's not subpleural predominant. And here we're looking at the upper lobes where the disease is worst. Now here a patient with chronic hypersensitivity pneumonitis, a prone scan through the lung bases shows fibrosis and honeycombing. You might think that's IPF, but the upper lobes show extensive disease, upper lobe predominance, involvement of the entire cross-section of lung, and some areas of mosaic perfusion that lead you to make the diagnosis. Another example, extensive reticulation, but upper lobe predominance. And here a 2D image I showed you in my last presentation showing a mid-lung or mid to upper lung predominance in this disease with relative sparing of the lung bases. Chronic hypersensitivity pneumonitis with reticulation and traction bronchiectasis. Here we see upper lobe predominance. The entire cross-section of lung is involved. There are areas of mosaic perfusion, so this is like the head cheese sign, but with fibrosis being present. So we're seeing not only fibrosis, but areas of mosaic perfusion and air trapping. Well, in summary, in my last talk, I talked about the interstitial pneumonias. In this talk, sarcoid and hypersensitivity pneumonitis. Taken together, these 5 things constitute most of the cases that I can diagnose correctly or suggest the diagnosis with a high degree of likelihood.
Small airways disease, there's a huge list of diseases that can cause or have small airways involvement. Infections, malignancies, congenital or acquired abnormalities. And the thing that these all have in common is that they affect the center of the pulmonary lobules. So obviously it's important to understand and know lung anatomy. And they affect the center of the pulmonary lobules in different ways. And the manner in which they affect that pulmonary lobule, whether there is filling of the airway, whether there is interstitial inflammation surrounding the airway, dense consolidation surrounding the airway, or airway obstruction, will determine what the radiology looks like. And so my goals today are to talk about the different CT patterns you may see and how they relate to the particular diseases that cause them, and also to really give you a sense of understand why we're seeing what we're seeing. And I think the key to that is really understanding the pathology. So if you have a good pathologist at your institution, I urge you to get to know them very well. My pathologist is great, so I'm very lucky. And I get a lot of good pathology images from him, and it really gives me a lot of insight into why I'm seeing what I'm seeing. This is the classic radiographic classification of small airways diseases. Ill-defined central lobular nodules, nodules with tree and bud, focal bronchiolitis with focal lung lucency, and bronchiolitis with ground glass or consolidation. We use a slightly modified version of this at UCSF. The fourth pattern is generally, the archetype of that pattern is organizing pneumonia. And organizing pneumonia, as you probably all know, is more of an alveolar disease than an airways disease. The airway component is relatively minor, if it's there at all, in both a radiographic and a physiologic sense. So generally, we just don't consider that really a small airways disease. And we're going to add one pattern here, which actually has a lot in common with tree and bud, which is soft tissue or dense central lobular nodules. And we'll talk about how there's some subtle differences between those two, but it does have a lot in common with the nodules with tree and bud. Always remember that at the center of the lobule is both the bronchiole and the artery. And so processes that affect the center of the lobule may be both airways related or vascular related. Now, the airways diseases are by far the most common. So when you see one of these patterns, that's going to be right at the top of your thought process of the diseases, what's causing this. But there are certainly vascular causes of all these patterns, which I'm not going to get into a lot of detail about today. But, and when I think of these, patients with pulmonary hypertension would make me think of these diseases. Patients who have maybe very diffuse abnormality, like 3 days of symptoms, you think of hemorrhage or edema or something like that. So keep this in mind, that this is always in the differential diagnosis. So let's go through the different patterns. This is a very nice example. This is probably the #1 most shown case of UCSF chest radiology. We pass this around like it's an Olympic torch from person to person and go from meeting to meeting showing it because it's such a beautiful example of what it is. And you can see that this is a beautiful example of central lobular disease. Why? Because there's striking sparing of the subpleural surfaces, including the fissures and the peripheral subpleural interstitium. The nodules are spaced about a ½ millimeter or so away from those surfaces. So a beautiful example of central lobular disease. And the nodules are predominantly of ground glass opacity or ground glass or ill-defined. They tend to be fairly small, as opposed to the nodules of fungal infection, which are very large. So often small, and in areas that are affected, they're relatively homogeneous in size. And the distribution may be diffuse, like it was in that case of hypersensitivity, or may be patchy. The pathologic correlate of this finding is inflammation, or much less likely, fibrosis surrounding the airway. Peribronchial inflammation usually. And more commonly, it's interstitial than alveolar. For instance, hypersensitivity pneumonitis, and I'll talk about why that is in a second. Occasionally, alveolar disease will do this, but more commonly, it's an interstitial process surrounding the small airway. And then what's absent is airway thickening, airway impaction, filling of the airways, and then dense confluent consolidation surrounding the central lobular lobule region. Some things you may want to think about in terms of putting this in a perspective is exposures like birds or dusts or mold, smoking history, and then underlying systemic disorders. Okay, so we're talking about nodules involving the central portion of the lobule, which look ill-defined, and again, you can see the nice distribution, how it's going to be about 5 millimeters from the subpleural surfaces. The pathology, you can see there's the airway running at the center of the lobule, and we can see this interstitial inflammation in this patient with hypersensitivity pneumonitis, and notice how it kind of peters out here at the subpleural surfaces. So this is the pathologic correlate of this radiographic appearance, and as I said, more commonly, not always, but more commonly, this represents interstitial inflammation, and when you have inflammation within the alveolar septal walls, there's the bronchus. Actually, we'll see a little bit of lambertosis, which is bronchialization of the alveolar walls adjacent to the bronchi. But there's airway thickening with air and alveoli, and when those average between the two, you get ground glass, as opposed to a patient with dense consolidation where it looks more solid. And there's the correlate on CT scan, another nice example of HP, which is by far the most common disease to give this pattern. You can see the nodules lined up like little soldiers along this, about 5 millimeters from the subpleural interstitium. Differential diagnosis, HP is the vast majority of cases, and if you have the CT scan and a clinical and exposure, it's considered diagnostic, and we will not get a biopsy in those cases. Of course, that only happens in about 50% where you have the exposure. Respiratory bronchiolitis in a smoker, HP is somewhat less likely in a smoker, so we think of respiratory bronchiolitis. If the patient has connective tissue disease or some sort of immune suppression, like common variable immune deficiency, you may think about follicular bronchiolitis. If they have an acute infection, we think mainly about viral infections where you have peribronchiolar, interstitial, and maybe some alveolar inflammation. Usually this is very early in the process of a viral infection before more generalized diffuse alveolar damage has developed. And then occasionally pneumoconioses. Usually silicosis and coal workers produce more well-defined nodules. Occasionally they can produce this pattern, but probably the more common one we see is in welders who have siderosis, where it's just deposition of iron adjacent to that bronchiole without a lot of lymphatic drainage or reaction to it. Here's a case of respiratory bronchiolitis. On the pathology, you see the nice example of relatively subtle interstitial inflammation and cellular inflammation in the interstitium surrounding the bronchiole. We see some pigmented macrophages here. The inflammation tends to be somewhat less than HP, so the nodules that we see are often very, very indistinct, almost things you would pass over if you weren't looking too carefully. Here's a case of siderosis. The arrow is pointing to a nice example of a central lobular ill-defined nodule. And again, what we're seeing here is mainly just deposition of iron around the airways without a lot of lymphatic drainage or reaction to it. Okay, so that's ill-defined central lobular nodules. Tree and bud looks very, very different. And here's a nice example there in the left lower lobe in particular. We see these branching tubular opacities. Their density they're much denser than the ill-defined nodules we just saw. And along the branches, we have a few nodules. And of course, that corresponds to this, which we've seen earlier. This is one of my trees in the spring right about now when the buds start to swell. The importance of tree and bud, well, it's a subtype of central lobular nodules, so these also should be spaced away from the subpleural interstitium, and they are branching with nodules, and it's often associated, now what we're seeing with tree and bud is essentially filling of the bronchi with usually infectious debris. That infectious debris may not stay there, it may extend outwards. So these are often associated with consolidation centered upon the center of the lobule, depending upon the stage of development. And it represents pathologically filling of the airways with various materials, and then that material over time can spread into the adjacent alveoli. And you could develop consolidation centered within the center of the lobule. And of course, immune status is very important in distinguishing the different infections, or at least the likelihood of different infections. Chronicity of symptoms, more chronic cases, you maybe think of MAC, or maybe think of something else like an invasive mucinous adenocarcinoma. And then this is some of the systemic disorders like HIV, like immunodeficiencies and connective tissue disease. Okay, so in this case, we're talking about filling of the airways with usually infectious debris, and that's what gives us this appearance. And over time, that will spread out into the adjacent alveoli. The importance of tree and bud is it's virtually always infection or aspiration. Those are, the specificity for infection or aspiration is very high. And you can include some what I call sort of infectious variants, which are basically infection in the airways and mucostasis. Like ciliary dyskinesia, where you're not clearing secretions normally and you get chronic infection in the airway. In most cases, the infectious variants are going to have some other findings to lead you to that diagnosis because they tend to be severe airways inflammation and chronic. So you often have just more large airways involvement, bronchiectasis, inflammation. There are non-infectious causes which are quite rare, so we usually don't think of these unless there's an important clinical history, with the exception of aspiration, which we've found is a not uncommon cause of tree and bud, but things like allergic bronchopulmonary aspergillosis, so in an asthmatic you may want to think about that disease, or things like the one big non-infectious cause of tree and bud that we have seen is follicular bronchiolitis, and what leads us to the diagnosis is going to be the history of connective tissue disease or immune suppression, and often it's very, very symmetric, and the nodules are all very small, which would be a little bit unusual for garden variety bacterial pneumonia to do, which would be more patchy and more heterogeneous in size. We have actually never seen a good case of tree and bud in invasive mucinous adenocarcinoma or multifocal BAC, although it's been described, but but we've actually never seen a very good example of tree and bud. And occasionally processes that surround the bronchiole, like sarcoid, can give you what I call pseudo-tree and bud, but there's usually going to be other nodules in other locations, subpleural nodules, more typical hilar predominant symmetric lymphadenopathy. So usually it's infection. So here's an example of a rare atypical mycobacterial infection which really shows the progression of disease over time very nicely. We have tree and bud, again, that's mostly filling of the small airways with infectious material, and then that extends into the central lobular, the alveoli surrounding the center of the lobule, so we have more of these dense nodules, some of which are relatively small, some of which are bigger, and then more confluent areas of consolidation where the process has just been going on for a while longer. Here is what those nodules represent. You have impaction and you have consolidation. You have confluent alveolar disease centered upon the bronchiole, the central lobular bronchiole. And that's why these nodules tend to look much denser than what's more commonly the interstitial inflammation of the first pattern, typical of things like HP. So consolidation begins here, but it doesn't end there if it's not treated appropriately or the immune system doesn't handle it, and it eventually fills up that entire pulmonary lobule and produces areas of more confluent consolidation. Here's an example of cystic fibrosis with nice examples of tree and bud, and it was some pretty, bilateral and upper lobe predominant, a little bit asymmetric, and this patient also had more central areas of bronchiectasis. So just an example of someone who has both large airways and small airways involvement with this process. An example of a MIP on someone with primary ciliary disorder. Lots of good examples of tree and bud, and they follow right back to the more central airways. And again, this is chronic mucostasis, chronic infection, mainly contained within the lumen of the airways and a little bit of inflammation surrounding the airways. Someone with ABPA and central lobular nodules, tree and bud, there on the right. A little bit in a slightly different location, had more typical cystic bronchiectasis and mucus impaction. Patient has asthmatic. That combination is pretty typical of allergic bronchopulmonary aspergillosis. We try to maintain our specificity for calling tree and bud because we want to be highly specific for infection. This was called tree and bud, but I don't see a good example here. And I think when the nodules are patchy like this, we just assume, oh, it's infection. There's a tree and bud. That's pretty good enough. But the other distribution of nodules that may be patchy like this are lymphatic processes. So the goal is we don't call tree and bud unless we see a very good example of it. This patient actually had a follow-up which was totally stable, so we recommended a high-res CT, and there are clearly subpleural nodules which you should not see in patients who have tree and bud. So this was a patient with sarcoidosis who also had some peribronchovascular nodular thickening. Okay, so just don't make that mistake. Be specific. Now, not all patients with pneumonia will have tree and bud. Some patients will look like this and just have these nodules, which appear denser than the first pattern of the ill-defined central lobular nodules. And so we sort of include this as a separate category, but very closely related to the tree and bud category. And you can see a nice example of different nodules of different sizes, smaller nodules, somewhat bigger nodules as they start to fill up that entire lobule, and then very large nodules almost filling up a pulmonary lobule. So this is different stages of evolution in someone who had a basic old bacterial bronchopneumonia and did not have tree and bud here or anywhere else. And our differential is just a little bit broader. Usually infection, aspiration, that's it for tree and bud. Some other things we've seen in the more chronic setting, you can think of multifocal BAC or invasive mucinous adenocarcinoma. And then Langerhans, often you'll see the cavitation and cystic changes with Langerhans, but occasionally you'll just see the nodules. And they can be ill-defined, but they tend to be more commonly this density, more dense, because they're more discrete collections of Langerhans cells. Here's a nice example of invasive mucinous adenocarcinoma, showing a very similar pattern. Invasive mucinous adenocarcinoma certainly may present with ground glass nodules, but in our experience, it much more commonly presents with these dense nodules. And if a patient has both ground glass and dense nodules, usually we sort of use the dense nodules in our differential diagnosis. So again, you see smaller nodules. Notice it's distant from the fissures. You have bigger nodules, and then these very large confluent areas of consolidation. Okay, third and final pattern is bronchiolitis with focal lung lucency. You see example like this. You have heterogeneous lung density, lucent and opaque lung. In this case, I'll tell you the lucent lung is abnormal, but that may not be clear. So the one question would be, how do we differentiate when the lucent lung is abnormal and the pattern is mosaic perfusion, and how do we differentiate when the opaque lung is abnormal and the pattern is ground glass opacity? So in mosaic perfusion, due to bronchiolitis, the obstruction or stenosis of the airways leads to decreased ventilation. Decreased ventilation leads to reflex vasoconstriction, and thus why we call it mosaic perfusion. And the decreased perfusion causes decreased areas of lung attenuation. That's the pathophysiology behind why the lung is lucent. When we are differentiating mosaic perfusion versus ground glass, most commonly is this very sharp demarcation. Ground glass most commonly is an acute alveolar process, not always, but often is. And often at the edges it appears very hazy. It kind of blends into the more normal lung. Whereas mosaic perfusion is obstruction of very focal airways, and the airways would just be knocked out of the lung. So you see sort of I always tell my residents, it's like you took a cookie cutter in the shape of a few lobes and just sort of knocked it out of the lung. So that's one. Number two, is helpful if you see it. It's not helpful if it's absence, but difference in vessel size. So in mosaic perfusion, the lucent lung, the vessels may be much smaller in the lucent lung than in the normal opaque lung, and that may be helpful in telling that the pattern is mosaic perfusion. If you see air trapping in the areas that were lucent on the inspiration, then that just confirms that the pattern was mosaic perfusion. And I find stability over time can be helpful. Again, because ground glass is often an active alveolar or inflammatory process, and it usually changes over time. So if you feel very, very stable findings over a period of time with two densities, at least consider that the lucent lung is the abnormal one. I'll show you a good example of that. Okay, so just to drive home the point of differentiating lucent from opaque being abnormal, these are all cases of mosaic perfusion. This is a case of neuroendocrine hyperplasia. Notice the very, very sharp demarcation between lucent and opaque. The lucent is abnormal from small airways disease. This is a patient, I believe, just with asthma who has a more abnormally lucent lung, and on the expiratory that stays quite lucent, whereas the more opaque normal lung, as it should, gets denser on the expiratory image. And this is actually a patient with chronic PE. Sorry, that's in there for a airways talk, but you can notice, and that's particularly prevalent with vascular causes, the vessel size difference. Notice the tiny little vessels in the lucent lung and the more opaque, or larger vessels in the more opaque lung. Okay, so this is an example of neuroendocrine hyperplasia, and the archetype of this pattern, the disease that probably commonly produces this pattern, most commonly is constrictor bronchiolitis or obliterative bronchiolitis or bronchiolitis obliterans, whatever you want to call it. They're all sort of synonymous. And in this case, you have fibrosis of the airways, but you can't see that fibrosis that surrounds the airway. We can't resolve that on a CT scan. So what we see is the downstream sequela of that airway obstruction, which is decreased ventilation, decreased perfusion, and decreased lung attenuation. Here's a path example of constrictor bronchiolitis. This is I believe, in that category where if a pathologist sees a normal exam in someone with symptoms, this is one of the diseases that can produce that. These findings can be extremely subtle on path, and thus we often don't see them in a CT scan. But that's where the smooth muscle should be, and this is an airway at the center. And in this case, this is mostly fibrosis surrounding that airway. And this can be very, very subtle on path, and we can't resolve that airway fibrosis on CT scan. Another example of bronchiolitis obliterans in a patient who was in a fire. You can see a nice example of lobular mosaic perfusion on the inspiration. On the expiration, it stays quite lucent, and that's compatible with small airways disease. Here's where the stability over time, I think, can be helpful. When you see opaque and lucent lung, okay, well, it is sharply defined, but viral infections can sometimes be sharply demarcated like that. Because there's such a difference in opaque and lucent, we tend to think the opaque is abnormal. But this patient was exactly the same 6 months later, which would be unusual for viral infection or any other cause of ground glass to do that. On the expiration, you can see how the normal lung, which is this small sliver of lung, gets denser, and everything else stays about the same. Pulmonary function tests may be very helpful here. This patient had a horrible obstructive defect on pulmonary tests because essentially they had very, very extensive air trapping. Mosaic perfusion, a fairly nonspecific finding. It can be seen with any airways disease, such as in this patient with cystic fibrosis. And we essentially ignore it unless it is the predominant finding, in which case it's only a small group of diseases. Mainly one is constrictor bronchiolitis, Asthma and HP are the other two where we can see this finding in isolation, and of course vascular diseases as well. So we've gone over these 3+1 patterns of small airways disease, why they look the way they look, and the differential diagnosis.
So as we begin HRCT and the multi-detector CT era. We're going to talk a little bit about the background of HRCT and how it's evolved into multi-detector acquisitions, what that means in terms of setting up a patient protocol, and what the limitations and pitfalls are related to that technique. An important structure is the border of the secondary pulmonary lobule, which is the interlobular septum, familiar to most of us on the chest X-ray as the curly B line when we see it. At a minimum, HRCT technique consists of thin collimation combined with a high spatial frequency reconstruction algorithm. Thin collimation has generally meant between 1 and 1.5 millimeters, but with today's multi-detector CT scanners, that can now mean sub-millimeter collimation, 0.5 millimeters, 0.6 millimeters. The high spatial frequency reconstruction algorithm, I'll show you some comparisons to standard soft tissue reconstruction algorithms, gives us an edge enhancing very similar to what's done for bone imaging, making the edges of small lines and small nodules more discernible and hopefully making them more conspicuous. Imaging spacing, particularly in the non-multi-detector era, has been variable and largely incremental, where images were obtained with large areas of skip between them. It could have been one image every 3 or 4 centimeters throughout the lungs, or as close as at 1 centimeter increments. Imaging is usually performed in the supine position, but prone imaging is particularly important to exclude the dependent opacity as a mimic of lung disease. Imaging is primarily performed at end inspiration to get the best lung detail and separation of diseased and normal structures, but end expiratory images provide an important role in looking for evidence of small airway disease that may not be visible on the inspiration images. And since the disease processes that cause shortness of breath, one of the reasons that interstitial lung disease is suspected, could be related to any number of disease processes, as many of the speakers here are going to be discussing, and expiratory images may be useful. People have performed targeted reconstructions where the entire pixel matrix is used to reconstruct one lung or the other lung, but primarily this has fallen out of favor, and not too many places use this as the primary way they review the images. With multi-detector CT, now we use multi-detector helical CT acquisition so that we have volumetric HRCT with contiguous images from lung apex to base, a true isotropic image set, as you would for a CT angiogram of the aorta, and this gives us some advantages. Let's look at the impact of a few technical variables on image quality, and the first of those is slice thickness. This is a 2.5 millimeter image in which we can see some low attenuation areas here, here, and here. And an important distinction is going to be whether there is a wall around these black holes or not. Black spaces or black holes with no walls is pretty much the definition of emphysema, whereas to see a wall around it would indicate cysts, which is a different differential diagnosis. On a thicker section image, 2.5 millimeters, you would partial volume away the edges of small cyst walls with adjacent lung, and you might not see them at all. With a 1.25 millimeter technique, we can see that there are just barely discernible, thin little white edges around these black spaces, making these cysts and not areas of emphysema. Here is another comparison of standard CT technique versus HRCT technique. This is a 1 centimeter slice using a soft tissue algorithm, and at the same anatomic level, a 1.5 millimeter thin section using a high spatial frequency reconstruction algorithm. There's no anatomic difference in the location of these images, but the amount of lung detail visible on HRCT is readily obvious. On the thick section, we have increase in lung parenchymal opacity. We can just barely see some vessels through it, and we see very little detail at all with respect to small airways. Note we also don't see the fissures. The fissure is an avascular plane. On the thin section HRCT image, we see the fissure for what it is, areas of mesothelial cells with submesothelial connective tissue. We see many small airways in cross-section, which we're not able to see with the thicker sections. And within that ground glass opacity, we can also appreciate a fine, lacy pattern in the underlying interstitium, not evident on a conventional CT image. In the setting of conditions like asbestosis, the HRCT image can be particularly useful because it may be hard to distinguish between pleural plaques and asbestosis. Is this blurry abnormality along the edge of the lung next to the plaque just a plaque with partial volume averaging, or is it real lung parenchymal disease? And by using thin sections in the high spatial frequency reconstruction algorithm, we can clearly see the thin, lacy intralobular septal lines of asbestosis. So this patient doesn't just have asbestos-related pleural disease, they have asbestosis involving the pulmonary parenchyma. And a last comparison of CT versus HRCT images is this: a 10 millimeter standard soft tissue algorithm image versus an HRCT, and a patient with biopsy-proven usual interstitial pneumonitis, which on HRCT is characterized by honeycombing, contiguous cystic spaces. This is end-stage fibrotic lung, well shown in radiologic pathologic correlation. But if you take the same patient at the same time and reconstruct the data into a thicker slice and don't use a high spatial frequency reconstruction algorithm, all these little tiny honeycomb cyst walls blur together and could be mistaken as being ground glass opacity. And why is that important? Because in cases of UIP, ground glass opacity may be potentially reversible disease, and patients with ground glass opacity may be given more aggressive cytotoxic medications to treat potentially reversible disease and improve function, whereas patients with purely honeycombing, which is irreversible, are less likely to be given those toxic medications, which have side effects. This is our multi-detector HRCT protocol. Our acquisition includes 3 passes: a volumetric inspiratory helical acquisition where we reconstruct 1.25 millimeter images contiguously throughout the entire lungs from apex to base. Our clinical expiratory protocol is still incremental to minimize radiation dose, with 1 image every 2 centimeters throughout the lungs at expiration. And similarly, in the prone position, we perform the same incremental imaging. Many research protocols, however, now are volumetric in all 3 phases: volumetric inspiration, volumetric expiration, and volumetric prone imaging. The viewing, of course, for a multi-detector HRCT protocol is going to be multiplanar and interactive. It's no longer going to be looking at axial images alone, just like you would not accept for an angiographic study. Here's an example of a patient with emphysema. Image targeted here in the right upper lobe shows you the low attenuation spaces, often around small centralobular vessels, centralobular emphysema, but in one axial image, all you see is the upper lobe. In a coronal reformatted image from a multi-detector volumetric CT, in one image I can show the referring clinician not only the presence of disease in the apices, but the absence of disease in the base, so they get an idea of severity and distribution very quickly, as well as looking at the central tracheobronchial tree, which is not a reliable way to look at the airway if your technique is incremental with areas of skip between them. Here's another example: cystic fibrosis, single axial image, severe bronchiectasis, bronchial wall thickening, and a mosaic attenuation pattern in the background lung due to small airway disease and air trapping. But cystic fibrosis can be better shown in this fashion here: sagittal and coronal reformats, very much like a PA and lateral chest x-ray, the way clinicians are used to approaching chest disease and the way they look at their patients, from the front, from the side. Same thing now is possible with the multi-detector CT images, and again quickly shows from apex to base, from front to back and side to side, the distribution and severity of the disease, which one axial image cannot convey. And a third example of multi-detector volumetric imaging in usual interstitial pneumonitis. Again, we can see the subpleural lower lung predominant honeycombing, the associated traction bronchiectasis, and sparing of disease in the upper lung. So multi-detector CT high-resolution technique is an interactive 3-dimensional data set. Well, is it just a bunch of pretty images that help the clinicians appreciate the disease, or does it actually help us in diagnosis? Well, there are some things that it can help us with. differentiating between cysts and cystic bronchiectasis, because now the images are contiguous with no skip areas. So you can trace cystic areas and see, are they running into airways or not? It allows us to look both at the small and large airways in one pass, the tracheobronchial tree, the segmental, subsegmental bronchi of the lung, as well as the small airways by looking for air trapping in a more diffuse pattern. In addition, it's very important to be able to correctly review and characterize small pulmonary nodules. And many of the patients who come for HRCT are at increased risk of lung cancer. Patients with interstitial lung disease and patients with emphysema are all at increased risk of lung cancer. So you're commonly going to find small pulmonary nodules, some of which will prove to be cancer. And being able to compare their size over time when you're comparing their interstitial lung disease or emphysema over time is important. With incremental images, you may catch the middle of the nodule on one exam or the edge of the nodule on the next exam and not have the best section through each nodule to measure them. So an example of where volumetric HRCT helps in the presence of low attenuation spaces is here in the right upper lobe, multiple small black spaces with thin walls around them. Well, are these branching bronchi or is this cystic lung disease? If you have incremental images with a 1 or 2 centimeter gap between them, it can be very hard to tell. With the volumetric image, you can rotate the data set into the best plane for these structures, and here you can see it's clearly a branching tubular structure, bronchiectasis, not individual cysts or cystic lung disease. And in another example of a patient with NSIP, we have the interstitial abnormality, we have dilated bronchi, and we have this little cystic space. Is it a cyst or potential area of honeycombing, or is this a dilated bronchus? And by looking at it in a volumetric fashion, we can trace the bronchus in the best plane for that airway into this space, confirming that it's bronchiectasis. One question I often get asked about volumetric HRCT is, can I or should I do it with IV contrast? For instance, working up a patient for pulmonary embolism and interstitial lung disease at the same time, or working up a patient for pulmonary hypertension, excluding both lung disease and chronic PE in the same setting. And I usually tell people that's not really a good idea because you're going to get limited evaluation of the lungs in multi-detector CTs with contrast. If you stop and look at the lungs on a pulmonary embolism CT, you'll notice what is called the hurricane artifact, which is essentially a beam hardening artifact that's exaggerated with multi-slice CT. This is an example of a lung image, thin section, just like an HRCT is, 1.25 millimeters from a pulmonary embolism CT, but look at all the vessels, little C-shaped or comma-shaped structures with low attenuation on one side. And if you scroll through these areas up and down, you'll note they swirl, hence the name hurricane artifact. This can make it very difficult to look at the underlying lung and exclude particularly mild interstitial lung disease. I don't think you'd have a problem excluding overt honeycombing, but excluding ground glass opacity or mosaic attenuation or subtle nodularity would be difficult routinely on pulmonary embolism exams. So when our clinicians ask us, can they get both, what we usually do is do the second acquisition at low MA for the lungs, and then we follow it with the contrast for the pulmonary embolism exam. So once you know that you've gotten a good quality CT and you know the important parameters to obtain a volumetric HRCT, now you're going to set about interpretation. And for that, you need to know what a normal HRCT should look like. In general, there should be about a clear 1 centimeter peripheral zone around the anterior and lateral aspect of the lungs. When you get to the dependent lung, where there will be some degree of dependent opacity, where the vessels get closer to the pleural surface, you're going to see them looking as if they're touching the edge of the lung parenchyma. But you shouldn't see that in the anterolateral aspect. That should always be clear. In general, you should not see any small airways in the peripheral third of the lung parenchyma. To see them there would be abnormal. They would be bronchioloectasis. A few other pitfalls to think about when looking at the HRCT images. And one I've mentioned already is dependent opacity that mimics real interstitial lung disease. It's more common in smokers. It's more common with increasing age. And that's one of the reasons that we always do prone images for HRCT exams. Here's an example of a patient whose lungs were otherwise unremarkable, but for the presence of dependent opacity. Is this real disease? Is this real, just mild subpleural lower lung disease? Or is this dependent opacity? Without the prone images, my report isn't going to be quite clear that the lungs are normal or not. But by doing the prone images at the same setting, the opacity goes away when the patient's placed prone. It's dependent atelectasis. This is not interstitial lung disease. In contrast to this patient who has dependent predominant opacity in the lungs, again, what is it, real or not real? And when this patient is placed prone, the abnormality persists. This is real interstitial lung disease. Another thing to make sure that you are aware of when you're looking at HRCT images is to use a consistent window width and level combination. If you don't, you may overcall or undercall disease. There's really no one absolute correct window width or level setting. The width is generally between 1,000 and 2,000, and the level between minus 500 and minus 700. We use a window width of 1,200 and a level of minus 600 routinely on our HRCTs. But if you look at the literature across many different experts who report on HRCT, you'll see wide ranges. But the important thing is that you use it consistently, so the lungs don't look lighter today and darker tomorrow. In particular, if you're given hard copy film from another institution where it's been printed at a window level combination that's not what you're used to, you need to take that into account when doing the interpretation. And failure to do so will make you either overcall or undercall ground glass opacity. You may call bronchial wall thickening that's not really there. You may hide emphysema. And here's an example, an exaggerated example to show you this, the thinking here. This is a targeted image through the right upper lobe, and if you look in this area, we have some fuzzy ground glass opacity and ground glass type central lobular nodules. If we change the window level width extremely in one direction, I could make the lungs look like diffuse ground glass opacities with the more focal ones. And if I change it in the other direction, I can take those fuzzy ground glass nodules, which may be indicative of respiratory bronchiolitis or hypersensitivity pneumonitis, and change them into looking like discrete little miliary nodules, which has a very different differential diagnosis, miliary tuberculosis or fungal infection or metastases. Another pitfall in HRCT is increased image noise. And while most of our HRCTs are done with low MA, because you don't need a whole lot of dose to get good lung image quality, and if you're not using low MA technique, especially in light of continued discussions about the seriousness of over-radiating people with CT, I really suggest that you go back and lower your MA on your HRCT protocols. Down to 40 or 60 MAS is perfectly acceptable to get good quality lung images. But every once in a while, you'll be challenged by a patient that no matter how much MAS you generate, the image still looks like this. And the reason, of course, for this is the upsizing of the population. So in a case like this where you have more body than you have lung parenchyma to image, what I usually recommend is to just increase your slice thickness for reconstruction. So instead of reconstructing your images at a 0.5 millimeter, a millimeter, a millimeter and a quarter, reconstruct them at 2, 2.5, or 3. You'll get more signal relative to the noise, and it won't look so bad. You'll get some diagnostic capability out of the images you generate. And then a word of caution. A normal HRCT does not entirely 100% exclude interstitial lung disease. There will be some cases, such as this case, of mild interstitial lung disease where the HRCT looks completely normal. And we reported a series about a dozen years ago of patients who went to surgical lung biopsy with normal HRCTs. They had clinical suspicion of disease. They had pulmonary function test abnormality suspecting disease that was strong enough to go on to surgical lung biopsy, even in the face of a normal HRCT. And their disease was present, but again, it was mild relative to the patients who have abnormal lungs on CT. So every once in a while, this may come up. Does it entirely exclude disease? Not entirely, generally so, but in the face of strong clinical evidence, a surgical biopsy might still be warranted. I put ground glass opacity up here as a pitfall, and the reason for that is it has such a long differential diagnosis. Unlike things like honeycombing that we know are irreversible pulmonary fibrosis ground glass opacity can represent many, many things. The definition of ground glass opacity is increased lung parenchymal attenuation through which you can still see normal vascular architecture. So if you look at this image with the right lower lobe, the lung is too white, almost diffusely, but I can still see the branching vessels through it. If it were so white that I could no longer see the vessels, that of course would be consolidation. Now, ground glass opacity, as I said, has this long differential diagnosis, and basically if you think about anything that can cause alveolar opacity in a chest radiograph or alveolar disease, it can cause ground glass opacity. And of course that includes things such as edema, cardiogenic and non-cardiogenic, infections, particularly things like CMV and PCP can manifest primarily with ground glass opacity. Any number of the alveolities from UIP to NSIP to DIP to hypersensitivity pneumonitis, and Dr. Galvin is going to talk to us more specifically about the idiopathic interstitial pneumonias. Alveolar proteinosis gives us a lot of ground glass opacity. One of the reasons that ground glass opacity is also a pitfall is it can represent fibrosis that is below the resolution limit of HRCT. We like to think of ground glass opacity in the setting of pneumonitis as being inflammatory and active and something that can be treated and when treated improve patient outcome and symptoms, but sometimes it actually represents fibrosis that CT cannot resolve the difference of. So the good thing is if you have it may represent an active inflammatory process that's potentially reversible, but the bad and the ugly is it could be fibrosis that's irreversible. And how can you distinguish between them? This is a series from Emily Young and colleagues where they looked primarily at this issue of ground glass opacity and did HRCT pathologic correlation in 27 patients where ground glass was the major abnormality on HRCT. 80% of those patients did have potentially reversible disease when the pathology specimens were reviewed. 20% actually had irreversible fibrosis. So that defines the problem. Martine Remy-Jardin showed us a way to help us out of this pitfall of is ground glass inflammatory or fibrotic. In her study of 26 patients with predominantly or exclusively ground glass opacity, in 2/3 of the patients that ground glass was inflammatory and 1/3 of it was fibrotic. But what they noted is that 85% of the patients in which the ground glass opacity was actually fibrosis, they had bronchiectasis. They didn't have honeycombing, but they had bronchiectasis. So if you see predominantly ground glass opacity in the setting of an interstitial pneumonitis and you see associated bronchiectasis, that should be an indicator that's most likely fibrosis and not active inflammation. Now, there are a lot of specific diagnoses that can be made on HRCT, and you could spend an entire morning or full-day symposium discussing each and every one of those diseases and the major and minor findings that you can see. These conditions include emphysema, that Dr. Bankier is going to talk about at the end of the session, cystic lung diseases, alveolar proteinosis, radiation pneumonitis, amiodarone toxicity, sarcoidosis, hypersensitivity pneumonitis, respiratory bronchiolitis, lymphadentic tumor spread. These are all things where we can play an important role in coming to a specific diagnosis when looking at HRCT. So while I don't have myself time to go through the patterns and the features of all of these diseases today, these are the things that you should consider you're able to make a diagnosis of very consistently with HRCT in your practice. Thank you very much.
Thank you very much, Ella. For the next 30 minutes, I'm going to provide you a general approach to looking at the interstitial lung diseases. And one of the problems that we're going to see with this is that there's not as good agreement as you and I would hope amongst the pathologists. And you and I know that we can only correlate with what the pathologists tell us they can see. The other problem we're going to find here is that a lot of the names that are used are legacy names. In other words, a lot of these diseases were named in the 60s and 70s, and for a variety of reasons, they have kept those names even though they know they no longer represent the pathophysiology which you and I look at. So what I hope to do for you in the next 29 minutes is that I will show you a general approach to these diseases, the role that smoking plays, and to leave you with a general pattern approach to looking at diffuse lung disease that is not infectious. So the idiopathic interstitial pneumonias. The first thing is the lovely presentation that Ella gave you talked about the anatomy of the secondary lobule, so I don't need to go through that. Just to tell you that those people who have these chronic infiltrative lung diseases have abnormalities that, for the most part, do not involve the airway, which here we see the central bronchiole and arteriole that goes into the center of the secondary lobule. So if we look at the abnormality in these people with the, quote, interstitial pneumonias, most of the abnormality is within the secondary lobule in the area of the alveoli themselves. We will see specifically in those patients who smoke cigarettes that there's going to be inflammation around those airways. But for the most part, we're not talking about distortion of or abnormality of the airways themselves. And as a result, most of these patients have what is called restrictive physiology, meaning that a clinician sees somebody who has small lungs. They can blow out the normal air that you would expect them to. If I asked you to blow all the air out in your lungs, you could blow 70% out in 1 second. These patients are able to do that, but their lungs are small. And so as a consequence of their shrinking lungs, you and I expect to see small lungs if we were to look at a plain radiograph. Their pulmonary functions would show restrictive physiology. And for the most part, these people got sick over months to years. So from the clinician's point of view, they're short of breath, they got sick over months, their lung volumes are small, and their airway function appears to be relatively normal. The European Respiratory Society and the ATS got together and created a group to look at these diseases, and they were based on what Avro Liebau showed in the early 70s. So as I said, most of the descriptions of these diseases were from Avro Liebau. And what he showed is, if you look at the images you see here, is that the alveolar walls are thickened, and the blue area here are areas of fibrosis. But he knew, even though he called these, quote, interstitial lung diseases, involving the alveolar wall, he also knew that a lot of the disease were really cells which were in the alveolar spaces. So even though we, as radiologists, have taken this to mean exclusively interstitial lung disease, in fact, most of these diseases have involvement of both the alveolar spaces and the alveolar wall. And this is the list. So in this very short period of time, I'm going to try to give you what is the typical appearance for each one of these diseases. I cannot go into great detail, but I think it will allow you with an early window into understanding them. The first, and probably one of the most important, as Ella points out, is idiopathic pulmonary fibrosis. Again, one of the problems is just the name. In general, IPF, or idiopathic pulmonary fibrosis, is what the clinician will say when they are trying to describe this disease. The pathologist, when they see the abnormality associated with IPF, will call it the usual interstitial pneumonia pattern, UIP. One point I want you to take away is when a pathologist says UIP, although it is part of the diagnosis, it is not specific. There are definitely patients who have other diseases, hypersensitivity pneumonitis is one of them, sarcoidosis, who occasionally will have the UIP pattern of fibrosis. It is not specific. The next three diseases, respiratory bronchiolitis, interstitial lung disease, desquamative interstitial pneumonia, and pulmonary Langerhans cell histiocytosis, all three of these can be thought of as smoking-related inflammatory diseases. Each of them was named somewhere between 20 and 40 years ago before we knew that. So we used to call things DIP because we thought type 2 pneumocytes were falling into the alveolar spaces. The name has never been changed. We now know that this is an inflammatory response to cigarette smoke. We will talk about these three diseases as representatives of inflammatory cigarette injury. AIP, what was in the past has been called Hammond-Rich. This is diffuse alveolar damage. This is an acute lung injury. It is what you and I would call ARDS. Again, many names for this, an acute lung injury to the type 1 cell. Cryptogenic organizing pneumonia, which is usually a fibrotic organizing response most of the time to an infectious process. The infection is gone, and you are left with a lung which continues to try to repair itself with fibrosis, and you're left with an area of consolidation. And finally, nonspecific interstitial pneumonia. In my practice, the most common fibrotic diagnosis is NSIP. And the one thing I'd like to leave you when you talk about NSIP is that when someone says that to you, you should think, this is the beginning of the workup, not the end. Now, most of the time when I get somebody who says that they have an open lung biopsy, I assume that that is the diagnosis. But you must know better, because this could well be hypersensitivity pneumonitis. It could be they have some form of collagen vascular disease. It could be that they're a smoker and that smoking is related to is causing that fibrosis. Most important, it could be that when they say NSIP to you, that is really IPF, or idiopathic pulmonary fibrosis, and they have biopsied an area which is not specific. At that point, your look at the pattern trumps what they found by open lung biopsy. So with that, in 20 minutes, let's go through all of them. IPF, idiopathic pulmonary fibrosis. In general, older men, they got sick over months. They will tell you that they got short of breath progressively and slowly. Most of them will tell you they were cigarette smokers. The clinicians don't put this as part of the smoking-related interstitial lung diseases, but if you look in the literature, 70 to 80% of the people who have IPF will be smokers. They will have restrictive pulmonary defects. In other words, their lungs are getting smaller, but they're able to blow out all of their air normally. There are other things associated. They have GE reflex and autoantibodies, but they don't make it for the diagnosis of either lupus or rheumatoid arthritis. And finally, the very last thing to remember, the prognosis in patients with IPF is terrible. It is worse than lung cancer. 90% of these people will be dead within 2 to 3 years. There are 2 findings that the pathologists use to make the diagnosis, and I'm going to show you these again to remind you that even though the diagnosis can be made by open lung biopsy, it is not absolutely specific. They look for 2 things, one of which is called geographic variation, which you see here. Normal alveoli next to very abnormal alveoli. Fibrosis next to normal lung. The second thing that they look for is what's called temporal variation, time variation. And all that means is that this pale area which you see here, this fibroblast focus, means that there's a new area of fibrosis being laid down. And next to it are lots of areas of old fibrosis in the lung, time variation. New areas of injury next to old areas of injury. Early on, many of the clinicians thought that the abnormality was really caused by inflammation, but there's no correlation between the degree of inflammatory cells and the progression of disease. We believe that this abnormality is an abnormality of wound healing. Those of you who get keloids, you know there are some people who get a scar on their arm and the scar keeps getting bigger and bigger and bigger, no particular reason for it. Something is happening in the lung where there's loss of control of the repair mechanism, and they believe that that is what is happening in patients with IPF. We do know that if you count the number of these fibroblast foci, that it does correlate with the patient's with how they're going to do. The more fibroblast foci, the worse the patient is going to do. The findings, as Ella so nicely pointed out, if you look at this drawing of one lung, the abnormality is strikingly peripheral. The combination of reticulation, cystic change, and honeycombing is the key. I'll repeat that. Honeycombing for me in the right distribution is really the key for me to make this diagnosis. So if we look at 3 images, the upper lobes are usually involved. Peripheral areas of reticulation, lovely areas of honeycombing, holes with very definite walls. As we work our way down, the abnormality becomes worse. But to appreciate how much worse it is at the bases than is the apex, as Ella so nicely pointed out, you really need to look at a sagittal image. Here you see again that the abnormality is strikingly in the periphery of the lung, and certainly the upper lobe is involved. But as you go down to the base, it is the very lowest slices, the areas in the most dependent and lower part of the lung that are most involved. And whenever you see traction bronchiectasis, you can say there's fibrosis. So if you do a minimum intensity projection of that image, you will note that the airways are markedly distorted. It's much easier to see when I do a minimum intensity projection than in the standard projection of those lungs. But traction bronchiectasis, specific for fibrosis, but not specific for IPF. I'm going to show you that any cause of fibrosis will give you traction bronchiectasis. So, first disease. Is this a case of IPF? Is it more upper or lower? Here is the upper part, here's the lower part. Is it more central or peripheral? Okay, so this isn't IPF. This is a central abnormality that's more in the upper lobes. The reason I show you this case, this was a case from the archive of the AFIP in which it was sent in, and when they looked at it, it was the typical findings of IPF. In other words, they called this UIP. When I looked at this, I said, sarcoid, chronic hypersensitivity pneumonitis, some kind of upper chronic progressive disease. And it turns out that even though the diagnosis on histology was UIP, the final clinical diagnosis was chronic hypersensitivity pneumonitis. So my point to you is this. There are definitely going to be times when the pathologist will say UIP. You and I, as the imagers, need to let them know that maybe there's another diagnosis that's possible. Okay, finished with IPF. The next 3 to 4 diseases we're going to talk about are smoking related. The first 3 are all related to these cells. These are smokers' macrophages. If you put cigarette smoke into the lung, it responds with inflammatory cells. Not a surprise. If a pathologist looks at this, they very quickly can tell you that these very dirty brown macrophages that are filled with iron come from a cigarette smoker. And all of these processes, respiratory bronchiolitis, interstitial lung disease, and desquamative interstitial pneumonia, are all basically a spectrum of injury from cigarette smoke. Unfortunately, the names for these came at different times. And Carrington and Liebau thought that DIP was an early phase of IPF. We now know that that's not the case. So everybody who smokes gets this. Here's one of the small airways. When we say small, usually 1 millimeter, and it has no cartilage. You will notice that there are these these small cells within them, these macrophages. The pathologist will tell you that they know that that this is a smoker. Everybody who smokes gets RB, or respiratory bronchiolitis. About a quarter of those will have changes on imaging, very nicely shown by Martine Remy-Jardin, that when she had people who were smokers, and a lot of them were asymptomatic, about 20% of them would have these small ground glass nodules. And we now know those small ground glass nodules result from those macrophages which are around the small airways. So RB, if you're a smoker, everybody has RB. A small percentage of them will have changes that are upper lobe, small ground glass nodules. A small percentage of those will have symptoms. So everybody who smokes has RB. A small group of those people who have RB will have symptoms that make you think about an infiltrative lung disease. They may have a little bit more fibrosis around in the alveolar walls, but for the most part, this is not a pathology diagnosis. They can't tell the difference between RB and RB-ILD, or respiratory bronchiolitis interstitial lung disease. And we see basically the same findings in respiratory bronchiolitis interstitial lung disease. These people who are short of breath have ground glass nodules that are, for the most part, around the airways. You can get confluence of those nodules so that you get ground glass, which is much more prominent in the upper lobes. Most chronic inhalational lung diseases are upper lobe. TB, histo, silica, sarcoid, emphysema, lung cancer, all of those are upper lobe processes. The lymphatics in the upper lobes are not very good, even though you inhale most of what you inhale into the bases. Most of what stays there is in the upper lobes. So respiratory bronchiolitis, upper lobe, chronic inhalational lung disease. If you get symptoms, it's called respiratory bronchiolitis interstitial lung disease. DIP is just an extension of RB-ILD. Here, the exact same cells, these exact same cells are in the alveolar spaces, not just around the airways. But these are heavy cigarette smokers, and interestingly enough, this is a more acute process that tends to be in the mid and lower lung zones. Usually we see areas of ground glass. There may be some areas of fibrosis, a little bit of alveolar wall fibrosis, but we don't see honeycombing in the main here. Now, before I move on from these two diseases, I want to try to convince you that RB-ILD, and DIP are basically all the same disease. It's just where those cells are. On the left-hand side, this is a highly magnified small airway. In the middle of that small airway, what we see are those dirty brown macrophages. If you show that to a pathologist, they say RB. If you're sitting with them at the microscope, and while they're looking away, you accidentally nudge their slide and just say, go ahead, look again now. If they looked again and saw that most of these abnormalities were out in the alveolar spaces, they'd say, that's DIP. Now, do you really think that with something that's 3 angstroms away with the exact same cells is a different disease? No. The reality is this is all a spectrum of the same inflammatory process. And the typical findings are here. So, in the upper lobes, ground glass nodules. In the lower lobes, diffuse areas of ground glass. These people are smokers. It should not surprise you that when you find things of RB and DIP, that you also find changes of emphysema, holes in the upper lung fields. Now, you'll notice that these holes are very well circumscribed. Now, it is, and I don't have time to go into it, but you can get some fibrosis when you smoke. This is not honeycombing. These are emphysematous spaces with a little bit of fibrosis around them. So RB, RB-ILD, and DIP all start part of the same spectrum. And if we did a coronal reconstruction of this, you can probably see the ground glass nodules, these tiny, small ground glass areas with more diffuse areas of ground glass. This is all one disease. In that same vein, if we talk about smoking-related lung disease, I have added Langerhans cell histiocytosis. It is not in that original group, not in that original article about the interstitial lung diseases, but it fits nicely because people who have pulmonary Langerhans cell histiocytosis are smokers. Men pretty much equal to women. They may have dyspnea or cough. A lot of them are asymptomatic. If we look at the abnormality as far as the histology, we see the most important thing are these Langerhans cells, described by Langerhans himself in the 40s. These are cells that you find in the lung, in the skin, in the gut. And these Langerhans cells with these big nuclei and indistinct cytoplasm are what drives this process. You can think about it. If you inhale smoke, you could get macrophages in the lung. Some people respond with Langerhans cells. It is just another inflammatory response to cigarette smoke in the lung. You also have lymphocytes, and you can have some eosinophils. And here is the main findings in people with Langerhans cell histiocytosis. Most of them start out with nodules. These nodules are airway associated. Over time, there's cavitation of these nodules, and when you see cysts in the lung, for the most part, they are the airways themselves. If the disease progresses even more, you can have cystic spaces with paricicatricial emphysema, so nodules to nodules and cysts to finally diffuse bullous emphysema, upper lobe, inhalational lung disease with inflammation. So if we step quickly through this, the most common abnormality, stellate nodules. They're almost always associated with this small airway that you see here and are represented by these nodules that you would see on high-resolution CT. As the disease progresses, you get cysts, usually well-formed upper lobe, holes in the lung. Some of them have bizarre shapes. Some of them are V-shaped because they are actually the airways. And finally, if the disease continues to progress, you get bullous lung disease that you and I would not make the diagnosis of pulmonary Langerhans cell histiocytosis. But does it matter? This is another smoking-related lung disease, and whether it was Langerhans cells that created this or macrophages that were the inflammatory change, it probably doesn't matter. So, to tie up PLCH, you usually start out with nodules. On the plain film, it's not a surprise that the patient is hyperinflated. They are a smoker. Over time, those nodules are replaced with cysts. And because the cysts may be just under the pleura, about 15% of them will present with a pneumothorax. So if they present with upper lobe nodules alone, you and I are not going to make the diagnosis. We may think about a granulomatous process because it's upper lobe. You could think about sarcoid. You could think about silica. You could think about TB or some other granulomatous infection. If we see just upper lobe cysts, especially if you see these sort of crazy shaped kinds of cysts, then you might be able to think of the diagnosis, but it is really the combination of cysts and nodules. If you look at this, here are well-formed cysts and nodules, which are predominantly in the upper lung fields, on a background of emphysema in a hyperinflated patient, then you can put this all together as a smoking-related inflammatory disease, emphysema with superimposed pulmonary Langerhans cell histiocytosis. That takes care of the smoking-related diseases, RB, RBILD, DIP, and PLCH. Acute interstitial pneumonia, AIP, what used to be called Hammond-Rich. This is what's also known as diffuse alveolar damage. It is what you and I think of as ARDS. There are many terms for this acute lung injury. A lot of these people will have an antecedent flu syndrome, and the mortality rate is high, between 50 and 90%. There are two phases that I want to show you, and they are important because we can see them imaging-wise. There's an acute edematous or exudative phase of AIP or ARDS or DAD, whatever you'd like to call it. This is an alveolar wall, and you will note it is damaged. You will see a hyaline membrane, and that hyaline membrane is a combination of edematous fluid, debris, damaged type 1 cells. You also have some collapse of alveoli in the early phase. If you survive that acute edematous phase, you can go on to what is called an organizing phase. And in the organizing phase, you will note that the hyaline membranes are gone, and in their place are these blue cells which are covering the alveolar wall. These are type 2 cells which are attempting to heal that damaged alveolar space. You'll note the alveolar walls are very thickened, and there are now fibroblasts. Fibrosis is occurring in these patients. Now, this disease involves all 5 lobes. So here the pattern is helpful. We said RB, predominantly lower lobe. DIP, more in the mid and lower lung zones. IPF, strikingly peripheral and along the bases. AIP or ARDS, all 5 lobes. 90% of the lung is involved. You may get a little bit of sparing of the costophrenic angles. The plain film is what you usually see, and I see. When I come in the morning at the University of Maryland, there are 100 films, and people on the ventilator, they all look like this. The patient is ventilated. All 5 lobes are involved. I never know whether this is infection, edema, some form of nonspecific lung injury. I usually vary what I say just to break the monotony, because in reality, it's very hard to know what this is. If you were to take a coronal section, if you could, you would find that the majority of the lung was involved. There is a little bit in the way of sparing here. The vessels are relatively normal. It's probably not edema. There usually isn't anything in terms of there being an effusion. This is a case of proven, open lung biopsy proven AIP, and it's on a background of emphysema, widespread opacity. The reason I showed you this case is if we do some MIP imaging, we can see that the airways are normal. This is in the early phase. That's quite different from somebody who has moved into the organizing phase of AIP. Again, 80-90% of the lung involved, but now look at the major fissure is becoming irregular. There are intralobular septal lines, and if we do a MIP image of this coronal study, we will see that the airways are now becoming very abnormal, distorted, bronchiectatic. As I said, one of the things you can take away from this lecture is that when you see traction bronchiectasis, there is fibrosis in the biopsy. Now, that's not synonymous with saying IPF, but there is some form of fibrosis. So, late phase of AIP going into the organizing and fibrotic phase shown to you by traction bronchiectasis. Cryptogenic organizing pneumonia. This is a response to a prior injury in which you have organization in the alveolar spaces. It is a self-perpetuating injury and then an attempt to repair. Most of the time, it's post-infectious. We see it in connective tissue diseases, malignancies, drugs, even organ transplantation. Again, most of the time, there's been an infection, the infectious agent is gone, and now you have the lung continuing to try to organize something within the alveolar spaces. And what we see are these plugs, or which are called Masson bodies, which are areas of organization of exudate that's in the alveolar spaces, not in the alveolar wall. And the representation as far as imaging is that you and I are going to see areas of consolidation, very different from what I've shown you before. Consolidation. In the ER, 90% of the time, 95, areas of consolidation, infection, 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 infection. Here, if the infection doesn't go away or they treat them and you're left with persistent areas of consolidation, think organizing pneumonia. The most common finding at the AFIP, and I must see 20 cases a week, of somebody who has an area of consolidation is organizing pneumonia. It's a very common response within the lung. These areas of consolidation tend to follow along the bronchovascular bundles. So if we do a parasagittal image, we will see that the abnormality is in the periphery, but not at the absolute periphery. They tend to talk about these diseases as peripheral, and yes, that's true, but I usually find that the absolute periphery of the lung is less involved. I just want to show you this one image before I go on to the last disease, and to remind you that people with organizing pneumonia can present as a solitary pulmonary nodule, and it can look frighteningly malignant. So you have people with this areas of nodules, an old case from the archive, one from last year, and we have this nodule with some spiculation and maybe even a pleural tag. You and I are going to have to be concerned that this is malignant. Just to point out that organizing pneumonia can be very focal. Almost all of these were prior infections. The infection's gone. There's an area of organization. Unfortunately, most of these are going to have to come out. Last disease, and we're done. Nonspecific interstitial pneumonia, first described by Katzenstein in 1994, and she found a group of patients who had fibrosis that did not fit into all those other diseases I talked to you about, IPF, RBILD, DIP, OP, or even the fibrotic phase of acute interstitial pneumonia. A lot of these people had collagen vascular disease. The most important thing is that in general, they had a better prognosis. Now, there are three categories, either cellular, fibrosing, or mixed, and a lot of these have organizing pneumonia in addition that complicates it. The only thing I want you to remember is that these people can have a lot of fibrosis, and the more fibrosis they have, the worse their prognosis, and their prognosis can be very similar to IPF if they have a lot of fibrosis. As I said, I wanted you to remember that if somebody says NSIP to you, it is the beginning of the workup and not the end. Because when the physicians and radiologists at the Mayo Clinic looked at patients with NSIP, they found that a third of them had imaging that was absolutely diagnostic for IPF. So some of these people really have IPF and they haven't been able to biopsy the right area. Some of them had hypersensitivity pneumonitis. Some of them had organizing pneumonia. So within the diagnosis of NSIP are multiple other diagnoses. And this is confirmed by Andrew Nicholson, a very well-known pathologist from the Brompton, who says when he says the NSIP pattern, he thinks about these. Sampling error in patient who has IPF, someone who's just a smoker and's got a little bit of fibrosis, someone who has hypersensitivity pneumonitis, it may be post-infectious, it may be related to collagen vascular disease. The typical findings are areas of ground glass and maybe a little consolidation along the bronchovascular bundles in the lower lobes. If we look at the CT, ground glass, reticulation, predominantly at the bases, but no honeycombing. The best way to separate IPF from NSIP is the presence of honeycombing. It's not perfect, but people have honeycombing, think IPF. You see no honeycombing, all you can say is fibrosis. Now, how do we know this person has fibrosis? Again, I find the MIP imaging very helpful. Here we see, again, traction bronchiectasis buried in the areas of ground glass. There is no doubt in your mind or mine that this person has fibrosis, but it doesn't make it for the diagnosis of IPF. There is no honeycombing. And I just wanted to say one more thing before we close, and that is that there are people who have organizing pneumonia, biopsy proven here, who can go on as they begin to heal to have changes that 6 months later are basically called NSIP. So one of the healing routes from OP is NSIP. So let's tie this all together. People who have IPF have predominantly peripheral abnormalities with reticulation and honeycombing. The smoking-related lung diseases, respiratory bronchiolitis, those macrophages around the small airways give you ground glass nodules that are predominantly in the upper lobes. RB, RBILD, and DIP are all in a spectrum. The only difference is that DIP will include some ground glass down at the bases. Pulmonary Langerhans cell histiocytosis, another smoking-related disease. Nodules. Starts out as nodules around the airways. Over time, it becomes nodules and cysts. Those cysts are actually the airways. You can end up with terrible bullous emphysema, but that's a late change. AIP, all 5 lobes. This is basically ARDS. As they go into the fibrotic phase, they get traction bronchiectasis. And finally, organizing pneumonia, areas of consolidation. And NSIP in the literature is basically ground glass more at the bases. But remember, when somebody says NSIP, it might look like IPF to you, at which point it really is IPF. It could be they're just a cigarette smoker with some well-circumscribed holes. It could be hypersensitivity pneumonitis, and it could really be organizing pneumonia that's gone on to NSIP. I've gone over by a couple of minutes, so I'm going to stop and move on so we have time for Dr. Bankier, who is going to talk to you about emphysema. Thank you very much.
Good afternoon. In the following 30 minutes, I will try to answer the following questions. What is pulmonary emphysema? Why is this an important disease? How do we image pulmonary emphysema? What do we see? How much of the disease do we see? And what about the context, the medical context of pulmonary emphysema? So first, what is pulmonary emphysema? Emphysema is defined as an abnormal permanent enlargement of the air spaces distal to the terminal bronchioles, accompanied by destruction of respiratory tissue and without fibrosis. This is the definition that you will find in the textbooks. The important element about this definition is that emphysema is defined in strictly anatomical terms. When we talk about emphysema, we don't talk about primarily clinical presentation or physiology or lung function. Here we are really in anatomy and in morphology. The key concept of the definition of emphysema is destruction, irreversible destruction of lung parenchyma. And as this house is destroyed by a storm, so will the lung parenchyma be eventually destroyed, completely destroyed by pulmonary emphysema. The definition of emphysema is based on microscopy. We see reflections of emphysema in macroscopy and in radiology, but whenever we talk about emphysematous changes, we should try to relate microscopy, macroscopy, and radiology. And in fact, most of the substantial research about emphysema is about the interrelation between changes seen in radiology, macroscopy, and microscopy. This is a normal lung on microscopy. This is a microscopic specimen of a patient with emphysema. The key feature is the destruction of alveolar walls, the irreversible destruction of lung tissue. The same at a different level of magnification, a gross pathologic slice of a normal lung, and here a section of a patient with emphysema. Again, changes congruent with irreversible destruction of lung parenchyma, and finally, at yet another level of magnification, normal lung on this coronal reconstruction and irreversible destruction of lung parenchyma by emphysema. We are basically looking at the same thing, but at different levels of resolution and at different levels of magnification. Why is emphysema important? There are about 2 million cases of pure emphysema among the community of patients with chronic obstructive pulmonary disorders. More importantly, the extrapolations for the future, for the year 2020, say that emphysema will get an even more important role, both as a cause for morbidity and a cause for mortality. Emphysema also is a very expensive disease. Here are recent features from Europe. Emphysema, for example, causes costs of 1 billion pharmaceutical expenses in Europe. If you want to have the figure in US dollars, you just multiply these numbers by 1.5. So this is a tremendously expensive disease. What are the risk factors for emphysema? These risk factors are well known for a very long time. One of them is environmental pollution. Another one of them is dusts to which certain professions are exposed, coal miners, for example, but also dentists. The use of cosmetic aerosols have also been accused to be causative of pulmonary emphysema. Fortunately, I personally don't need this anymore. How do we image pulmonary emphysema? When we talk about the imaging of pulmonary emphysema, we mainly speak about CT. Why? Well, first, because the conventional radiograph is quite insensitive in detecting emphysematous changes, notably if they are not very advanced. And on the other hand, MR suffers from relatively poor spatial resolution in the depiction of emphysematous lesions. Although we have been introducing multi-detector CT and other techniques in the past decade, the key technical parameters for imaging emphysema are known since quite a long time. First of all, if emphysema is suspected, we need to perform thin sections, meaning sections between 0.5 to 1.5 millimeters in collimation. We need to image the patients in full inspiration. Expiratory scans in pure emphysema are of very little help. We do not need to give the patient contrast material, and recent studies have shown that we can considerably reduce the patient dose and still obtain adequate levels of diagnostic accuracy when we're looking for pulmonary emphysema. There are other additional techniques that we can use to enhance the visualization of emphysema. One of them has been shown by Dr. Galvin before. This is the minimum intensity projection technique as presented in emphysema by Martine Rémy-Jardin. She proved that this technique helps to detect mild forms of emphysema, as shown here. On the very left, you have a conventional HRCT section, and on the very right, you have this minimum intensity projection that indeed reveals lesions that were not visible on the conventional image. This slide is to illustrate what I said before. When looking at this radiograph, you might suspect that there are some very subtle abnormalities in the region of the aortopulmonary window or in the region of the paratracheal area on the right. But just looking at the chest radiograph, you would probably never suspect how extensive these emphysematous lesions in fact are on the CT image. So conventional chest radiography really suffers from sensitivity in detecting emphysematous changes. The radiographic signs and the CT signs of pulmonary emphysema are relatively limited and relatively typical. We see disruption or distortion of vascular structures. We see an increase in lung transparency on the radiograph, or a focal decrease in lung attenuation on the CT image, and we see focal destruction of lung tissue. So again, on the radiograph, distortion of vascular structures, an increase in transparency, a decrease in lung attenuation, and focal areas of lung destruction. These are the most important findings for pulmonary emphysema. In textbooks, notably of the older generation, you might find things stating or passages stating that the classical radiographic signs of emphysema are the flattening of the diaphragms, the increase of the interrib spaces, the increase in the retrosternal space or in the retiocardiac space. These in fact are not typical radiographic signs of emphysema, but are rather signs of the obstruction and the overinflation of the thorax that can accompany emphysema, but that does not necessarily accompany emphysema. So these changes are that were previously called the classical radiological signs of emphysema are in fact the result of overinflation, and you might find overinflation in other diseases such as asthma and a lot of other diseases that do not have anything to do with pulmonary emphysema. What do we see in pulmonary emphysema? According to the destruction of the lung parenchyma and the pattern and the distribution of the changes in the lung parenchyma, we can differentiate two important subtypes of emphysema, and these two subtypes are the so-called centrilobular and the so-called panlobular emphysema. In centrilobular emphysema, we see focal spots of lung destruction. Immediately neighboring these spots of lung destruction, we have normal or almost normal lung parenchyma, and the bronchial and vascular structures in these areas of parenchyma are preserved. They are not destroyed. This is the corresponding section in a paper-mounted section. We see that these areas are focal areas of destruction, but you also can see that this hexagonal shape of the secondary pulmonary lobule, although the entire parenchyma inside is destroyed, the shape of the secondary pulmonary lobule is still preserved. And the same is seen on CT images. We see holes in the lung without walls. These holes are, the border of these holes is normal lung parenchyma, and if we look for the secondary pulmonary lobule, we will find this anatomic structure, and in most cases we will also find the central core structures in the secondary pulmonary lobule. Even if centrilobular emphysema is very far advanced, we still will be able to find the secondary pulmonary lobule in these patients. So in centrilobular emphysema, the well-defined holes give the pattern of destruction a heterogeneous appearance because the holes are just neighboring normal lung parenchyma. The structures of the secondary pulmonary lobule are preserved. This is the classical manifestation of emphysema in cigarette smokers. It has a clear upper lobe predominance, and there are some focal manifestations of centrilobular emphysema that are mainly related to dust inhalation. The second type of emphysema is panlobular emphysema. Here, the pattern of destruction is much more widespread. There are some very sparse area of lung parenchyma around, but in most instances, this lung parenchyma is not normal, and the vascular and bronchial structures tend to be either destroyed or disrupted. This is the gross pathology section, the paper-mounted section. We see that we don't find the structure of the secondary pulmonary lobule anymore, and the visual impression is that the pattern of destruction is much more widespread, much more diffuse than in centrilobular emphysema. And finally, this is what we also see on CT. The process is very widespread. Other than in centrilobular emphysema, we cannot exactly tell where the process starts and where the process ends. It more looks like an effacement of lung structure, as if somebody would have just erased, just rubbered part of the lung parenchyma. And these are just two other cases that illustrate this very diffuse appearance of panlobular emphysema very well. So panlobular emphysema has a very homogeneous pattern of destruction. The structures of the secondary pulmonary lobules are destroyed. In most cases, panlobular emphysema will be associated with alpha-1 antitrypsin deficiency. The distribution of the destruction is rather diffuse and can have a lower lobe predominance. There are patients in whom you will find both types of emphysema. This is such a case, such a patient that has centrilobular emphysema, centrilobular lesions in the upper regions of his lung, and panlobular areas of destruction in the lower part of his lung. So finding both patterns in one patient is a thing that is not uncommon. There are also patients that will have emphysematous lesions and fibrosis, like here. On the left you see fibrosis on the basis of the lung, and on the right emphysematous lesions in the apex of the lung. And you will remember what I said in the beginning. The definition of emphysema ends with that this is a destruction of respiratory tissue but without fibrosis. Here we have to remember that the definition of emphysema is based on histology, and this definition is not incorrect and applies to the pathologic or histologic context, and is not invalid just because fibrosis and emphysema may coexist on a radiological level on a level of less magnification. So it is also relatively common to find patients with lesions corresponding to emphysema and lesions corresponding to pulmonary fibrosis on one CT examination. There are other subtypes, so-called subtypes of emphysema: soft tissue emphysema, bullous emphysema, paracicatrisal emphysema. I just put this into brackets: paraseptal emphysema. Often the term emphysema is used as a synonym for pathologic accumulation of air. But this does not match with the very definition of emphysema that I show you here again. It is clear that in so-called paracicatrisal emphysema, there is scarring, there is traction on the lung parenchyma, there is distension of the lung parenchyma, but this is not really congruent with the very stringent histologic definition of emphysema. This is so-called soft tissue emphysema. It is clear that there is pathologic accumulation of air in the soft tissue, but this has nothing to do with lung emphysema as according to the definition of emphysema. How much emphysema do we see? This is a question that has become increasingly important in the recent years, just because emphysema is more and more considered as a treatable disease. There is the possibility of lung reduction surgery. There are new drugs on the market. There are devices such as these endobronchial valves that can be implanted in patients with emphysema, or little artificial fenestrations of obstructed lung parenchyma. And for the planning of all these therapeutic interventions, it is important not only to know that the patient has emphysema, but also how severe his emphysema is. One way to assess this is by subjective assessment. There are widely used grading systems. These grading systems grade emphysema according to the extent. This is presumed to reflect severity. These grading systems show good correlation with pathology. However, they may underestimate mild emphysema. When comparing subjective and objective quantification, it has been shown that subjective quantification tends to overestimate emphysema and has a higher interreader variability. This is why, in a more scientific context, it's probably desirable to have an objective approach to the quantification of emphysema. Anyway, the subjective and objective quantification of emphysema answer to different questions. Subjective quantification of emphysema is based on correlations and answers to which degree the extent of emphysema is linked to the extent of emphysema assessed by a given reference method. And in objective quantification, we look for identity and try to answer the question to which degree is the extent of emphysema identical to the extent of emphysema, for example, in pathology or in microscopy. How does the objective quantification of emphysema work? This is rather straightforward. Many products on the market just segment the lung out of the thorax. They quantify the Hounsfield values for each given pixel, and then they will compute the distribution curves of the different densities, the so-called histogram. This would be a normal distribution, a normal histogram, and because in emphysema we have more values with low attenuation, the histogram curve in emphysema is typically shifted to the left. There are different approaches that quantify emphysema by using this histogram, by using a certain percentile of these distribution curves, either the lowest 5 percentile or the lowest 12 percentile. The problem with that is that there is little CT microscopic correlation for this approach, and as you will easily understand, there is a problem of coexisting pathology. This method works well if the patient has only emphysema, but for example, if you have a patient like this is the same patient than before that has emphysema in the top of the lung and fibrosis in the basis of the lung, then The emphysema will shift the histogram to the left, but the fibrosis will again shift the histogram to the right because of the higher density, and this will falsify your objective quantification of emphysema. Therefore, other authors have proposed to choose a single threshold value, a threshold of density, and they say, for example, that all values between the threshold of minus 950 Hounsfield units will correspond to emphysema, and these computer programs can then quantify exactly to how much percentage of the lung parenchyma this will correspond. There have been different thresholds proposed in the literature. The oldest one is from Dr. Müller and co-workers. Then there was one in the mid-1990s proposed for thin section CT, and very recently there has been another threshold proposed in the literature, which is minus 960 to minus 960 to minus 970, and this is a valid threshold for multi-detector CT imaging of pulmonary emphysema. The final point, what about the context of emphysema? Emphysema belongs to what is clinically called the chronic obstructive pulmonary disorders. Emphysema, as we saw, is a disease of the lung parenchyma. However, COPD in general also has contributors that is located in the airways due to airway inflammation and airway wall remodeling, and in the vascular due to structural thickening. And the clinically important and relevant question to ask is, how do these three contributors, to which extent do these three contributors cause the airflow limitation and the gas exchange abnormalities that we see in COPD? And here CT might be very helpful, because CT indeed allows us to visualize at least two of these potential contributors, for example, lung parenchyma and airways. There are a number of studies published that did look simultaneously at the airways and at the lung parenchyma. This is very straightforward. You know all from your daily practice that on thin sections we see the airway structures very well. Let me just give you two examples of those studies. One comes from Italy. They found that bronchial wall measurements and lung attenuation measurements allow to differentiate patients with COPD that have chronic bronchitis, which in many instances is reversible, and those that have no chronic bronchitis, meaning that the COPD contribution comes from emphysema, which is an irreversible destruction. And in fact, these two different groups of patients have differences, significant differences in lung attenuation. Another study that comes to similar results comes from Great Britain. They tried to identify various patterns of emphysema, various distribution patterns that would be linked to airflow obstruction and gas transfer abnormalities. They found that not only the extent of emphysema, but also the distribution of emphysematous lesions in the lung is something that is very important. So in the future, we will have to look not only at the overall extent of the disease, but also at the distribution and at the different patterns of emphysema. Another way to approach the thing is to look simultaneously at the lung parenchyma and at the lung vasculature. We are currently studying this approach. We image the patients with emphysema without contrast material. We measure lung attenuation, but then we give the patient a contrast material and perform these perfusion maps, and we are hoping to find how the parenchymal destruction matches or does not matches with impaired perfusion, and we try to get important or hopefully important information from the longitudinal evaluation of these parenchymal and perfusion abnormalities that we see in these patients. So in summary, we were talking first about the definition of emphysema. This is purely morphological. We were talking a little bit about the epidemiology of emphysema. I briefly talked about the technique of pulmonary emphysema. We discussed the two important entities, which are centrilobular and panlobular emphysema. I briefly discussed the problems of the quantification of emphysema and why this is becoming increasingly important. And I tried to place emphysema in the context of the clinically important entities called chronic obstructive pulmonary diseases. How will the imaging of emphysema evolve from here? We will surely progress from a mere quantification to the mapping of emphysema, including distribution patterns and clusters of distribution. We will surely make a step from the quantification of emphysema to the more integrative imaging of COPD by assessing bronchial morphometry, by assessing the pulmonary vasculature, and by attempting the so-called phenotyping of emphysema by means of imaging. And finally, we will move from static to a more dynamic imaging with the new technical advantages that we have. Thank you very much for your attention.
Hi, my name is Elizabeth Y, and I'm here to talk about a basic approach to interstitial lung disease. The goal of the next few talks will be to understand some basic thoracic imaging anatomy and terminology, and to provide information for a clinician that's useful when encountering a request on a CT form for evaluation of interstitial lung disease. And then finally, to understand some of the basic differences between some of the more important chronic fibrosing interstitial lung processes. It's important when understanding that with interstitial lung disease, it refers to a broad range of conditions that have a common clinical, physiologic, and radiologic features. However, they all involve abnormalities within the respiratory interstitium, which is a potential space between the respiratory epithelium and the capillary endothelium. It does not necessarily mean that they share a common histopathologic and physiopathologic basis. When we break this down into the idiopathic interstitial pneumonias, subsetted as IIPs, this is a subset of the interstitial lung diseases that's a heterogeneous group of diffuse lung diseases without a known cause. And it's usually associated with differing degrees of inflammation and fibrosis within the respiratory epithelium. This is where we get the terminology IPF, NSIP, cryptogenic organizing pneumonias, acute interstitial pneumonias, desquamative interstitial pneumonia, and respiratory bronchiolitis. So it's important as a radiologist that we are describing the histologic patterns and not the clinical diagnosis, which is really made by the clinician. So we should aim, when we read a CT of the chest, to describe what pattern histologically the radiologic findings look like. So as for the terminology on the left, we should really be saying that things look like usual interstitial pneumonia and not assign somebody with the clinical diagnosis of, for example, IPF or idiopathic pulmonary fibrosis. So first, we're just going to go over some really basic interstitial lung terminology to better understand how to describe CTs. First, it's important to understand that when we talk about the interstitium of the lungs, there's actually three components of the interstitium. The first component is the interstitium that lies along the bronchovascular portion of the lung, and it's known as the axial interstitium. And this is the interstitium that supports the bronchi, the arteries, and the central veins as they extend from the hilum all the way down to the respiratory bronchiole. And it's seen on the image on the right. We see where the artery and the bronchial airway is. We see that the axial interstitium is the interstitium that sits along there. Also in this picture, we see the subpleural or connective tissue interstitium, which is contiguous with the interlobular septa. And that's where we see the interstitium that lies along the venous aspects of the interstitium. And then we talk about the parenchymal or acinar interstitium, which is the interstitium that we see on a microscopic level, which is the space that's situated between the actual respiratory epithelium and the capillary endothelium near the capillary basement membranes. So this space within there that has all sorts of proteoglycans and different lymphatic cells that provide support for the tissues at a microscopic level. So it's important to understand when we talk about interstitial lung disease, we have changes at all three levels. Next, we'll talk about the interlobular septum, which is part of what we talk about when we reference the secondary pulmonary lobule, which in the superior parts of the lung have a more hexagonal appearance and look more uniform, but as you go more centrally towards the lung, the secondary pulmonary lobules become less regular. It's along the periphery of these secondary pulmonary lobules that you have your venous and lymphatic channels that can swell or become fibrotic, and they become thickened on a radiograph. And that's what we're seeing on the left. This is just an example of pulmonary edema where we have nice thickening of the interlobular septum in the lung apex. The next thing we talk about is the intralobular lines, which are small, fine lines that are inside the secondary pulmonary lobules. And so on the image on the right, we see that there's what looks like a fine reticular pattern almost on the medial aspect of the lung base. And when they're numerous, we call this a reticular pattern. And in reality, this is just thickening of the interlobular lines. When we refer to crazy paving, a common radiographic finding with certain entities, this is a combination of both thickened intra and interlobular septa. So as we can see on the image on the right, we can see that there are thickened hexagonal appearing structures which are parts of the secondary pulmonary lobules, but within it we can see smaller lines faintly among the ground glass, which is what's reflecting the interlobular septa, and it's part of the crazy paving pattern. This pattern was originally described with alveolar proteinosis when it's diffuse in the lungs. However, we've now determined that a crazy paving pattern can actually be seen with many different processes. A reticular pattern, when we use that terminology, it was first described on chest radiograph. And when we saw it, it was kind of this diffuse, small, linear opacities that kind of produced a net-like appearance. We've translated that definition onto CT, and it now can represent, when we look at it on a CT scan, these small, thin lines. We usually see them in the periphery, but in reality, they can either represent interlobular septa, interlobular lines, or cystic walls. A cyst, by definition, is any round circumscribed space that is surrounded by an epithelial or fibrous wall. Typically, thin wall cysts have walls that are less than 2 millimeters in size, and they normally contain air but can be superinfected or have fluid or solid material with them. This is just a nice example of LIP, where we see these small thin wall cysts within the lungs. So a cyst is just a clear space with a thin wall around it when we're speaking about interstitial lung disease. Traction bronchiectasis and bronchiolectasis is just irregularity within the bronchial and bronchiolar portions of the airways. And we call it traction when it's related to underlying fibrosis, usually related to fibrin or fibroblast deposition along the airways that eventually contract and cause the airways to rip and pull apart, which is why we see a very tortuous, serpiginous, irregular appearing wall. Once we see it extend out to the periphery, as we do in the basilar portion of the right lower lobe on this image, we can start calling it bronchioles, the more distal airways. And finally, I just want to discuss honeycombing. The actual definition of honeycombing has changed over the last 30 years in the literature. Now, the definition we use is a clustered cystic airspaces, typically of comparable diameter, but occasionally, they usually range somewhere between 3 and 10 millimeters, but can range all the way up to 2.5 centimeters in size. They're usually subpleural, and they're defined by very well-defined walls. So, when we talk about honeycombing, the real important thing to notice is that it's usually cystic air spaces that share walls and abut the peripheral part of the lungs. We most commonly, with interstitial lung disease, see it in the lung bases. But it's important to realize that what we see macroscopically on a radiograph is not the same thing as microscopic honeycombing that is described on a pathology report. So this is just a beautiful picture of honeycombing within the lungs. We see nice thin wall cystic structures that are stacked on top of one another. And as I said, the definition has changed over the year, but it's a very important feature when we begin to discuss UIP. It's a very defining feature in UIP. Very occasionally can be seen with NSIP and DIP type pictures. And again, it's that subpleural it's most commonly seen in the subpleural and posterior bases, particularly when we talk about the entity IPF. What's important to realize is what we see, what appears cystic in the periphery of the lungs, isn't always actual true honeycombing. And this was just a beautiful example of sometimes when you have someone who has emphysema that sits peripherally in the lungs, as we see on the image on the left, when someone has a superimposed acute decompensation of their heart failure, for example, or superimposed infection, sometimes the wall around the emphysematous spaces can begin to become more defined on CT. And you can artificially get the look of a cyst on top of a cyst, as shown in the picture on the right. But in reality, this is just an exacerbation of heart failure on top of emphysema. So sometimes distinguishing true honeycombing from other etiologies can be quite difficult. It's important to realize that when we speak about what honeycombing is, honeycombing really defines the end stage part of disease. But you don't go from normal lung parenchyma to the end stage part of a disease. There's usually a progression that leads to an area of honeycombing. So there's been some description in the literature that typically we start off with an area of peripheral ground glass, maybe a little bit of subtle reticulation within a secondary pulmonary lobule. Over time, we get a decrease in the amount of ground glass peripherally, and you begin to see more reticulation within the lungs in areas of bronchiolectasis and bronchiectasis, and then it ends up turning into honeycombing at that point. And from that honeycombing, you can have smaller cysts that then become larger over time, but we're talking about a process that takes a progression of years to actually ensue. So when you see honeycombing, that usually means we're at the end stage part of a fibrotic process. So now quickly we're going to start talking about the interstitial pneumonias. When we talk about the idiopathic interstitial pneumonias, they're all characterized by alveolar involvement and usually involve the surrounding airways. Fibrosis or cell deposition is usually seen at the level of the alveolar space. With all of the interstitial lung diseases, it usually refers to something that has a restrictive lung physiology, which by definition usually means that there is decreased lung volumes as the lung cannot normally expand, which gives you that restrictive physiology. Typically, the idiopathic pathologies can either be subacute or chronic and can progress anywhere from the course of weeks to the course of years. But it is very important to understand that interstitial lung diseases, although they involve the interstitium, they are not confined to the interstitium, and they almost always start at the level of the airspace. So again, back to the original slide, as a radiologist, we should aim to look at the histologic pattern and describe what we believe we'll see on histology and not assign that idiopathic diagnosis. So in 2012, there have been a few revisions of this classification. There was reclassification of how we look at interstitial lung diseases, and we've broken it down into chronic fibrosing interstitial lung diseases, which is the big players that we always commonly think about, which is the clinical diagnosis of IPF. The fibrosing forms are UIP and NSIP, and that's where we as radiologists can really make a difference in helping diagnose the disease so the patient can receive better treatment. The second classification we talk about are the smoking-related interstitial pneumonias, which encompass respiratory bronchiolitis and desquamative interstitial pneumonia. And then the acute and subacute processes, which are your organizing pneumonias and your diffuse alveolar damage. And then there are a few rare entities. We speak of LIP. That's been known for years, but recently in the literature we have described and have seen a few cases of a new entity, pleural parenchymal fibroelastosis, which has creeped onto the interstitial lung disease categories. When we're looking at interstitial lung disease, when you have an idiopathic form of disease, just so you know, the frequency that you'll see on a request. Usually, most of what you will see on someone who has no known diagnosis of interstitial lung disease, about 40% of them will end up with a UIP type pattern. But when you break it down, NSIP will be about 20%. Your smoking related interstitial lung diseases will comprise about 20% of the population on your idiopathic forms. Then your organizing pneumonias are about 10%. Your diffuse alveolar damage, or the disease process we know as AIP, is about 10%. And then your LIP and PPFE, which is your pleural parenchymal fibroelastosis, are very rare and not commonly seen. Unfortunately, one of the very difficult things for radiologists is when we're not able to give an exact diagnosis on a CT. And one of the very frustrating things about interstitial lung disease, and what probably scares a lot of radiologists away from wanting to read the studies, is that there is a lot of overlap between the histologic look of the disease and what we see on chest CT. So it's important to understand that UIP and NSIP can have a lot of overlapping features histologically, which means that they can also have overlapping features when we look at it on a radiograph. So taking this whole concept into consideration, it's important that when we describe a CT that we talk about different sorts of features that would lead your diagnosis towards or away each of these features. But just understand that there is a lot of overlap, which makes it a very frustrating disease to diagnose on CT. So thanks for listening to the first part where we described a little bit of the terminology and features that we're going to be describing with interstitial lung disease. And next week we'll come back and we'll start actually talking about some of the different fibrosing interstitial lung diseases and start off with usual interstitial pneumonia. Thank you. Welcome back. We're here today again to talk about the second portion of the interstitial lung disease talk. And today we're pretty much going to focus on usual interstitial pneumonia and the imaging characteristics we see with usual interstitial pneumonia. There's a wide diagnosis or differential diagnosis for the UIP type pattern. When we don't know the cause of it, we call it idiopathic IPF. And again, as we said on the earlier lecture, we as radiologists really shouldn't make the diagnosis of IPF, but more tell the description of what kind of imaging pattern we see. Other causes of a UIP type pattern include collagen vascular diseases, especially rheumatoid arthritis and scleroderma. Those are the more common ones that give you a UIP type pattern. Asbestos, chronic HP can have some overlap with the UIP type pattern. Chronic drug reactions. There's an unusual presentation for familial pulmonary fibrosis. It doesn't always look like your normal pattern of UIP. And then there is overlap with what we know as fibrotic NSIP. So when we talk about the clinical presentation of somebody with idiopathic pulmonary fibrosis, typically they tend to be male predominant in an older age group. Usually somebody we see their presentation coming in their late 60s, early 70s with a large amount of restrictive lung disease. They usually have a positive smoking history. About 75% of patients with IPF have a strong prior smoking history, and survival is typically better in those patients that have not had a positive smoking history. Usually it's a pretty gradual onset, and unfortunately we don't see these patients present to clinic until their lung restriction is much worse, so it's a very difficult disease to treat. On radiology, the distribution, we're really looking for a lower lobe predominant process. And it tends to always involve the peripheral parts of the lungs. So the findings we really want to focus on is whether there's reticulations, traction bronchiectasis, honeycombing, and there should be a relative paucity of ground glass opacity seen within the lungs. So this is our first case. We're going to start with just some plain radiographs. This is a 61-year-old gentleman who came in with progressive dyspnea. On his history, he had actually had shortness of breath that was gradually increasing. And we see on these radiographs on the frontal view, there's quite a bit of volume loss seen in those lower lobes. We can see that the inferior hyla are being tucked down as the lung volumes are decreasing, and there's a lot of reticulation and almost a bubbly appearance, or what we like to call bronchiectasis. On the lateral view, you can see that a lot of the reticulation and more cystic appearing look we see involving the posterior sulci. The correlation of this on CT is when we look at these MINEP images, we see that there's a lower lobe predominant bronchiectasis that extends out to the periphery of the lungs with areas of peripheral reticulation. On the lateral view, we can really see areas of early honeycombing starting in the posterior sulci, or concentrated primarily in the posterior sulci. This is a very, very classic look for a UIP type pattern secondary to IPF. So the prior case we saw was a very classic appearance of UIP. The next case I'm going to show you is a presentation of a UIP type pattern that's not as prominent as we saw in the last one. So on the radiograph on the left, we see that there is a little bit of volume loss. You can see the hyla are being tucked down and pulled medially. And we can tell that there's some fine reticulation in the lower lobes. On the correlate for the CT, we see that there are areas of traction bronchiectasis, but the very key thing here is we see mostly peripheral reticulation, and maybe on this one image we can see some early honeycombing, especially along the left diaphragmatic surfaces. When we look at the correlation of the lateral radiograph, we see that all we really see is this increased density over the region of the posterior sulci. But when you take the correlation for CT, we see that there is quite a bit of reticulation and some areas of bronchiectasis, but not a lot of honeycombing that we classically see. And this is a more early presentation of a UIP or IPF pattern. Again, this is just very classic look for a typical UIP type pattern. So again, it's a lower lobe predominant process. We see areas of peripheral reticulation. There are some areas of traction bronchiectasis and some potential areas of honeycombing, especially on the image on the right, the right upper portion of these four images. You can see areas of cysts stacked on top of cysts, but it involves the bilateral lung bases, and it is a symmetric process. Of note, there's really not a lot of ground glass opacities, which is one of the things that we're looking for with a UIP type pattern. So honeycombing is the diagnostic feature that we really want to see to slam dunk the diagnosis of a UIP type pattern. We see it in 70 to 80% of cases of UIP, and it is the strongest predictor of a UIP type histology. Interestingly, honeycombing with UIP is more the end stage part of UIP. So once you hit the honeycombing stage, your mortality is about 2.1 years. UIP without honeycombing is the earlier stage of UIP, and the survival after that is at that point is about 6 years. So in 2011, the American Thoracic Society and European Thoracic Societies came up with an algorithm that clinicians should follow in a patient with suspected IPF. First, what they need to do is figure out is whether there's any other identifiable causes for the interstitial lung disease, whether the patient has risk factors for collagen vascular disease, prior exposures to asbestos. If they can't find any other, if they have another identifiable cause, it's not IPF by definition. So we classify that as not IPF. But if there is no unidentifiable cause, then they move to high-resolution CT. And at that point, this is where the radiologists can come in and play a huge role. So we want to look on the radiographic findings to see if we see imaging findings that are characteristic or consistent with UIP. If they're consistent with UIP, no identifiable cause, the patient's given the diagnosis of IPF. But if there are some features that are slightly questionable or don't fit the classification for UIP, we call it an either possible or inconsistent with UIP, and those are the patients that need to eventually go for biopsy if further workup is requested. So this is an example of a definite UIP type pattern. We see somebody that has a lower lobe predominant process with peripheral reticulations, a relative paucity of ground glass, and honeycombing. So we would call this a definite UIP type pattern, and this patient would not have to go to biopsy. This is some examples of what we might call a possible UIP pattern. On all of these images, we see that on the image on the left, we have areas of bronchiectasis, but there's a little too much ground glass. That's a little inconsistent with a UIP type pattern. The image on the right upper part of the slide shows again some definite peripheral reticulation. Everything is hitting the periphery of the lung. Maybe some start of some bronchiectasis or potential early honeycombing, but again, too much ground glass. And the image on the lower end shows a little bit of mosaicism within the lungs, definitely areas of reticulation, but it's also somewhat patchy in appearance. And then findings which are inconsistent with UIP include whether it's an upper lobe predominant process, if we see peribronchovascular predominance, whether we see too much ground glass, so more ground glass than reticulation, nodules, cyst, areas of diffuse mosaicism, or consolidations involving segments or lobes. All of these imaging features are suggestive for potential other causes of UIP, whether it's a collagen vascular disease, whether it's related to HP or other etiologies. So complications with IPF and with any of the UIP type patterns is respiratory failure. Once a patient is given the diagnosis of IPF, usually the mean survival is somewhere between 2 and 4 years because, as I said, it's usually end-stage restriction within the lungs. And unfortunately, there's really no good treatment outside of lung transplantation. Survival if you have UIP related to a collagen vascular disease, your survival is much better. About 10 to 20% of these patients will end up with lung cancers, so you have to be very careful and vigilant about screening them. About 10 to 20% of the patients will end up with acute exacerbations or accelerated IPF fibrosis stages. And then there's this very weird phenomenon called pulmonary ossification that we see in about 7% of the patients. So this is a nice example of how fibrosis progresses in the lung. In 1999, when the patient started having shortness of breath, we see that there are areas of a little bit of peripheral reticulation and maybe some areas of bronchiectasis starting. But by 2008, as the patient has represented, we see that we've had marked progression of areas of bronchiectasis. We have honeycombing and a lot of reticulation. And as we progress to 2010, we see that some of these cysts are actually getting larger in size. So this is very characteristic of what we see for progressing fibrosis. So as I've mentioned before, there is an increased incidence of lung cancer with IPF. About 10 to 20% of patients with IPF will develop a lung cancer if they live long enough. And a lot of that has to do with the fact that there is an increased smoking risk within these patients. This is a nice example of a mucinous BAC that developed over the course of 2 years from an opacity that didn't go away in somebody with underlying UIP. And it's often very difficult to differentiate areas of fibrosis and inflammation from lung cancer. So these patients, we should really be doing 3-month follow-up exams whenever you see a consolidation or nodule that's not going away. There's a phenomenon called acute exacerbation, which is known as the accelerated phase of IPF, and it's often a diffuse alveolar damage that is superimposed on top of the underlying fibrosis, and it can occur along with organizing pneumonias. And what we'll see is diffuse ground glass typically in the areas of fibrosis, but it's very important to rule out other causes of ground glass, which include both edema and hemorrhage and infection in patients with IPF before you're given the diagnosis of an acute exacerbation. Once there is no identifiable cause, and we call it accelerated phase, there's a very high mortality that goes along with it. And then the phenomena, the dendritiform pulmonary ossification, we see that in the lower lobes, typically peripherally, we'll see these areas of little calcifications that are forming, and they are actually islets of little bone marrow, or there are calcifications that have bone marrow cells within them, and the clinical significance is not really known. So just again to kind of hit home, there are IPF is when we don't have a cause for it, but other things that can cause a UIP-type histology, collagen vascular disease, hypersensitivity, pneumonitis, asbestos, and other familial diseases. We should always look for secondary findings on radiograph. So when you see somebody with underlying interstitial lung disease and you think they have a UIP-type pattern, you should also look for other things that would suggest a different etiology, including whether they're pleural plaques, pericardial thickening or effusions to suggest, whether there are pleural effusions, pericardial thickening to suggest an underlying collagen vascular disease, whether you see the bony changes that go along with collagen vascular disease, esophageal dilation, which we often see with scleroderma and can see with dermatomyositis and myositis in areas of increasing ground glass. And then other etiologies like pleural plaques when related to asbestos, and then mosaicism or nodules to suggest an HP pattern. So this is just a nice example of UIP with scleroderma. We have nice areas of honeycombing within the lungs, areas of bronchiectasis, relative absence of there is a little more ground glass than we normally see with UIP. And on our soft tissue windows, we can see a nice dilated esophagus, which goes along with scleroderma. This is UIP and rheumatoid arthritis. We see, again, a peripheral predominant pattern with areas of ground glass, which is a little atypical for UIP, but areas of early honeycombing as well. And on bony changes, we can see erosions at the level of the right humeral head, which goes along with a rheumatoid arthritis pattern. So why do we care about identifying a different cause? It does matter. So there is some conflicting data in the literature, but overall it has shown that patients that have UIP related to collagen vascular disease tend to have a better survival rate than those with IPF, and they respond to treatment a little better. So, but overall, once you have a UIP type histology, whether it's related to collagen vascular disease or whether it's related to IPF, the true cure is only transplantation. So we'll stop here, and our next lecture will go over nonspecific interstitial pneumonia and the imaging findings we see with that histologic pattern. So welcome back for part 3 of our lecture series on interstitial lung diseases. Again, my name is Elizabeth Wye, and I'm one of the thoracic radiologists here at Hopkins. So on this lecture, we're going to talk a little bit about nonspecific interstitial pneumonias. And again, when we look at the overlap of interstitial lung disease, NSIP, or the nonspecific interstitial pneumonias, really overlap with a lot of the other histologies, which makes it very confusing for radiologists and pathologists to come up with a final diagnosis in many cases. But on the differential diagnosis for NSIP, of course, we have the idiopathic forms, but it is most often caused by a collagen vascular disease. Drug toxicities can also cause it, occupational exposures, and in chronic hypersensitivity pneumonitis, we do see NSIP-type histologies on pathology. Clinically, the idiopathic form tends to be in younger patient population than we see with IPF, usually somewhere in their 40s to 50s. There's no association with smoking, and it's usually an equal gender distribution. But we see NSIP histology more commonly overall in women because of its relation with collagen vascular diseases. So just a little bit about the pathology of NSIP and how it differs from UIP is that we see more of a temporal and spatial homogeneity within the lungs, whereas with a UIP-type pattern, we see a lot of heterogeneity. There's usually a relative absence of honeycombing, and there are varying degrees of inflammation. More recently in the literature, we've talked more about the different types of pathologic histologies, including cellular, mixed, and fibrotic. Usually the cellular form, we have more of a cellular infiltrate into the lungs. More of the fibrotic form, we have more fibrin and end-stage fibrosis. So it's usually the cellular NSIP that responds to therapy because it's pre-fibrotic stages. And then there's, of course, the mixed histology. Looking at the radiology of NSIP type histologies, typically it is a bilateral process, but it can be asymmetric, whereas UIP tends to be a little more symmetric. The idiopathic form tends to be more lower lobe predominant, but can involve the entire lung. And it commonly, we see it along bronchovascular bundles, and it can be peripheral, but we often see one of the classic features called subpleural sparing, which if you look at the image on the right, you can almost see that there's a little bit of sparing of the periphery. But in this image, we see that there is a lower lobe predominant ground glass appearance with relative subpleural sparing. So again, the distribution in NSIP, as on these images, we see it's more of a lower lobe predominant process, often has ground glass opacities along bronchovascular bundles. Oftentimes we see a little bit of bronchiectasis under it. And then we see that especially in the image on the upper right and the lower image, there is relative subpleural sparing. We don't see the definite honeycombing that we normally see with a UIP type histology. Parenchymal findings we often see with NSIP include ground glass opacities, reticulations, traction bronchiectasis, and oftentimes we do see consolidations, which is something that we don't usually see with a UIP type histology. And when we do see consolidations, sometimes there is the overlap syndrome where we see an NSIP and an organizing pneumonia type histology, which is mixed. So when we look at reticulations within the lungs, we see on the image on the left, there are some peripheral areas of linear reticulation extending to the periphery, especially in that right lung base. But again, we see that this image, nice idiopathic NSIP, has a lot of underlying bronchiectasis and ground glass, but we don't see the extensive reticulation that we normally see with UIP, and we see a relative absence of honeycombing. So this does not look like your typical UIP type histology. Again, with NSIP, you can get ground glass and bronchiectasis, just another great example of areas of lower lobe predominant ground glass that center around the bronchovascular bundles, areas of subpleural sparing, and relative absence of honeycombing. You can get some areas of more dense consolidation, which is where you get that overlap with organizing pneumonia. And on these images, you can see that we definitely have areas where there's more concentrated ground glass consolidation around bronchovascular bundles. And oftentimes when we see that, we see underlying bronchiectasis within the areas of consolidation. But again, in the lung bases on the image on the right, you do see a little bit of reticulation, but relative sparing of the periphery. So with NSIP, just like with UIP, there are features that when we see them, we kind of steer away from an NSIP type histology. One of them is if it's an upper lobe predominant process. Another one is if we see extensive honeycombing. Usually we don't see that with NSIP. If you see areas of just dense consolidation, like the image on the upper right, you oftentimes, it can be that overlap case, but we begin to think a little more of an organizing pneumonia type pattern. We don't usually see discrete ground glass nodules with NSIP as a dominant feature. So if we see mostly nodules, we steer away from it. We shouldn't see a lot of air trapping or mosaicism, and oftentimes you don't see cyst with NSIP. So when we're trying to make our decision on whether something is UIP or NSIP, this is a great case. So this is what we commonly encounter when we see a request. We see something that says someone has a restrictive lung disease, and do these images look like a UIP or an NSIP type pattern? And if we look at them, there's not a lot of great features or defining features on any of these, but we do see that there is a little bit of peripheral ground glass. There's a little bit of lower lobe predominance. Can't really tell if there's any subpleural sparing. There might be some reticulation, especially in that image on the left lower portion of these images. And there's no real honeycombing. So if you had to put this in something, you'd probably say, well, this looks more like an NSIP. But they did a wedge biopsy on this, and this is UIP. And so this is where we see a lot of frustration among radiologists, pulmonologists, and pathologists, because sometimes the imaging features don't always match up with what we classically think. So going on to some of the secondary causes of NSIP, as I mentioned before, collagen vascular diseases, drug toxicities, occupational exposures, and hypersensitivity pneumonitis can all lead to NSIP-type histologies. NSIP in general, when we talk about collagen vascular diseases, is the most common histology over UIP. So even though we often classically talk about UIP and scleroderma, it's much more common with a scleroderma patient to have an NSIP type histology. The only collagen vascular disease that tends to have more frequency of a UIP type pattern, ironically, is RA, or rheumatoid arthritis. And lung disease, interestingly enough, in most of the collagen vascular diseases is the major cause of mortality. So even on people who are asymptomatic, who have prolonged bouts with collagen vascular disease, they're always very cognizant of looking for underlying interstitial lung diseases. So this is a great example of a 38-year-old woman with known scleroderma. Her heart's a little big. We see a little bit of opacity in her lung bases. We don't see definitely a lot of traction bronchiectasis. On the areas on CT scan, we have one that's the image on the left is supine and the image on the right is prone. And we see that there is some ground glass opacity, kind of extends to the periphery, relative subpleural sparing, absence of honeycombing. This was a scleroderma patient. And we also look for some of the secondary signs, including a dilated esophagus. And this patient, ironically, also had a pleural effusion, which you can sometimes see with scleroderma, but you more often see it with lupus. Another example of this is a 31-year-old woman with polymyositis. This has more of the consolidation and bronchovascular appearance of the NSIP type histology, lower lobe predominant. We've got bronchovascular consolidations with underlying bronchiectasis, areas of relative subpleural sparing. This would have features more consistent with NSIP, but we would also throw on the differential. This could be an overlapping OP or organizing pneumonia case. Another example of a 44-year-old woman with polymyositis. This one has a little less bronchiectasis, but again, lower lobe predominant nonspecific ground glass opacities with relative sparing of the periphery. So does it matter whether NSIP is caused by a collagen vascular disease or whether it's idiopathic in nature? And the answer truly is probably yes, it does. Unlike with UIP, if you have an IPF diagnosis, you've got a very grim morbidity and mortality. With the idiopathic form of NSIP, they actually have a slightly better prognosis than those with NSIP related to collagen vascular disease, which is the opposite that we see with a UIP type histology. So then finally, we'll talk about the NSIP outcomes. And so with NSIP, oftentimes they tend to respond more to steroids than the UIP type pattern. And so there's the potential for improvement, for progression, or an acute exacerbation. So with improvement in NSIP, this is a nice example of someone who had on the left image, they had an NSIP type histology, again, that ground glass opacity with relative sparing of the periphery and no honeycombing. After dosing with steroids, we see that the ground glass opacity has somewhat decreased. This would be more suggestive that there is a cellular component of the NSIP versus just the end-stage fibrotic form or stages. Understanding that once you have deposition of fibrin in the lung, it's difficult to recover the fibrosis and turn the lung back into normal appearing lungs. So once there's significant fibrosis, you can get rid of the ground glass, but a lot of the fibrotic features remain. With an acute exacerbation of NSIP, just like with UIP, there's a small subset of patients that will have an accelerated form of their NSIP. They have basically a diffuse alveolar damage that causes accelerated fibrosis. And it has been shown that when you see this in someone with UIP, the prognosis is very grim. If they have the idiopathic form of NSIP and have an acute exacerbation, they actually do much better than somebody who has a collagen vascular disease who undergoes an acute exacerbation. Their mortality rate tends to be much higher. So finally, we're just going to talk about the radiology versus pathology. Again, as I said before, there's a lot of inter-observer variability, and the American Thoracic Society actually recommends in the ideal clinical setting that radiology and pathology and the pulmonologist all sit down together to clinically come up with a diagnosis of what type of fibrosing interstitial lung disease a patient has. This concludes the third portion of our talk on interstitial lung disease. On our fourth and final lecture on the interstitial lung diseases, we're going to breeze through the other types of interstitial lung disease and kind of bring everything together. Thanks for listening. Hi, welcome back for our fourth and final installment on the interstitial lung diseases. And again, my name is Elizabeth Y, and I'm one of the thoracic radiologists here at Hopkins. On this session, we're going to breeze through the other forms of interstitial lung disease. The prior sessions, we talked a little more about, in depth, about the fibrosing forms of interstitial lung disease. But first, we're going to start off very quickly talking about smoking-related interstitial lung diseases and respiratory bronchiolitis. So histologically, respiratory bronchiolitis is seen in all smokers, and it's something that's usually asymptomatic. And when a patient begins to experience symptoms and shows a restrictive pulmonary function test, then we know, then the clinicians will call it respiratory bronchiolitis interstitial lung disease. On radiology, or on the clinical side, usually we see it in someone who's 30 to 40 years old, usually a mild male predominance. 100% of these people have a smoking exposures or smoking-related history. And again, oftentimes they have a restrictive lung disease. Because they are smoking, we do see oftentimes also a mixed pattern because of the smoking-related changes in the lungs. And usually the prognosis is pretty good following cessation. On radiology, what we're really looking for is an upper lobe predominant process. It's really defined by central lobular nodules, usually ground glass in appearance, and oftentimes we see a little bit of thickening of the bronchial walls. Very on the more advanced cases, we'll see subtle areas of reticulation, and it's plus or minus having emphysema and air trapping. But we really don't see a lot of the heavy fibrosis we saw with UIP and NSIP. So with respiratory interstitial lung disease, oftentimes this is a very classic look. We just get vague ground glass in the upper lobes, and they have somewhat of a nodular pattern, and we call this central lobular nodules. On this patient that has a slightly more restrictive lung disease, we see that there are areas of mosaicism, a little bit of airway thickening, but if you subtly look at the lung parenchyma, you can start picking out these very subtle areas of ground glass nodularity. And so that we call this respiratory interstitial, or respiratory bronchiolitis, interstitial lung disease. Another form of the smoking-related interstitial lung diseases is desquamative interstitial pneumonias, or DIP. Clinically, these patients tend to be 40 to 50 years old, again, in mild male predominance. Most cases have an abnormal oxygen exchange, so an abnormal DLCO, and it's almost always related to smoking, but there are sometimes DIP can be related to other inhalational injuries, and every now and then a collagen vascular disease or an idiopathic form of DIP can crop up. But usually the prognosis, again, is pretty good following smoking cessation, and the progression to end-stage fibrosis is usually relatively rare. Talking about the radiology of DIP, the radiologic findings are usually pretty nonspecific. We see ground glass opacities. It tends to be a little heavier in the lung bases, and it usually goes peripheral. But desquamative interstitial lung disease is oftentimes defined by areas of thin wall cysts. They're usually less than a centimeter in size, and it's very uncommon to see honeycombing and architectural distortion. And to note that because it is a smoking-related lung disease, we often see central lobular nodules related to respiratory bronchiolitis in addition to a DIP pattern, so you can see nodules as well. So this is just a radiograph of someone who has DIP. We see that there is a lower lobe predominant process. On these radiographs, we see that there is a little more ground glass kind of reticular nodular pattern in the lower lobes. But once we look at it on CT, we see that there is kind of a diffuse ground glass throughout the lungs, but we see in the lower lobes there are definitely areas of thin wall cyst, mild airway thickening, maybe a little bit of mosaicism or air trapping in the image on the lower right, but very nonspecific, but findings that we do see with DIP. And again, this is another example of DIP where we see kind of ground glass in lots of areas. Don't see a lot of consolidation, mostly ground glass. Areas of relative sparing or air trapping, and some thin wall cysts that are starting. And again, just another great case of DIP where we see ground glass, areas of mosaicism and thin wall cyst in the lower lobes. Another documented case of DIP. DIP over time can improve with smoking cessation and sometimes with steroid use. And this is just a nice example of the image on the left. We have a little more ground glass and we have some thin wall cyst. After the cessation of smoking, we see some of the ground glass has been removed. And the cyst, unfortunately, is architectural destruction within the lungs, and they don't resolve themselves over time. So you still are left with essentially holes in the lung. Next, we're going to talk about the more subacute and acute phases of interstitial lung diseases, and we're going to breeze by organizing pneumonias, which, when idiopathic, do cause underlying interstitial fibrosis. The differential diagnosis of an organizing pneumonia type histology is very broad. So we call it COP or cryptogenic organizing pneumonia when there's no known cause. But most commonly organizing pneumonias are caused by other things such as infections, bronchial obstructions, aspirations, drug reactions, collagen vascular diseases. The list goes on and on. So organizing pneumonia type histology is actually a very common histology we see, and is just a big fancy name for how the lung is trying to repair itself when it incurs injury. So looking at the clinical features of organizing pneumonia, it tends to be kind of a mean age of around 50, equal male-female distribution. And smoking actually is believed to be a relative protective mechanism to organizing pneumonia. We see it much more commonly in non-smokers than we do in smokers. And the prognosis, most people who have an organizing pneumonia type histology completely recover with no residua in the lungs. But there is a subset of patients that go down the interstitial lung disease. So there's a wide expression of what organizing pneumonia can look like within the lungs. Of note, in someone who's immunocompetent or who has a normal immune system, we often tend to see more consolidations, whereas if you're immunocompromised, someone with organizing pneumonia can be just ground glass opacities. Classically, they tend to be peripheral and along bronchovascular bundles. They can have nodules. There are some classic signs. We talk about the reverse halo sign and atoll sign that you can see with organizing pneumonias. And as I said before, nearly all of them resolve, and only a small percentage go to end-stage fibrosis. So this is a nice example of a cryptogenic organizing pneumonia. We see that there are bronchovascular consolidations that extend out to the periphery. So on the differential for peripheral consolidations, we often put organizing pneumonia on top, and this is just a great example, especially the image on the right, where we see that there are more peripheral appearing consolidations along bronchovascular bundles and areas of ground glass. Some of the classic features that we can see that help us define something as an organizing pneumonia is what we know as the atoll sign, which we see on the image on the left. We kind of see a half atoll sign where we see a crescentic band of more dense consolidation with more central ground glass opacities. Also, this can be termed as a reverse halo sign, which is the image on the right, where we actually see, instead of the original halo sign was first described with aspergillus, where you have density centrally and ground glass around or surrounding it, whereas the reverse halo is just the opposite. Again, it looks like an atoll, so you've got dense consolidation peripherally and ground glass centrally. We tend to see these signs a little more as the organizing pneumonia is resolving. The one thing that's always on the differential for organizing pneumonia or peripheral consolidations that we need to keep in the back of our minds is eosinophilic pneumonia. So this is an example of eosinophilic pneumonia. It essentially looks just like an organizing pneumonia, and sometimes they can be very difficult to distinguish. So just remember, on someone who has peripheral consolidations along bronchovascular bundles, you always keep eosinophilic pneumonias on the differential. So next we're going to talk quickly about the acute interstitial pneumonias. And with the acute interstitial pneumonias, it is essentially a very rapid form of rapidly progressing diffuse alveolar damage. So when we don't know a cause, we call it AIP, or acute interstitial pneumonitis, whereas when we know the cause, it's also in the spectrum of ARDS, or acute respiratory distress syndrome. The idiopathic form usually has a viral prodrome, and it is the only one of the idiopathic interstitial lung diseases with a very acute onset. So the idiopathic forms tend to be, we tend to again see them around the age of 50, no association with smoking, equal gender predominance, and unfortunately the prognosis is very poor on these patients, and there's about a 50% mortality with your first exacerbation. The radiology of AIP includes usually a diffuse, nonspecific pattern, patchy consolidations in ground glass throughout the lungs. Oftentimes it involves the lower lobes, and it's seen posteriorly, but the key feature with AIP is that you see very rapid fibrosis within the lungs that occurs in the course of days to weeks. And oftentimes, if the patient does survive the episode, they end up with a very bizarre appearing scarring pattern within the lungs. So on these images, it was the same patient, and again we see that it's a diffuse process involving both lobes, not a lot of definition in terms of simply ground glass or simply consolidation, but a lot of ground glass. There are some areas to suggest that there's some early underlying bronchiectatic changes in the lower lobes starting. So another patient, this is another example of a patient with AIP. So this is how they initially presented, where we see just a lot of diffuse ground glass in the lower lobes, relative sparing of the upper lobes. And if you look at that ground glass, we see areas of underlying crazy paving pattern. And we see that, again, these ground glass opacities extend out to the periphery. They are encompassing bronchovascular bundles with relative areas of sparing. But 1 week later, same patient, again, we see ground glass everywhere. The ground glass hasn't improved, but if we look at these images, we begin to see that the airways are starting to be ripped apart, particularly in the lung bases. You can see that the airways are starting to dilate out. We see more varicosity, or more beating appearance of the airways, to suggest that there's been underlying fibrosis or fibrin deposition along the interstitium of the airways. And so when we put these two images side to side, one of the key features to really identify whether you have underlying fibrosis within the lungs is to look at those airways. And we can see, looking at essentially the same or near same slices of the lungs, the ground glass distribution has changed a little bit, but within just a week we see quite a bit of dilation or new dilation within airways. And that would be highly suggestive of a very rapidly progressing fibrosis in the lungs, which we can see with AIP or ARDS, and it's usually a very, very bad prognostic sign. When people survive with AIP, again, the fibrosis can look very weird. You can have areas of little cystic changes and reticulation. The ground glass will hopefully relatively go away, but there's not a defined characteristic of how the fibrosis will look within the lung. It's just a very bizarre appearing pattern. Anyone would look at the CT and say that there is definitely scarring that has undergone itself within the lungs. Finally, we're going to just briefly touch on the very rare forms of interstitial lung diseases. First, we're going to talk about lymphocytic interstitial pneumonias. An LIP pattern is it's very rare when we see it. It's very rare to actually be idiopathic. It's almost always related to Sjogren's disease or with someone who's had prolonged HIV. But we can see it every now and then with infections and immunodeficiencies. When we do see it, there's no association with smoking. We often see it more commonly in females because it's related to collagen vascular diseases, and the prognosis is variable. So looking at the LIP, the radiologic features of LIP, oftentimes we see patchy ground glass with poorly defined nodules, but the real defining feature is that we see isolated thin wall cyst. And this is what places it in one of the cystic lung disease categories as well. It's very commonly associated with follicular bronchiolitis when it's related to collagen vascular disease. And we often see thickening of the bronchovascular interstitium. So this is just a nice example of an acute LIP, very nonspecific, but we see these very vague ground glass nodules in the lower lobe. And if you look on that image on the lower right, we see a very small thin wall cyst. It's a very nonspecific finding. You would have to exclude infection, but certainly LIP would be on the differential. This is a nice example of a more burned out case of LIP where you have thin wall cyst and maybe fewer ground glass nodules, but again, a very characteristic look for LIP. And this is an example of somebody who has, it's actually a teenager who had HIV since birth and it had multiple bouts of interstitial lung disease. And this is the very classic look of what LIP looks like with end-stage fibrosis. We have areas of mosaicism, thickening of the bronchial walls, thin wall cyst, and relative areas of ground glass and nodularity. And finally, another example of just large thin wall cyst with LIP. And then finally, I'm just going to brush on one of the new pathologies that are one of the new diseases that we're newly defining, pleural parenchymal fibroelastosis, which is now on the spectrum of interstitial lung disease. It's a very rare idiopathic disease described just a few years ago. And we have seen cases that are related to, that are been thought to be genetically related and related to bone marrow transplant, and then a few idiopathic cases as well. And what really defines pleural parenchymal fibroelastosis, as seen on the image on the right, is that you have a very thick band of peripheral fibrosis is involving the periphery of the lung and the pleura. So this is just a great example. This patient was actually status post bone marrow transplant who in 2005 had relative normal appearing lungs, but by 2011 had a very classic look of pleural parenchymal fibroelastosis with thickening seen along the pleural surfaces, nicely seen along the fissures. And this is just a nice kind of time course of the same patient who went from normal lungs in 2005 to 2011, where they had end-stage pleural parenchymal fibroelastosis. And we can see as the images are progressing, thickening along the periphery of the lung and in the pleural spaces, particularly along the fissures. She also had a concaminant organizing pneumonia, which is why we see some ground glass opacity within the lung as well. So over the last 4 lectures, we've kind of gone over the defining features of interstitial lung diseases. We've talked more in depth about the chronic fibrosing forms of interstitial lung diseases where radiology really plays a role. And then on this final lecture, we've kind of breezed through the smoking-related interstitial lung diseases, the more subacute and acute forms of interstitial lung disease, and then the very rare entities that we sometimes see with interstitial lung disease. So thanks for listening.
What I'd like to do is give you guys a brief review of the clinical history and the pathophysiology of sarcoid, as well as show lots of images of both common and more unusual thoracic imaging findings in the chest, and just to briefly touch on the complex relationship of smoking and sarcoid. So sarcoid was originally described in 1877 by a pathologist named Jonathan Hutchinson, and it got its name because of skin lesions which look like sarcoma. It's a multisystem disease. It's characterized by non-caseating granulomas, and in 90% of patients it involves the respiratory system or the lymphatics, which is associated with most of the morbidity and mortality of the disease. and it also frequently involves the skin and the eyes. So there's a broad range of clinical presentation here. Some patients are asymptomatic or have very limited disease, while other patients have real debilitating disease ending in death, unfortunately. But luckily for 2/3 of patients, they have stable disease or they enter remission in about 10 years. And after remission, very few recur. Unfortunately, for 20% of patients, they go on to develop chronic disease and lung fibrosis. And in about 5% of patients, they end up dying from their disease, typically related to their pulmonary manifestations, and sometimes related to cardiac and neurologic involvement. So usually patients present when they're in their 20s, young adults. There's a variable incidence throughout the world, and it's seen more commonly in women than in men across ethnic groups. So the highest annual worldwide incidence is in Northern Europe, but here in the US, Black Americans are 3 times more likely than white Americans to be afflicted with sarcoidosis. Black Americans are more likely to have severe or chronic disease or extrathoracic disease, and white Americans are more likely to have asymptomatic disease. There was a paper published last year which looked at the mortality of sarcoid over about a 20-year period, and they found that mortality had increased about 3% per year. The highest absolute death rate was among Black females, and the greatest increase in mortality was seen in older patients over 55 years of age. And interestingly, the patients with sarcoid-related death actually died from sarcoid rather than superimposed or other complications such as lung cancer or even pneumonia, which actually was a surprise to me. So the pathophysiology, the etiology is obviously it's a big point of discussion for many people. A lot of people think that it's related to something airborne because of the frequent involvement of the lungs, the skin, and the eyes. Again, non-caseating epithelioid cell granulomas is what makes the diagnosis, and those are produced as a product of cell-mediated immunity. So what we have are activated alveolar MACs and T-cell lymphocytes, which produce interleukins and growth factors, and in turn, those recruit more T-cells and fibroblasts. It basically sets off a cascade of cellular infiltration and chemical release. Serum angiotensin converting enzyme is frequently used by clinicians. It's a product of macrophages and an indicator of granuloma burden, but just a reminder, there's a 40% false negative rate. So clinically, if patients present with symptoms are typically respiratory ailments like cough or shortness of breath, systemic symptoms like fever, fatigue, polyarthritis. Those are also seen. I had forgotten about Lofgren syndrome, which is supposedly pathognomonic, and it's composed of intrathoracic adenopathy, erythema nodosum, and arthritis. So if you consider these 3 elements together with fever, those 4 actually convey a good prognosis for sarcoid. However, on the other hand, there are a few elements which generally portend a not so fortunate course, a bad prognosis, and those are an older age at diagnosis, over 40 years, and either lung parenchymal or airway involvement. And it's also very important to remember that in about 50% of patients, they present asymptomatically, detected incidentally on a chest X-ray. So let's start looking at some images here. Chest X-ray, usually the first foray into radiology for some of these patients. And bilateral hilar adenopathy is the most common finding, oftentimes in association with right paratracheal adenopathy. Other combinations are less common, obviously, but thank goodness unilateral hilar adenopathy is seen in a small majority of patients. So the older someone is at presentation, the more likely they are to have atypical lymph nodes. So nodes are oftentimes non-calcified. Those that are calcified tends to be related to duration of disease. About 20% of patients have calcified nodes at 10 years. And the calcification is often amorphous or smudgy or hazy. Sometimes it's eggshell. Here's a patient with hilar enlargement and paratracheal opacity, and the corresponding CT shows lymph nodes pretty much everywhere. We have some nodes in the anterior mediastinum, bulky right paratracheal adenopathy. We see involvement of the AP window. The hyla are enlarged, and there's subcarinal adenopathy. So here's another patient. The hyla are prominent, but it's almost overshadowed by this right paratracheal opacity with involvement of the tracheobronchial angle. And even on this non-contrast study, we can see that there are enlarged nodes in the paratracheal region next to the aortic arch and creeping into that anterior mediastinum. The hyla, there are some nodes there, but they're sort of overshadowed by the disease above. So chest radiographs, oftentimes There's the Siltzbach staging system, which was developed 40 years ago and is oftentimes still in use. It generally conveys a good prognostic value. This should be something that most of us are still familiar with. Ranges from stage 0, which is a normal X-ray, to stage 4, which designates fibrotic lung disease. 50% of patients have adenopathy, so that's stage 1 disease. Additional disease basically indicates parenchymal involvement. So here's an image. Hilar enlargement, right paratracheal opacity, and there are also some ill-defined parenchymal opacities at the bases. So this would be a good example of stage 2 disease, adenopathy and parenchymal involvement. So most patients go on to get CT, for better or for worse. It allows us much greater sensitivity for early disease or subtle disease, frequently using high-resolution protocol where we use thin section images. This can really help detect more subtle nodularity, ground glass opacity, reticulation, things you might not see so well on a standard chest CT. One of the best, the greatest advantages is really to be able to assess active, reversible, or treatable disease like nodules, lung consolidation, and oftentimes ground glass, in comparison to chronic, fibrotic, or irreversible, basically non-treatable disease, which is bronchiectasis, architectural distortion, or perhaps cystic changes. And again, it's important to note that a negative CT doesn't exclude the presence of sarcoid, unfortunately. So parenchymal disease usually starts as an alveolitis or an interstitial pneumonitis of the alveolar walls. Again, T cells, recruiting MACs, and the macrophages morph into these epithelioid cells. They coalesce to form what we call granulomas, and they typically congregate in lymph nodes and areas of the lung where there's a rich lymphatic supply. So what that means is subpleural spaces, the septae, the peribronchovascular regions, and of course that gives us our characteristic perilymphatic nodules. So on CT, we're looking for nodular thickening of the fissures and the pleural surfaces, nodular septal thickening, and thickened bronchovascular bundles. So here's a patient with nodular septal thickening of all the fissures. A little bit lower down in the chest, same patient, we see pleural nodularity and irregular thickening along the lateral margin of the right lung base. Another patient with nodular septal thickening. The image on the left could be confused with lymphangitic carcinomatosis if you had no history whatsoever. And finally, a case of pronounced bronchovascular bundle thickening in the right lower lobe. So here's a patient which seems to have a little bit of everything here. If you look at the images on the top, that you have a nice example of nodular septal thickening. There's also bronchovascular bundle thickening. And then the images on the bottom are a great illustration of nodular thickening of the fissures. Here's a patient with what looks like primarily adenopathy, hilar or paratracheal opacity, which is confirmed on a non-contrast CT. But 3 years later, the follow-up imaging, it's not so much adenopathy picture. Now we get more of a sense that there's a central predominant lung reticulation. So it's changed over 3 years. And the CT that followed that X-ray shows this. So there's really pronounced bronchovascular bundle thickening. There's also some septal thickening and pleural thickening and nodularity, but the bronchovascular bundle thickening was really pronounced in this patient. Here's another patient. There are perilymphatic nodules in this patient. We see nodular thickening of the fissures and even some ground glass in the right hilar region. But in the upper lungs, it looks like the nodules have more of a random appearance or random distribution. Certainly not all the nodules are perilymphatic. And in some areas, like in the right upper lobe, some of these nodules sort of have a clustered appearance, like perhaps suggesting maybe even a central lobular distribution, which would be really unusual with sarcoidosis. Here's some images of the lung bases in the same patient. Again, a few of the nodules are clustered, but overall, despite the presence of perilymphatic nodules, there was sort of a random distribution in this case. Here's another patient this was a man in his 50s who actually came in recently to our hospital. Abnormal X-ray with a diffuse micronodularity, sort of looking granular and ground glass opacity, and the corresponding CT showed that as well. What we thought was a miliary pattern of micronodules, best seen at the apices, and then as you go down towards the bases, nothing spared here. It involves the entire lung, but it sort of, again, produces this granular or ground glass opacity, and path on this patient showed non-caseating granulomas. Interesting case. Yet another X-ray. This shows widespread reticulation, oftentimes somewhat nodular in appearance. And the CT illustrates that as well, some upper lung predominant reticulonodular lung markings in a patient with sarcoid. So what we've seen so far is a fine nodular pattern or a reticulonodular pattern. But oftentimes, these nodular opacities coalesce. So in over 50% of people, they have at least 1 centimeter size coalescent nodules. You may have air bronchograms, or you may not. You can have satellite nodules, which is referred to as the galaxy sign. And you can have ground glass opacity, which is usually related to extensive interstitial granuloma infiltration. So ground glass is usually associated with active disease, but you can also see it with chronic fibrotic disease. It sort of bridges the gap between acute and chronic sarcoid. Coalescent nodules can be acinar, basically poorly marginated, somewhat stellate nodules. They can coalesce to form alveolar sarcoidosis. And fortunately, focal nodules or masses are rare, and they oftentimes require tissue sampling to exclude malignancy. Cavitation is also very rare, true cavitation that is. Several studies, everyone seems to be less than 5%, so it's pretty uncommon. So here's a patient with characteristic nodules. They're poorly marginated. They're primarily in the upper lungs, sort of a stellate appearance. This was a sarcoid patient. Here's another patient, actually 2 patients, with irregular nodules, somewhat stellate in appearance. And the patient up top, if you look at the right lung, these nodules sort of coalesce to form an alveolar sarcoid picture. Here's another recent patient we had, a young patient, young female who came in with widespread nodularity. And if you look at the arrows are denoting some upper lung nodules, which look like they may be undergoing cavitation. So the corresponding CT there showed irregular nodules, some of which were indeed cavitary. This patient was lost to follow-up, unbelievably, for 6 months, and when she came back, granted we only have a few images here, but nodularity had increased, the cavitation had increased significantly, lungs looked horrible. A patient went for an open lung biopsy. This was actually diagnosed as necrotizing sarcoid granulomatosis, which is sort of a subset of sarcoid, primarily characterized by a vasculitis and associated necrosis. So that's why she has such a wide extent of cavitation here. We actually saw this image before. This is our stage 2 disease. The corresponding CT shows some nodular mass-like areas of consolidation, some of which have air bronchograms like we see in the right lower lobe. Yet another patient, upper lung predominant, heterogeneous lung opacity. And this also shows another case of alveolar sarcoidosis. Interestingly, at the apices, you can see that the airways are a little bronchiectatic, so that suggests that this disease has been around for a while. This X-ray looks primarily like adenopathy to me, but the corresponding CT shows some micronodularity of the fissural surfaces, and there's also a frightening, scary-looking, irregular consolidation at the right lung base. We can also see on the reformatted coronal image. So when we look back at the X-ray, I still think this is like my worst nightmare. I guess there's a faint opacity there at the right lung base, but honestly, I think this may be an easy miss. So the patient was treated with steroids, and after treatment, re-imaged, and the micronodularity resolved, and thankfully that irregular right basilar opacity shrank significantly. It left some residual streaky opacity in an area of focal bronchiectasis. This is another patient with a focal consolidation at the right lung base. Everyone thought this was cancer. It was actually sarcoid. So 20% of patients go on to develop lung fibrosis, and just like acute disease, the distribution is primarily involving the upper and the mid lungs. And we see classic fibrotic findings, so linear opacities, airway distortion with traction bronchiectasis, and architectural distortion. Sometimes we can see fibrocystic changes with bullae, cysts, honeycomb-like cystic changes, and rarely, again, cavitation. If cavitation is present, it's usually pseudocavitation with a fibrous lining of that cystic or cavitary space. There was a paper published about 10 years ago which looked at patients with sarcoid-related pulmonary fibrosis, and of the 80 patients in that study, about half had bronchial distortion, so that was the primary or common finding among them. And honeycombing and linear opacities were much less common in those patients. So we'll take a look at a few cases quickly here. This is a patient with some widespread traction bronchiectasis. There's volume loss and architectural distortion, ground glass opacity, some scattered reticulation. Here's another horrible patient with some cardiac disease and definitely abnormal lung parenchyma. And here's the corresponding CT. So these images also have a little bit of everything. At the right apex, you could consider that there may be some honeycombing. There's also traction bronchiectasis, ground glass opacity, and reticulation. This doesn't spare any area of the lung. This involves the apices all the way down to the bases. And this patient had a long history of sarcoidosis. Here's another patient. We see these characteristic stellate nodules, but in this patient, the hyla are enlarged, sort of a conglomerate mass-like opacity, and they're retracted posteriorly with associated traction bronchiectasis. This is another patient, similar findings, but what we see in this patient is a lot of ground glass opacity. So one of our last cases of fibrotic lung disease. What we see here is hilar enlargement, paratracheal opacity, but we also see widespread reticular, somewhat cystic-looking spaces. Looks like it involves the entire lung, but it looks more prominent at the bases. And on CT, you might not think this was sarcoidosis. We see traction bronchiectasis, and we see honeycombing, but it's basilar predominant. So sarcoid would certainly not be on the top of your differential, but in case, strangely enough, that's what this patient had. Another case, this is a patient younger than you may think, but there's extensive bullous and cystic change involving both upper lungs. When we look at the axial images, you can see there's also a mycetoma forming in the left upper lung, lots of destruction and distortion of that right lung especially. But interestingly, I just want to point out that the bases actually look pretty good in this patient. It's another patient with lots of ground glass and evidence of air trapping. So with that, I want to sort of segue quickly into airway involvement, which is oftentimes overlooked. It involves about 2/3 of patients, and it's associated with increased morbidity and mortality. So it's something important to consider. It goes from top to bottom, so to speak, oftentimes producing mild extrinsic compression from enlarged lymph nodes, but it can also be intrinsic airway disease, mucosal inflammation, and areas of stenosis intrinsic to the airway itself, rather than extrinsic compression by enlarged nodes. Any sort of extrinsic compression is usually not very clinically significant. Large central airways are not involved commonly. Usually involves medium-sized airways, but this was a patient where sarcoid was on the differential. What we see is a circumferential thickening of the trachea, the main stem bronchi, and even some segmental airways. But most airways are lobar or segmental bronchi when they're involved with sarcoidosis. Early stage disease includes edema, inflammation, and infiltration with granulomas, and that produces this characteristic nodularity or cobblestoning that we hear about from our bronchoscopist colleagues. It also develops not just within the airway, but along the bronchovascular bundle, as we mentioned before. So in the early stages, it can result in some luminal stenosis and narrowing, sometimes some atelectasis, but surprisingly, the symptoms are usually fairly minor. And then, of course, as disease progresses, you get some fibrotic changes either from intrinsic airway involvement or from surrounding parenchymal involvement pulling those airways open. So it can be either directly related to the airway itself or the surrounding lung that's involved. This slide we've seen before, just sort of reiterating that bronchial distortion, airway distortion, is the most common fibrotic finding associated with sarcoidosis. So small airway disease can occur in early disease or late disease. It can be seen with or without parenchymal involvement, and we typically see this with expiratory images. Air trapping is seen in the large majority of patients with sarcoid, up to 95%, in a study performed by Davies and colleagues. Here's a patient with acute disease and evidence of air trapping. And here in the flip side is a patient with chronic fibrotic lung disease and air trapping. So sort of runs the gamut. Hemoptysis is usually related to a complication of aspergilloma rather than traction bronchiectasis. There was a study last year by Peña and colleagues that looked at over 400 patients and found that about 2% of them also had to deal with aspergillus infection. So this was only seen in patients with fibrotic lung disease from sarcoid, but it was seen more commonly in sarcoid than other chronic lung diseases. And although there were only 10 patients afflicted with this complication, the outcome was actually pretty bad for several of them. 3 patients out of 10 died. So it's a potentially very serious and fatal complication. So here's a great example of a patient with Monod sign. There's an air crescent and heterogeneous opacification of the right upper lung. and corresponding CT images demonstrate our mycetoma. There's also some honeycombing or honeycomb-like changes in both upper lungs. So smoking, it's very interesting. There's been a lot of work on smoking and as it relates to sarcoidosis. And there was a study in 2004 called the ACCESS study, which found that the odds risk of sarcoid in patients who had ever smoked, meaning current smoker or ever smoker, was significantly lower than people who have never smoked at all. And so lots of studies came as a result of this. One such study looked at CT findings and found that smokers had a decreased frequency of bronchovascular bundle thickening than non-smokers. And since bronchovascular bundle thickening is associated with airway obstruction, some people assume that bronchovascular bundle thickening can be sort of a surrogate marker for assessment of disease burden or airway obstruction. A couple other studies have looked at exactly why smoking might produce a decreased odds of sarcoid. And basically the thought is that smoking decreases the inflammatory response or decreases the immune response, which allows granuloma formation in the first place. So pleural involvement is pretty uncommon. It's 10% or less of patients, usually small or moderate effusions, which clear after a few months. And one interesting complication or sort of a variant is a chylothorax, which involves infiltration and obstruction of the thoracic duct. This is very uncommon. This is a patient we had in Brooklyn, a 36-year-old who came in with acute symptoms to the emergency department. He had a low-density pleural effusion. He also had chylous ascites. He had airway involvement. Really interesting case. So this is our case of chylothorax. And I just want to remind you very briefly, I don't read nukes, thank goodness, but nuclear medicine can be used to assess the presence of active sarcoidosis and looking for extrathoracic disease. It's very useful. Response to treatment, for example, using gallium citrate.
So let's define what we mean by micronodular lung disease. Obviously, these are rounded opacities. Typically, they're very small, less than 3 to 5 millimeters, usually on the 2 to 3 millimeter side of that, and they are usually quite numerous. Now, a little bit about CT detection. I think that there have been a lot of support in the literature over the last 20 years for using sliding MIP reconstructions for detection of micronodular lung disease. In this case, I think you can see them pretty obvious. This is a pretty obvious case to begin with, but I'll show you a case as we go through where I thought the MIPS were really helpful. This is my protocol. I usually use about 5 millimeter thick sections and slide through them at 1 millimeter increments. And again, if I'm trying to decide whether or not there are really some little small lung nodules there, I find this technique fairly helpful. I also find coronal MPR is helpful, particularly for assessing distribution, as we'll see in a minute. I think it helps you, obviously it gives you a upper lobe, lower lobe predominant sort of picture, but it gives you an idea just how diffuse the abnormality is in terms of disease distribution. Okay, so we'll start with this case. This is a patient with loads of tiny, well-defined lung nodules. How do we approach a differential diagnosis in this case? All right, well, first and foremost, distribution is key. Identifying the distribution primarily related to the anatomy of the secondary pulmonary lobule is very helpful for constructing a differential diagnosis. 3 patterns have been described: a random or diffuse distribution, central lobular distribution, or a perilymphatic pattern. Okay, and what we're going to focus on first is the central lobular pattern of nodular opacities. Okay, so this patient has a discrete central lobular nodules. Let me just see if I can get the pointer up here. You can see them out here, all right there. Some of them about 5 millimeters from the pleura, and that's one of the characteristics of central lobular nodules. They will cluster along the core lobular bronchiole and artery, as you see here in the diagrammatic section, but they will typically not extend to pleural surfaces or extend to the interlobular septum. That's very important for differentiating this pattern from the perilymphatic pattern that we will discuss in just a moment. And again, in the left lung of this particular patient, we can see these nodules. Even in dependent portions of lung, we see that very subtle peripheral clear zone. These nodules are out there in the center of the secondary lobule, but they do not touch pleural surfaces. These are classic central lobular nodules. Now, when you identify central lobular nodules, I think it's helpful to describe some further features about them before we attempt a differential diagnosis. Are they relatively solid and discrete? Do they demonstrate a tree in bud pattern, or are they of ground glass attenuation? Because our differential will differ depending upon which of these answers we arrive at. Okay? Now, the solid and the tree and bud sort of go together to some degree, so I'll talk about them next. This patient has solid, discrete central lobular nodules. There are no additional linear opacities here to imply a tree and bud pattern. Now, what is my differential for solid central lobular nodules? I'm thinking about the pneumoconiosis, silicosis, co-workers pneumoconiosis, pulmonary Langerhans cell histiocytosis, infection, as we saw a number of cases this morning of infection manifesting with central lobular nodules, aspiration, very probably under-recognized cause for central lobular nodules, particularly in dependent portions of lung and particularly in hospitalized or otherwise debilitated patients. And then rarely you may see metastatic disease having a purely central lobular pattern. That's not really all that common in my experience, but it certainly has been described in the literature. This patient, as you might have imagined, has silicosis. Now, it would have been helpful if perhaps, as in this patient, we had more areas of conglomerate fibrosis in the upper lobes, and that would be a clue to the appropriate diagnosis. This is a patient with Langerhans cell histiocytosis, also manifesting with some central lobular nodules. Notice they're not quite as well defined as the patient with silicosis. They're a little bit larger. And a few of them, perhaps right there, you can begin to appreciate some central lucencies. Notice also as we scan from apex to base, there is a paucity of nodules, particularly in the anterior portions of the lower lungs, and that's fairly characteristic of Langerhans cell histiocytosis. In a more advanced state, as in these patients, we may see larger, more discrete nodules, but we then will begin to see excavation, and we appreciate the characteristic cystic forms of pulmonary Langerhans cell histiocytosis. Now, this patient has tree and bud central lobular nodules. Here are the nodules. Some of them are soft tissue, some of them are ground glassy, but here are the little connecting linear opacities. And it's really the connecting linear opacity along the core lobular bronchiole associated with the nodular opacity in the center of the secondary pulmonary lobule that allows us to call this particular pattern on CT. This is another patient with a tree and bud pattern. You can see it here anteriorly, here posteriorly, these clustered central lobular nodules with the little branches resembling very much a tree as it is budding. And that is, of course, what has given rise to this particular term. Now, tree and bud opacities are typically taken to imply the presence of infection, and most of the time that will be true. Tuberculosis, non-tuberculous mycobacterial infection, some viral infections as we saw this morning, and bacterial infections, I would add, as well. But I would also emphasize aspiration, again, as a potential cause of a tree and bud pattern, particularly when it's in dependent portions of lung in patients who are hospitalized or debilitated. This patient had airway disseminated tuberculosis, and this patient was aspirating. You can see that there's actually fluid here within the central bronchi, as well as a tree and bud pattern dependent portions of the lower lobe. This case was given to me by Dr. Laura Heinemann, also demonstrating a central lobular nodular pattern with some tree and bud component, particularly up anteriorly. This patient had an esophageal stricture. The stricture was repaired. The patient had a PEG tube placed, and you can see 6 months later these opacities have resolved. So don't forget or overlook aspiration as a potential cause for this pattern on CT. Let's talk for a minute about ground glass central lobular opacity. Some people would object to the use of the term nodules. That's why I put it in parentheses here, central lobular opacities. What we're talking about is perhaps best illustrated up in this portion of the lung. You can see the secondary pulmonary lobule here with a central rounded area of ground glass attenuation, 4 to 5 millimeters in diameter. You can see some other ones that are more elongated, as you can see here, along the core lobular structures. So this is a central lobular pattern of ground glass, or central lobular nodular pattern of ground glass opacities, if you will. Now, when I see this pattern on CT, first and foremost, I'm thinking about HP, hypersensitivity pneumonitis. And with that Florida pattern, that's going to be the first thing on my differential diagnosis. There are other things, other forms of bronchiolitis, respiratory bronchiolitis, some infections, as we saw this morning. The adenocarcinoma, or the tumor formerly known as bronchoalveolar cell carcinoma, adenocarcinoma spreading throughout the airways, may manifest with this pattern. Organizing pneumonia, cellular NSIP, and sometimes edema and vasculitis. But when it says Florida, as in this particular case, we really want to think about HP in the differential diagnosis, and in fact, this patient had bird fancier's lung. It's another case talked about earlier today. This is another case of HP. This would also demonstrate some centrolobular ground glass nodular opacities anteriorly, some more broader areas of ground glass. But a characteristic feature of HP on expiratory exams, we see areas of expiratory air trapping in this patient who had recently purchased a hot tub and stored it indoors. And this is a case of hot tub lub, which Dr. Hartman mentioned this morning, secondary to inhaled mycobacterial organisms. It's a patient with respiratory bronchiolitis, and it's hard to project. I think David showed a really nice example earlier. There's probably one of those centrolobular ground glass opacities there. In this particular case, I found the MIPS really helpful because I just wasn't sure based on the individual axial sections. But as this runs through, you just get the overall sense that there are these little ground glass attenuation opacities within the center of the secondary pulmonary lobules. It's very subtle. And again, I think the MIPS here help in this patient who was a very heavy smoker but was otherwise asymptomatic. Patient with an adenocarcinoma in the left upper lung, and you can see endobronchial spread of infection here with centrolobular ground glass and to some degree more solid opacities related to spread of tumor within the air spaces. Okay, let's talk about the perilymphatic pattern just for a minute. Now, just by way of review, the lymphatics invest virtually all portions of the secondary lobules. We think about them as being very peribronchovascular, as in this particular example. But as we will see, there are also lymphatics in the interlobular septa and in the subpleural connective tissues as well. But characteristically, perilymphatic nodules will be seen along bronchovascular bundles, and you can see that perhaps better on this coronal reformatted image as these nodules ramify out from the hyla along the bronchovascular bundles. Now, as I mentioned, they may also be seen along the interlobular septa, but most characteristically is the location along the subpleural connective tissues and touching the pleura. So when you see nodular opacities adjacent to the pleura, as we see here, and on the coronal views along the margin of the lung, as you can see here, that implies a perilymphatic pattern of disease. Now, perilymphatic nodules are usually, in our experience, going to be due to sarcoidosis, and that accounts for the majority of cases. Lymphangitic carcinomatosis also can produce this pattern, and between the two of those, that is the vast majority of cases of perilymphatic nodules that we encounter on a daily basis. Other things that are occasionally reported to result in a perilymphatic pattern include pneumoconiosis, lymphocytic interstitial pneumonia, amyloidosis, and I'm sure we could come up around the room with a host of others, but usually it's going to be sarcoid or lymphangitic metastases. This was a patient with sarcoid, which will be discussed in more detail in the next talk. This is a patient with lymphangitic carcinomatosis in the right lower lobe. Here's the tumor in the right hilum, subcarinal nodes. What I want you to notice is the nodular opacities along the pleural surface, along the septa, and the thickening along the bronchovascular bundles. A perilymphatic pattern of spread here from the hilar tumor into the lung parenchyma itself. Here it is in the right lower lobe. Notice the nodular thickening along the wall of the bronchi. You have lymphatics there. You've got a perilymphatic pattern of abnormality. Here on a coronal, or actually sort of semi-sagittal MPR, we can see nodularity actually along the pulmonary veins, and on this volume rendered image, I thought it showed up very nicely the nodules along the pulmonary vein as well in this patient with lymphangitic carcinomatosis and a perivascular pattern. Okay, let's finish up with random nodules. And as the name implies, random nodularity means that you've got nodules virtually everywhere. Looks centrilobular, looks a little bit perilymphatic, but it's uniform and diffuse. Top to bottom, axial slices here, coronal view here. This is just chock-a-block full of small lung nodules. A classic random pattern of nodularity, or miliary pattern, if you will, particularly to use a chest radiographic term. Now, random nodules are frequently due to disseminated infection, as you know, miliary tuberculosis, histoplasmosis, other fungal infections, as were discussed earlier today, of patients who have a truly result in a miliary pattern, or a random pattern, if you will, on CT. And between the two of these, that accounts for the vast majority of patients who have a truly random pattern of nodularity on high-resolution CT. Other things we might want to consider: metastatic disease occasionally. That wasn't supposed to come up. Silicosis, co-workers pneumoconiosis, and Langerhans-Cell histiocytosis, excuse me, has been described as having a random pattern, but primarily it's going to be disseminated infection or sarcoidosis. This patient actually had disseminated histoplasmosis. They were mildly immunosuppressed, I think related to a renal transplant. Okay. So in summary, distribution of micronodular pattern, of course, is very important. The first thing you want to do is identify whether it's primarily centrilobular, perilymphatic, or random in distribution. If it's centrilobular, we may subdivide it into solid and a subset of solid nodules, tree and bud opacities, and then ground glass centrilobular opacities, and construct our differential diagnosis based upon those particular patterns.
In my next 20 minutes, I hope to cover the CT features of the idiopathic interstitial pneumonias, focusing on the fibrosing interstitial pneumonias, which I think are the most common diagnostic challenges in ILD practice, in fact, and also to talk a little bit about the multidisciplinary diagnosis. So this you're familiar with. This is the grid that we produced in 2002 with the ATS-ERS classification of idiopathic interstitial pneumonias. We, as radiologists and the pathologists, are morphologists. So these are the patterns we recognize. These are patterns of lung injury. And when the clinician identifies an associated morphologic clinical syndrome that's idiopathic, the clinician can apply the label of, for instance, idiopathic pulmonary fibrosis, idiopathic NSIP. So our job is to speak the pattern language and give a differential diagnosis. The clinician gets to assign the disease or clinical syndrome label. So what's going to happen next? Well, it turns out that nothing stays constant. There is a 2012 revision that's in reasonably advanced phase of completion. And the good news is there really isn't that much change, just update on our understanding. So that's mainly what I'm going to present today. So these top two, usual interstitial pneumonias and NSIP, have been grouped together now as the chronic fibrosing interstitial pneumonias. The next two, DIP and RB-ILD, are grouped as smoking-related interstitial pneumonias. Then these two, organized pneumonia, DAD, are grouped as acute or subacute interstitial pneumonias. And it's been recognized that lymphoid interstitial pneumonia is a very rare entity, and it's moved into a category with a couple of other rare entities. I'm not going to, for time reasons, I'm not going to talk about diffuse alveolar damage. We'll focus most of our time on these top two. It is important to know the relative frequency. In your practice, you should expect to see UIP most commonly, and NSIP is the next most frequent, along with the smoking-related lung diseases. Organized pneumonia is not a common disease, at least the cryptogenic form. And DAD is actually not that common either, and as I said, LIP is pretty rare. The reasons that it's important to make this distinction are on this slide. If you, as a radiologist, say that you see a UIP pattern, then you are telling the patient that their 5-year survival is about 40%. That's worse than breast cancer, better than lung cancer, but it is an important responsibility to make sure you're doing that right. So these criteria were published last year with the ATS-ERS statement on idiopathic pulmonary fibrosis. Basically, the process, the flow chart is suspected IPF. If you have an identifiable cause, then you clearly don't have IPF. You just go into some other algorithm. If you think it is IPF, the next critical thing is HRCT. And our task as radiologists is to identify whether the CT pattern represents the UIP pattern, in which case the patient receives a diagnosis of IPF, or whether it's possible or inconsistent, in which case the patient receives a lung biopsy and multidisciplinary diagnosis. So this is the language we should use. UIP pattern, possible UIP, inconsistent with UIP. And we'll go through the criteria for each of these. The diagnostic criteria for UIP have really changed very little over the years. It requires a subpleural and basal predominance with reticular abnormality and honeycombing with or without traction bronchiectasis. And you have an absence of features inconsistent with the UIP pattern. And we'll go through what those features are. I use coronal images, and we do routinely coronal images, but I find them particularly helpful for identifying the distribution of disease, and also somehow it's often easier to see the honeycombing on the coronal images compared to axial images. So this is a typical UIP pattern. This patient has UIP and usually would not require a lung biopsy. Now, the possible UIP, the only difference in these criteria with the ones I just showed you is the absence of honeycombing. So honeycombing is the pivotal distinguishing point. We do have to understand that there is a substantial minority of cases, or sometimes majority, with UIP in whom you can't make the diagnosis because there is no honeycombing. Those people need to go for biopsy because the features overlap with other lung diseases. So honeycombing is present in about 70 to 80% of UIP. It's the strongest indicator, and it does have prognostic significance. If you have UIP with honeycombing, about a 2-year median survival. Without honeycombing, survival seems to be longer. Whether that's because of earlier disease or a different disease phenotype, I think is unclear. So I think our most important job and the commonest issue we see in our practice is people being overdiagnosed with UIP, right? Radiologists in the community tend to overdiagnose UIP. There are actually papers that show that. So and usually it's for one of these reasons. These are the features that should lead you to say this is not consistent with the UIP pattern. Upper or mid-lung predominance, peribronchovascular predominance, extensive ground glass abnormality, profuse micronodules, predominantly in the upper lobes, discrete cysts, diffuse mosaic attenuation or air trapping, or consolidation. What's the reason this patient is inconsistent with UIP? What's the diagnosis here? Hypersensitivity pneumonitis with mosaic attenuation. Good. So this, just to reiterate, if you make a first choice diagnosis of UIP, you'll be correct about 85 to 100% of cases. If you make a confident first choice diagnosis, which usually means presence of honeycombing, the positive predictive value of that is over 90% in many series. But there is a substantial majority or minority of cases who have histologic UIP who you can't make the diagnosis, and those are the cases that still need to go for biopsy. And so this paper was published a couple of years ago because now that we're so good, the only people who are going for biopsy are those that don't have typical CT appearances. So Dr. Sferzolati found that only of people who had undergone biopsy, only 20 had high probable diagnosis of UIP, which is actually appropriate. And then the rest of them overlapped with CT appearances of NSIP, chronic HP, or sarcoid. So that's just a fact of life. There are some cases of UIP that have atypical features. We think that those people behave better than classic UIP. A couple of other imaging points about UIP. First is, this is a thing you will see. Here's a patient with moderate UIP, comes into the emergency room, hypoxic and short of breath, gets a PECT 5 months later, diffuse ground glass abnormality. What's the diagnosis? This is accelerated deterioration in IPF. It's a relatively common cause of deterioration and of death in the IPF population. And you, as the radiologist, really should suggest that diagnosis. Obviously, there's a differential, including infection, maybe lung edema. Usually, they'll get a bronch and lavage to exclude infection. The other important thing for us to look for is lung cancer. Probably somewhere around 5 or 10% of people with UIP get lung cancer, and the problem is that it hides out in the areas of fibrosis, so it can be very subtle, particularly in the early stages. So it's peripheral, lower lung predominant, maybe multifocal, and so you need to have your eyes open if you see any sort of solid mass in those people. So now we move on to NSIP. NSIP usually presents with a fibrosing interstitial pneumonia. It's usually fibrotic. Remember all that thing about cellular NSIP and fibrotic NSIP? The vast majority of them are fibrotic. So the key points are, as I showed in that earlier slide, it does have a substantially better survival than UIP. And the other key point is that when you have an NSIP pattern, you have a pretty high probability of having an underlying condition, either collagen vascular disease, hypersensitivity pneumonitis, or drugs. So always bear that in mind. And if you look at the literature on the CT appearances of NSIP, it's very confusing. But there is a particular CT appearance that we've learned to recognize that is pretty highly suggestive of this diagnosis. And it's characterized by basal predominance, so that's like UIP. But in contrast to UIP, it tends to be more peribronchovascular with sparing of the subpleural lung. And that's a useful diagnostic sign. It tends to be more confluent than the patchy distribution of UIP. Often you'll see a lot of lower lobe volume loss. Look at those fissures. Those lobes are really small. You will see quite a bit of ground glass abnormality mixed with reticular abnormality. Often you'll see traction bronchiectasis. Almost always you'll see traction bronchiectasis. You may see some consolidation. Honeycombing is uncommon and should suggest UIP. All right, so I'm just going to show you a couple of other examples of this. Coronal images, again, are very helpful in showing this confluent peribronchovascular distribution and the marked traction bronchiectasis and lower lobe volume loss. Typical NSIP. Here's another example. Traction bronchiectasis, some ground glass, but you know this ground glass is actually fibrotic because look at those dilated bronchi. And then that subpleural sparing. This is the image to fix in your brain for typical NSIP. Do they all look like that? No, but a substantial amount of the time you will be able to make the correct diagnosis, but unfortunately it's less specific. So most of these people, if it's idiopathic, will still go ahead and get a lung biopsy. And this is why, because there is overlap with UIP, HP, DIP, and even LIP. So there's just more overlap in this diagnosis. As I already mentioned, when you see somebody with NSIP, you should look for signs of collagen vascular disease. You should look for clues to hypersensitivity pneumonitis. Think about drug toxicity. We see a lot of nitrofurantoin lung for some reason, and there's actually a nice poster on that out there that can often look like NSIP. So always include drugs in your differential. Some people believe that smoking may also be associated with NSIP. What happens to people with NSIP over time? Some of them get better, okay? Get better on treatment. I think most of them just say exactly the same. You can follow this. This is a 4-year follow-up, and it looks identical. So it seems to be just a once-off lung injury that the patient is just left with disability. And then there are some people, a minority, who actually progress. They look like this, typical NSIP. They actually get honeycombing. And this, of course, is confusing because it suggests that there's some overlap between NSIP and UIP, and people have done histologic studies as well that show that you can evolve from NSIP to UIP. It's a minority of cases, but you just need to be aware that that can happen. This is a paper from Dr. Silva and Dr. Mueller showing that when they followed these people over 5 years, they basically had an increase in the number of the subjects who looked like UIP or IPF. So it's something to bear in mind. Now, so a lot of our practice, as I said, is the fibrosing interstitial pneumonias, and you're sitting there trying to figure out, it's typically, is it chronic HP, is it UIP, or is it NSIP? What are the features that help us make that diagnosis? Another paper from Dr. Silva shows that honeycombing, as we already said, is uncommon NSIP, should make you think of chronic HP or UIP. Lobular areas of decreased attenuation should strongly suggest chronic HP. I showed you an example of that already, and likewise centrilobular nodules. You have to look for those findings. And then the presence of subpleural sparing is the best predictor of NSIP. And then the last thing is, if you have lack of lower lung predominance, if you have mid or upper lung predominance, then you really should think about chronic HP. Smoking-related lung diseases we're going to talk about very quickly. Respiratory bronchiolitis, the dirty lung appearance, centrilobular nodules, patchy ground glass. When you have more extensive ground glass, it gets the label respiratory bronchiolitis interstitial lung disease. That's a more clinical label. And then with DIP, the clue to the diagnosis is the ground glass abnormality, often associated with cysts within the ground glass. RB is usually mildly symptomatic, RB-ILD, and DIP usually much more symptomatic. This was a paper from the New England Journal last year. We looked at 2,400 cases of this in the COPD gene study. We actually found 194, 8% of this population had some sort of interstitial abnormality, usually ground glass abnormality. Clearly it was related to current smoking and pack years. They actually were less likely to have COPD, more likely to have a restrictive physiology. So it is a common finding in people who are cigarette smokers. Talk for just a couple of minutes about organizing pneumonia. You're all familiar with this at this point. Patchy consolidation, like the word says, it's an organizing pneumonia. Often it's either subpleural or peribronchial, and sometimes associated with ground glass. Relatively nonspecific, there are a lot of causes of lung consolidation. Two clues to the diagnosis would include this perilobular thickening. Dr. Franquette showed an example of this morning in a post-infectious organizing pneumonia. So this irregular thickening of interlobular septa should lead you to at least wonder about organizing pneumonia. And actually in our practice, we see this particularly with the drug toxicity like nitrofurantoin. And then the other classic clue to the diagnosis is this reverse halo, peripheral consolidation, central ground glass abnormality, also called the Atal sign. Again, these are just patterns of lung injury. They can be cryptogenic, but they can also be collagen vascular disease, drug toxicity, aspiration, or even, as was shown this morning, infection. So again, you have to include a broad differential and not assume it's cryptogenic. What about multidisciplinary diagnosis? We all say, oh yeah, it's great to get together and, talk about cases and that sort of thing. Does it make a difference? So there are a couple of papers like this, two from the Michigan group, and this is one from Dr. Flaherty, where they looked at 58 cases, suspected IIP who'd undergone biopsy. They underwent independent review followed by clinical radiology pathology consensus. During the consensus review, 50% of the time, the radiologic diagnosis was changed. That's not surprising because these people also all had to undergo lung biopsy for diagnosis. So the biopsy changed the diagnosis. 30% of the time the clinician diagnosis was changed. That's largely because the clinicians had access to the imaging as well as clinical details. But the important point is 19% of the time the pathologic diagnosis was changed. And what drives that change? It's imaging. It's finding upper lobe predominant disease in someone with an NSIP pattern. That means you think it's HP. You find other features like mosaic attenuation. Those are the features that we identify that you have to stick to your guns even if the pathologist offers a different diagnosis. That's why this is important. So in summary, I hope you've seen that we're now trying to be more less list-driven and more organized about classifying the idiopathic interstitial pneumonias into fibrosing and non-fibrosing entities. That honeycombing, which you all knew, is the most important distinguisher between UIP, possible UIP, and non-UIP, and that multidisciplinary diagnosis makes a difference, and sometimes the radiologist is right.
Well, what a pleasure it is to be here today. Thank you guys for coming. So we're going to be talking about UIP on imaging, more or less. But we're not just going to talk about UIP as it is. We're going to kind of talk about where UIP came from, so pulmonary fibrosis in general. And we're going to talk about the rationale for why this was changed. It wasn't just so academics like myself can publish more, I swear. There is actually a rationale to why things were changed from 2011 to 2018. These are my disclosures, none of which are directly pertinent to this talk. Okay, so let's talk about where we're going to be going here. We're going to start talking about IPF 101, so just, for people who maybe don't know much about idiopathic pulmonary fibrosis or UIP, usual interstitial pneumonitis, we'll just get everyone caught up as best as we can. Then we're going to talk about UIP. So why have I said UIP probably 20 times already? It's the most important pattern, and in most clinics, the most common pattern of pulmonary fibrosis that you'll see. So that's why we focus on it. We're going to talk about that new UIP classification system that I alluded to, but again, with reference to the historical 2011 guidelines UIP classification system, because I'm assuming most people in the audience probably already know that. So let's leverage what people know to learn what's new. And then we will talk about a little bit of controversy, but let's get to that later. Let's talk about the good stuff first. All right, so I'm sure most of the people in the audience are very, very well aware that in 2011 we had these guidelines, this 3-tier UIP classification system. So if you saw pulmonary fibrosis on high-resolution chest CT, this is how you're supposed to describe it, either as a UIP pattern, possible UIP pattern, or inconsistent with UIP pattern. If you don't know this, if you haven't memorized this yet, please ignore this. Please just look at your smartphone right now. Right? Please don't look at me, don't look at the screen, because this is now defunct. We have new guidelines released in 2018. And so this is 2017. This was, PAP, so this is published ahead of print. But in 2018, the Fleischner White Paper officially released their guidelines on UIP classification on CT. And so we went from a 3-tier classification system to a 4-tier classification system. And so this 4-tier classification is actually better. And I will describe the rationale for why we went to 4 tiers and why the nomenclature of some of these classifications were changed. So now we have typical UIP, probable UIP, CT pattern indeterminate for UIP, and then CT features most consistent with non-IPF diagnosis. The great thing is that, again, if you knew the 2011 guidelines well, the UIP pattern, possible UIP pattern, and then inconsistent with UIP, there are many corollaries with the 2018 guidelines relative to the 2011 guidelines. So we're actually in luck. There's actually not that much to memorize. More things to understand than memorize in this talk. Before we get to the UIP-CT classification system, let's again talk about the very, very basics of idiopathic pulmonary fibrosis. So IPF, idiopathic pulmonary fibrosis, is the most common in most clinics and definitely the most mortal type of pulmonary fibrosis. Remember, it is a clinical diagnosis though, so we as radiologists don't make a diagnosis of IPF per se, right? With clinical correlation, perhaps we could if we were to go into the EMR, but in isolation, imaging never makes a diagnosis of idiopathic pulmonary fibrosis because the name says it all. It's idiopathic. There has to be no known cause for the patient's pulmonary fibrosis. And we, as radiologists, unless you see patients in a clinic, we're not going to be able to make that assessment, at least not in any, with any sort of accuracy. Now, UIP, usual interstitial pneumonia, is the imaging and histological correlate of idiopathic pulmonary fibrosis. And so, essentially, all cases of IPF are going to be UIP, okay? All cases of IPF are going to be UIP, but not all cases of UIP are IPF, okay? So that's a little factoid to remember. But just remember, if you have a patient with IPF, they have to have a UIP something, whether it's on histology or on imaging. Remember though, in this setting, the setting of interstitial lung disease and pulmonary fibrosis, pathology is not the gold standard. I don't know any other disease process where pathology is not the gold standard. If anyone in the audience knows of one, afterwards please come up and tell me so I could talk about it in future talks. But to my knowledge, in any other field, pathology really is the gold standard. And so in the setting of interstitial lung disease, it's not. Multidisciplinary discussion is the gold standard. Indeed, in the setting of multidisciplinary discussion, a pathologist, a good pathologist, not even just an average pathologist, but someone who's a world-renowned pathologist, will change his or her diagnosis 1 out of 6 times in the setting of MDD. Kind of blew my mind when I first saw that data, right? Because as a medical student, as a resident, even as a fellow, I just thought pathology was always gold standard. It's not, and MDD is certainly not. Bad news about IPF, universally fatal. Here's a survival, this is 5-year survival. So you see these bar graphs here. So IPF has worse survival than lung cancer, but not by much. And in fact, if you get all comers of non-small cell lung cancer, it's actually probably similar in terms of 5-year survival, but far superior survival to patients compared to patients with colorectal cancer or breast cancer. So you don't want IPF. You don't want anyone in your family to have IPF. Heck, you don't even want any of your worst enemies to have IPF. You're not those kind of people, I know, right? So IPF is a bad player. So how does one diagnose idiopathic pulmonary fibrosis? Well, again, idiopathic is in a name. You got to exclude known causes for interstitial lung disease. So first step is a detailed history and physical. Again, not done by us, usually done by a pulmonologist or a good internal medicine doc. Once you have excluded a known cause for interstitial lung disease, then what? Well, we are central to diagnosis as radiologists. HRCT really is the next step, always the next step. And there, if you have a UIP pattern, or now we call it a typical UIP pattern, or a probable UIP pattern, which is this is a little different compared to the old guidelines. So if you have those two patterns, typical UIP or probable UIP, with a high pretest probability of idiopathic pulmonary fibrosis, you're done. Drop that mic. You, as a radiologist, have actually achieved the diagnosis of idiopathic pulmonary fibrosis. We have obviated biopsy, which in this clinical setting is very important. So patients with pulmonary fibrosis, more and more data shows that if you actually do surgical lung biopsy, oftentimes you set off this acute exacerbation cascade, and those patients oftentimes will live far shorter than a year, most of them shorter than 3 months. So we are, as a community in interstitial lung disease, are moving away from biopsy. We are becoming essentially the histology and pathology, because I'll tell you, when I first started doing ILD in academic practice, we used to biopsy, I don't know, percentage-wise, maybe 10%, maybe more, 15%, maybe up to 20%, depending on the year or the place of our patients with interstitial lung disease. Now I'd say it's well less than 5%. So we as radiologists, we are the imaging and histology sort of combined in one. In so very difficult cases, still histology will be pursued. Okay. So what if you don't have a typical UIP or probable UIP pattern? Then what? Well, then you consider pathology. Consider doing surgical lung biopsy. You consider doing bronchoalveolar lavage. But that's up to the clinicians, the pulmonologists, and the internal medicine docs to decide. But based on that, then you get together in the setting of multidisciplinary discussion, and you duke it out. You try to figure out what the patient has in terms of their best diagnosis. And so this doesn't, so I know that everyone's getting busier. It's hard to do this. But it doesn't have to be done at the same time in the same room. It could be done temporally discongruous. It could be done at different times. I haven't had all my coffee yet, so I can't think of the word to say, right? But it could be done essentially via text, via email, assuming HIPAA compliance, right? So these patients aren't dying right now, right? They don't have aortic dissection, they don't have PE. You don't need the answer like yesterday. This can wait a couple of days, even a couple of weeks to figure out what's going on. So emails back and forth, text back and forth, there's no reason why you can't do that to save everyone time. Because again, as everyone's getting busier, hard to break from your normal routine and go to a specific conference with other people who actually have the same issues that you do. All right, let's talk about the UIP pattern. So the UIP pattern on CT, or now we call it the typical UIP pattern CT, is pretty powerful because it's where we as radiologists are most accurate and probably most helpful to our clinicians. So the correctness of a first choice diagnosis of UIP on CT from a radiology standpoint, from a radiologist, and it is important that it comes from a radiologist, is somewhere around 90% based on the literature. Now, if you looked at the correctness of a confidence first choice diagnosis, it's through the roof. It's around 95%. That's pretty much as good as you can get in medicine. I don't think there's anything else that I know of where the accuracy is greater than 95%, except maybe things based on genetics. This is tempered by the fact that in only about a half of cases can you make that diagnosis on imaging, but still pretty good. This is very important. So that pattern is now called the typical UIP pattern. The great thing about the typical UIP pattern is that in 2011, if you knew what UIP looks like, you still know what UIP looks like in 2018. Very, very little has changed. So what are we looking for here? Peripheral basilar predominant pulmonary fibrosis characterized by reticulation. You have to have subpleural honeycombing, right? So those little cysts in the most peripheral portion of the lung, which are lining up in rows or stacking upon each other, with or without traction bronchiectasis. You don't actually have to have traction bronchiectasis to call a typical UIP pattern. But the last thing is actually very important. Absence of features listed as consistent with a non-IPF diagnosis. So things that would draw you away from that UIP pattern toward other patterns, you can't see any of that. If you look at the Fleischner guidelines, they do say that sometimes in the zonal distribution, so that's up and down, superior and inferior, it can be diffuse, and I agree with that. But most of these cases are going to, again, be peripheral and basilar predominant. So here's an example here. Yeah, I think a medical student would probably make this diagnosis, right? It's rip-roaring pulmonary fibrosis, all those cysts at the lung bases lining up in rows, stacking upon each other. This is a patient with a classic UIP pattern of pulmonary fibrosis. No findings to suggest an alternative diagnosis. So that's a florid case. This is you never actually see that anymore, to be honest. Like, I don't see it, at least. Maybe it gets picked off in the community. This is what I see more often now. So I see little cystic things where I have to sort of blow it up and I have to scroll back and forth and say, is that honeycombing or not? Is it just a little bit traction bronchiectasis or bronchiolectasis? But I think in the posterior aspect, that left lower lobe, I think there are enough cysts there, subpleural cystic abnormality, where I'd be pretty confident there is some honeycombing back there. Clearly peripheral predominant here. Zonal distribution shows that it is indeed basilar predominant. So peripheral basilar predominant pulmonary fibrosis, subpleural honeycombing, no other features that suggest an alternative diagnosis, UIP pattern. Obviated biopsy. Do not biopsy these patients. We don't need to do it. Okay, but this pattern more or less has not changed since 2011. So UIP, they've just changed the nomenclature to typical UIP for really no good reason, right? UIP should have just stayed UIP, but it is what it is. So that's good. Now let's talk about probable UIP. So probable UIP, this nomenclature has changed. So this was formerly known as possible UIP. Now we call it probable UIP. But again, good news. In 2011, if you knew what possible UIP was, more or less, you still know what probable UIP is because nothing has changed, just the nomenclature more or less. So also, if you remember what UIP, or now we call it typical UIP, looks like, peripheral basilar predominant pulmonary fibrosis with reticulation and subpleural honeycombing, you know what probable UIP looks like. It's exactly the same, more or less, except for one small caveat, no subpleural honeycombing. So that's really a powerful differentiator of a UIP, probable UIP versus typical UIP. Here's an example. Clearly peripheral, clearly basilar predominant pulmonary fibrosis characterized by reticulation, no subpleural honeycombing, no findings to suggest an alternative non-IPF diagnosis. This is something we call probable UIP. Formerly, we would have called it possible UIP. Whoops. All right. So let's talk about words. Let's talk about that nomenclature, the shift from possible UIP to probable UIP. So words are very powerful things because I think it changes your mindset. And I think that's the rationale behind why the nomenclature was changed from possible to probable. So this is an interesting study for people who like psychology and behavioral economics. I really do. It's fascinating stuff. But these researchers in the Harvard Business Review, they went up to 1,700 just normal people, lay people, and they just asked them, if I say this word, how sure of you of that actually being true? So it's things like likely or mostly or slam dunk or home run, right? These sort of terms. How sure of you? Pretty fascinating stuff. And so here's an example here with these all the way on the right. These are areas where people thought that was 100% confidence, and then over here, all the way on the left, people thought 0% confidence. So never means never, always means always. That's obvious. But then all these terms are sort of in between, right? So let's blow it up. Let's look at possible or possibly. So possibly less than 50% confidence, right? We see that here. Probable, greater than 50% confidence. And so that's interesting, isn't it? So possible and probable, which to me, didn't actually make that much of a difference. Actually, to I guess the lay people or the majority of people out there, maybe I just don't know English that well, is vastly different. So possible to most people means less than 50%. Probable means greater than 50% likelihood of something happening. So now let's look at this pattern. Okay. So probable UIP, again, formerly known as possible UIP pattern. If you look at the data, the literature, you will see that if you have this pattern on CT, the yield on UIP is somewhere in the 80 to 90% range for UIP and pathology, right? So what am I saying? If you see this pattern, 89% of the time you're going to have UIP and pathology if you were to pursue pathology, 80 to 90%. So now it seems obvious. Why would you call this pattern possible UIP when possible means less than 50% likelihood, when in fact it should be more like probable UIP? Which again implies that it's greater than 50% likelihood. Just as an aside, the actual correct term we should have used is usual. So usual is actually like around 80, a little bit or above 80%. But for obvious reasons, we cannot call this usual interstitial pneumonia, right? That just wouldn't fly. So I think that's why they choose the term probable UIP. And again, it changes your mindset. So based on this, the new guidelines, Fleischner guidelines, actually suggest that these patients should no longer get biopsy with a high pretest probability of IPF. I alluded to that before. In 2011, this same pattern, which again we called possible UIP at that time, we still biopsied those patients. It was suggested we do surgical lung biopsy in these patients, even with the morbidity and mortality associated with that procedure. But now that we understand exactly the UIP yield on pathology with this pattern, now it's suggested we do not biopsy these patients if you have a high pretest probability of IPF before you get that CT scan. So actually this is very important. Okay, so we talked about typical UIP. We've talked about probable UIP. Let's talk about and probably for those astute people in the audience, you've probably noticed that I've skipped this one, but this is a little harder. So let's just go to this. Let's talk about CT features most consistent with non-IPF diagnosis. So again, good news. So if you knew what the inconsistent with UIP pattern was on CT in 2011, you know what this pattern is, more or less exactly the same. And so if any of these 7 features are present on CT, you can invoke this pattern, this category. And so these patients certainly would require biopsy in a lot of situations to establish the diagnosis. And so it's hard to remember 7 things, so I clumped them together. I clumped distribution. So is the distribution not right for UIP? Instead of being lower lung preponderant, is it upper or mid lung preponderant? Instead of being peripheral predominant, is it more central parabronchovascular? Is there too much density in the lungs? So extensive ground glass abnormality, above the degree of reticulation, a lot of consolidation in the lungs, diffuse nodular lung disease, all these things that really they don't jive with UIP. So you would invoke this pattern. Or is there not enough density in lungs? So is it hypodensity, these hypodense things? So extensive mosaic attenuation or air trapping with sharply defined margins, or frankly, diffuse cystic lung disease. All these things, they don't really make sense in the setting of UIP and will draw you to this pattern. Here's some examples here. Beautiful pattern here of mild pulmonary fibrosis with ground glass opacity and reticulation at the lung bases. Clear subpleural sparing, if not central lung preponderance here. Also note the mildly dilated esophagus. There is also some traction bronchiectasis as well. Coronal reformation shows a similar pattern, but again, the subpleural sparing here is, this is to die for, isn't it? I mean, you never see this anymore. I don't know why, but this beautiful subpleural sparing. So this would be very, very inconsistent with UIP, using previous terminology, and now we call this consistent with a non-IPF diagnosis. And I think that most people in the room know what this pattern is. This is a classic NSIP pattern, non-specific interstitial pneumonitis. Another example here, this basal predominant ground glass opacity, minimal superimposed consolidation. This patient had history of dermatomyositis. This is a combined NSIP and organized pneumonia pattern. Little pearl here, these patients with myositis who develop this sort of pattern, NSIP and OP combined, or just one of those, for some reason they're exquisitely sensitive to corticosteroids. So after corticosteroids, I bet you after 6 weeks this would just all melt away, but pretty classic. Another non-IPF diagnostic pattern here, clearly upper lung preponderant pulmonary fibrosis. This does not jive with UIP. The UIP, again, peripheral basal predominant pulmonary fibrosis. And just as a kicker, there's also superimposed diffuse nodular lung disease in this patient with sarcoidosis. Inspiratory image here on the left, expiratory image here on the right. There's a lot of things here that are not going with UIP. This is a non-IPF diagnostic category. On the inspiratory image on the left, we see a lot of ground glass opacity with mosaic attenuation. These dark areas that look like polygons, those are secondary pulmonary lobules. And in expiratory imaging, these areas are shown to represent a significant amount of air trapping. So this patient had hypersensitivity pneumonitis, non-IPF diagnostic category. Okay, and that brings us to this pattern, the CT pattern indeterminate for UIP. And so why did I leave this for last? Is because there's nothing to lean on. There's nothing from 2011 to sort of like use as sort of your crutch. This is completely new. This is a heterogeneous pattern. No one really knows what it is, but I like it. It's a really, really good pattern. And I think it's logical why we went from 3 to 4, because now we can include this pattern. So what is it? It's if it doesn't fit into any other category, or if it's really too subtle to call. If it's like just a kind of mild stuff where you're questioning if it's real or not. I mean, it really is for hard cases, and I love it. Here's an example from Dr. Lynch's paper in the Lancet Respiratory Medicine. This is actually the Fleischner white paper. So you see these axial and coronal images, and there's just a little bit too much ground glass opacity. There's a little bit of mosaic attenuation. There's even the distribution in the axial plane is not quite peripheral. There's actually a little bit more central preponderance than you'd like to see. But you kind of throw up your hands because none of these findings are so floored where you just kind of jump to that last non-IPF diagnosis category. This is a hard one. So this is appropriate for that indeterminate for UIP category. Another example here, basal predominant pulmonary fibrosis. There is ground glass opacity here, but there's a lot of reticulation as well. I don't know. I wouldn't know what to do with this exactly. Like maybe I'd try to pigeonhole into the least confident UIP pattern using the 2011 guidelines. But again, this is hard enough where I would probably put this in the indeterminate for UIP pattern. Hard case. Distribution also in the axial plane. Is it diffuse? Is it peripheral? Hard to say. Okay, so as I alluded to before in the previous guidelines, there was no place for these hard cases. And up to 10 to 30% of cases are actually difficult to subcategorize if you look at the literature. I think in actual clinical practice, probably it's closer to 10%, 10, 15%, but the literature says 10 to 30%. And unfortunately, using the previous guidelines, there was a tendency to miscategorize these. And I'll show you why in just one second. So here are the previous guidelines again. So again, we have a 3-tier system. We got UIP, possible UIP, inconsistent with UIP, right? So everyone here in this room is a human being. There are no AI algorithms, I don't think. So just being humans, if you have something hard, something like you don't know where to put it, right, in terms of categories, where would you put it? Would you put it on one of the extremes, UIP or inconsistent UIP? No, right? We just shove it in the middle. That's what humans do, right? That's why my residents, instead of coming down hard and saying something's mild or moderate or severe, they're always saying this like mild to moderate, moderate to severe stuff. And I'm like, just try to like come down on one thing, right? But it's just humans. Humans don't like to do that, right? So if you have a hard case using the previous guidelines, you would shove it into this possible UIP category, yes? I think most people would agree. However, if you look at the data, there isn't much data on the indeterminate for UIP imaging category, but there is a little bit, right? So if you look at this indeterminate category, the yield of UIP on pathology is around 55%, at least in this single study. And that's most similar to these patients with the non-IPF diagnosis imaging pattern, formerly known as inconsistent with UIP. Very similar, 60%, 55%, very similar. And very, very different from patients who had a probable/possible UIP pattern where the UIP yield was around 82%, and very different from the patients who had a typical UIP pattern on CT where they had a UIP yield of 90%. Okay, so if anything, using the previous guidelines, you should have shoved this into the inconsistent with UIP pattern. But they didn't do that. People just don't do that. And some data that presented to RSNA showed that almost all these patients who had a hard pattern on CT, something that we would now call indeterminate for UIP, they were shoved into that possible UIP pattern. So this is better. It's better to have a place for hard cases rather than trying to pigeonhole them somewhere where it doesn't fit. Okay, so I talked about a lot of the good news. There's a little bit of bad news. I didn't tell you about this. So there actually is a competing guidelines to the Fleischner guidelines. This is the multi-society ATS guidelines. So unfortunately, someone might say, well, there's more to remember here. Actually, there isn't actually more to remember. The guidelines, their guidelines, the multi-society guidelines, and the Fleischner guidelines are almost exactly the same. Typical UIP, they call UIP. Probable UIP, still probable UIP. Indeterminate for UIP, still indeterminate for UIP. And instead of calling it non-IPF diagnosis, they call it alternative diagnosis. So more or less, exactly the same. There are some nuances, but the trick is just use one and go with it. Find out what they're using at your center and just run with that. And then put this table on your desktop. Okay. Unfortunately, there is one big apparent difference between the Fleischner guidelines and the multi-society guidelines. It's actually kept me up at night. First time I realized it. So again, I alluded to this before, the Fleischner guidelines say that if you have a high pretest probability of IPF, and you have a typical UIP pattern or a probable UIP pattern, you don't need to biopsy those patients. You have made the diagnosis of idiopathic pulmonary fibrosis. And again, this is big. That probable UIP pattern is really big because formerly, in the 2011 guidelines, we would biopsy those patients, even though there's morbidity and mortality associated with that. But now we don't. Now you have typical or probable UIP, you have made that diagnosis. Unfortunately, that's how Fleischner, right? Unfortunately, multi-society guidelines, so ATS and all these other pulmonary societies, they got together and, there are so many people. If you get too many cooks in a kitchen, sometimes your cake just doesn't turn out, right? And so I think that's kind of what happened here. There are a lot of people with sort of different opinions on this topic. Depending on where they practiced. And so unfortunately in their guidelines, if you just read it at surface level, they say that if you have a probable UIP pattern on CT, they still suggest surgical lung biopsy, even though this is based on a very low quality of evidence, and this is a conditional recommendation, okay? I read this and I swear, I just had reflux up to here. I couldn't sleep that night. I felt like my parents had gotten divorced. I'm not kidding. It was just like these two very respectful societies that put out these great guidelines are disagreeing. So how do you resolve this? Thankfully, the main authors of the multi-society guidelines up till now, I think they've written 3 or 4 editorials on this topic. Because probably they're being bombarded with emails by people like me, right? People who can't sleep anymore. And so they actually have said, well, you know what? I know that's what the recommendations say, like at surface level, but they've written these editorials that more or less say this. Okay, if you have a probable UIP pattern on CT, and again, you have a high pretest probability of IPF, you don't need to biopsy those patients. So they agree. These are the main authors on these multi-society guidelines. So I think now, my stars have all aligned. The world makes sense again. So really, the multi-society guidelines and the Fleischner guidelines, they agree on this topic. So really, there's almost no difference between the two guidelines now. So the trick is to choose one and to run with it. Okay, so take-home points. I think the new UIP CT classification system is better than the old guidelines, and I described why. How does one make an IPF diagnosis? Now there's really, for us as radiologists, there's 2 big ways we can do it. Exclusion of a known cause for interstitial lung disease by our clinicians and finding a typical UIP pattern on CT, peripheral basal predominant reticulation with subpleural honeycombing, or exclusion of a known cause for interstitial lung disease and seeing a probable UIP pattern on CT. And most experts will agree with this. In more difficult cases, multidisciplinary discussion and diagnosis is usually mandated. So if you don't have a typical UIP or probable UIP pattern, you have an indeterminate for UIP pattern, or you have a non-IPF diagnosis pattern, one of those 2 patterns, those patients often still will require surgical lung biopsy. But still, even at that point, it's not like the pathologist makes the diagnosis. Remember, gold standard really is MDD.
Good morning. I'm Caroline Childs. We're going to move on to smoking-related lung disease. I live in a tobacco state, North Carolina, so I see a lot of smoking-related lung disease, as probably you do as well. So, not to overwhelm you with guidelines, this was the 2015 classification from the American Thoracic Society and the European Respiratory Society, classifying the idiopathic interstitial pneumonias. And I'm going to show you a close-up of this. So these are the two smoking-related idiopathic interstitial pneumonias, which to me is a little bit of a misnomer because if they're smoking-related, they're not really idiopathic. But nevertheless, these are the two, desiccative interstitial pneumonitis and respiratory bronchiolitis-associated interstitial lung disease. So these are the two that are included in this classification. So DIP, which has a lower zone peripheral predominance of ground glass attenuation, progressing on to lines and cysts, and then respiratory bronchiolitis, which is often upper lung predominant central lobular nodules. So let's go into more detail and show you some examples of both of these diseases. Now, in the topic of smoking-related idiopathic interstitial pneumonia, even though they do not include Langerhans cell histiocytosis of that, I'm going to throw this in here. These smokers do not decide they're just going to get one of these. There's often overlap, and people can have features of all three diseases on the same CT. So I'm going to go over all of these as smoking-related disease. So I think it helps to understand the histology, what's going on in the lungs when you're looking at these CT images, these high-resolution CT images, which can really mimic at least macropathology. So what the pathologist sees are clusters of pigmented macrophages. So they call these smokers' macrophages. They, instead of having the sort of purpley look, they have a brown tint to them. And pathologists will see these in everybody who's a current and sometimes former smoker. They see them all the time. And on this slide, you can see some of these sort of brown-tinted macrophages within the lumens of distal airways and within the peribronchial air spaces. And then as the disease progresses, as the patient continues to smoke, you might start seeing an inflammatory and fibrotic response surrounding within the peribronchial interstitium. And that is going to correspond with what we see on high-resolution CT. So really, depending upon what your profession is, RB and RBILD appears to you as three different ways. So to the pathologist sees this top one. This pathologist sees smokers' macrophages in virtually all actively smoking individuals. But to the radiologist, what we see are ground glass, sort of fuzzy central lobular nodules with an upper lobe predominance. And then the pathologist sees a subset of those patients who are symptomatic. They have cough, exertional dyspnea, they have a mild to moderate restrictive ventilatory defect on PFTs, usually an impaired DLCO. And when they have this combination of signs and symptoms and PFT results, and in association with a CT that shows these fuzzy little ground glass nodules in the upper lobes, and in these patients who are typically current smokers, they're going to make the diagnosis of RBILD. So we don't make the diagnosis of RBILD, we make the diagnosis of RB, and then it's up to the pathologist to determine if the patient fits the pattern of giving them a diagnosis of RBILD. So again, sort of three different levels of diseases: smokers' macrophages in everybody, ground glass nodules in a subset, and then symptoms in a smaller subset of those patients. So here's just a distribution of the central lobular nodules. They're predominantly within the upper lobes, sort of hazy or ill-defined. And here's a CT, and if you look carefully, you'll see these little ground glass sort of nodules, which you can sort of imagine to be within the center of secondary pulmonary lobules, sort of peribronchiolar, and this is a typical appearance. And if you're in a place where you have a high prevalence of smoking, you're going to see this every day, unless your slice thicknesses are too thick. So sometimes I'll see a patient referred in with a CT from an outside facility, and the slice thickness on the lungs will be 5s. Now, I don't know if they're reading them that way. Maybe they kept the thin cuts for themselves. You're not going to see this on 5s. You're probably not even going to see it on 2.5 millimeter slice thickness. So we routinely will look at our lungs on 1 or 1.25 millimeter slice thickness, depending upon which CT scanners they're on. And that's going to give you this level of being able to see the finding and having confidence in what the finding is. Now, I will say we go back and do MIPS where we stack them up together and see thicker slices. And we're going to see features in other patients that are going to look more, we're going to be able to distinguish vessels from disease better. But for the most part, this is the bread and butter of being a chest radiologist, are these thin cuts. So here's another example where when you look closely, you can just see these little ground glass nodules. You can distinguish them from pulmonary vessels, which are separate and branching. We may see sort of patchy sort of clumps that create ground glass opacities. You may see bronchial wall thickening. And then sometimes you'll see a little bit of tree and bud. These will just branch a little bit. Again, strikingly upper lobe predominant. Now, one hesitation I make is if I have a patient come in for a CT for pulmonary embolism diagnosis, we blast them with this big bolus of contrast, and I'm going to see so much in the upper lobes. I sort of back off the diagnosis of RB in those cases because I'm afraid I'm seeing small arterioles. So I just take a little caution before I call it on a PE study. So I'm going to move on to let me say one other thing about RB before I go on. Your differential diagnosis here is going to be hypersensitivity pneumonitis. Now, the good thing is that smoking seems to be somewhat protective from HP. So I just look at the history. If I'm trying to decide whether to call it RB or hypersensitivity pneumonitis, I just look at the history. If they're a current or recently active smoker, I'm going to go RB. So this pattern doesn't really completely go away once people stop smoking. It may improve, but it may not completely go away. Whereas patients with HP are usually never smokers, and then you can try to figure out what the exposure antigen is. Okay, so let's go on to DIP. And in DIP, the pathologist sees diffuse filling of air spaces by smokers' macrophages. And depending on the time course of the disease, you'll see variable degrees of fibrosis. So let's show you what that's going to look like on CT. The striking thing is it's peripheral and it's subpleural and there's ground glass opacity. You may see irregular linear opacities. You may see some cyst within this, but it's strikingly peripheral and subpleural. When it's not, sometimes I'll still consider the diagnosis, but I'm not as confident. In later stages, this is going to go on to be more of a fibrotic process. We'll see septal lines, traction bronchiectasis, architectural distortion, cyst formation as the disease progresses. Clinically, notice how all of this smoking-related lung disease presents pretty similar to the pathologist, to the pulmonologist. They all have exertional dyspnea, a dry cough. Now, this patient may occasionally have some weight loss and fatigue. There's an insidious onset. Patients are typically 20 to 50 years at onset. Men 2 to 1. Distribution. Smoking history present in 90% of cases, but you can see this type of appearance with dust inhalation or some drug exposures. Clinical findings, rouse on auscultation at 60%. About half of patients will have digital clubbing. PFTs, again, a restrictive pattern. So unlike the patient who has central lobular emphysema is going to have an obstructive pattern, in DIP, you're going to have a restrictive pattern and a reduced diffusion capacity for carbon monoxide. So here's sort of a classic example. If I was writing an article on this, this is the case I would choose. This is, you can see how strikingly peripheral and subpleural this is. It's ground glass. And then if you look up closely, you'll be able to see some tiny little cysts beginning to appear in this. So this is sort of a classic example of DIP. And so you'll have a heavy smoking history, and you have the classic clinical pattern, and then you'll discuss with pulmonologist whether you need to go on to DIP, but it's pretty classic and should be able to treat without that. Here's another case that's not quite as classic. I see this ground glass opacity, but it's not strikingly peripheral and subpleural. And yet, in the absence of any other clinical findings, no evidence of infection to suggest an atypical pneumonia, heavy smoking history, this should be in your differential diagnosis for this patient. And then here's another one where it's a little bit more clearly subpleural. You're probably going to consider the possibility of NSIP in this, but this turned out to be a DIP on biopsy, and you can see this ground glass subpleural pattern. And perhaps a few little bit of lines in here as well. Now, this is another patient much further down the road. And so this is sort of the fibrotic form of DIP. And you can think of this in terms of the categories that Dr. Chung has just reviewed with us, where do you want to call this typical, probable, indeterminate, not consistent with? So when you look at this patient, you can see, well, you know, there is definitely some traction bronchiolectasis. I may not be able to call honeycombing, but I can see traction bronchiolectasis. There is a mosaic attenuation pattern, a lot of ground glass. And so this is a patient you might end up in your indeterminate category, and you might be thinking, I'm going to need to go to a biopsy. If, on the other hand, you can retrieve prior CTs that will show you more of a typical DIP pattern, then I think you could make a more confident conclusion that this represented a fibrotic stage of DIP and avoid a surgical biopsy at that point. Let's move on to Langerhans cell histiocytosis. Again, starting with the histology. And this is a beautiful picture from Jerry Abbott's article in Radiographics on Langerhans cell. But it took me a long time to understand what it was a beautiful picture of. So I'm going to explain it to you. So this is a bronchus sort of laid out end on. And these are three different levels and time points within the disease process. Because these patients started smoking back when they were teenagers and they continue to smoke, they have temporal heterogeneity. They'll have disease manifestations that are more acute, subacute, and more chronic. So you can see all of these findings in the same patient at the same CT. And so that's what can make this disease a little bit unusual in appearance. So in the beginning, there's a normal bronchus, and then the patient develops these discrete bronchiocentric stellate interstitial nodules separated by normal lung. And so at this point, here we have our nodule, and it may even completely obliterate the bronchus. And then over time, here we are where the nodules are replaced by a fibroblastic proliferation, and the fibrosis starts pulling this bronchus open into appearance of bronchiectasis or bronchiolectasis. And then even further down the road, the fibrosis can completely occlude the airway. We can end up with bronchiectasis and enlargement of the surrounding air spaces. And so we may see all three levels of disease in the same patient, or we may see just more of the acute process or more of the end-stage process. So let's look at this. So again, an upper lobe distribution, small nodules with cysts, and these cysts will look sort of like cavitary nodules. And I used to think they were cavitary nodules for a long time, but they're actually those the bronchi within the nodules rather than discrete cysts. So here's an example of a patient where we have these sort of stellate nodules. You can see they're just larger and more solid in attenuation than an RB. So you can be thinking about RB, but it's a little bit serious for RB. And then we have these cystic lesions as well. So again, you can see why, for a long time, we've considered these to be sort of cavitary nodules. That's what they look like. But these are really distended air spaces and areas of discrete bronchiectasis because the fibrotic process is pulling that airway open. So this is a typical appearance of Langerhans cell histiocytosis. And you're going to see this quite commonly, not always this severe, but you may see a few manifestations. And it can get a little challenging when the patient also has some central lobular emphysema. So the central lobular emphysema has black holes that don't have discrete walls, whereas these have discrete walls. But here, as we get later in the course of disease, this is the same patient, what was that, 4 years later? Let's go. So this was 2007. This is 3 years later where we get, we're losing some of the nodules and we're just getting more of these thin-walled cysts. And you can see how irregular it looks because there is a fibrotic process. But again, upper lobe predominant. You might initially think about whether or not this patient has emphysema, but the walls of the cyst are just too thick for that. And here we are, another 6 years later, same patient with these thin-walled cysts. We're really not seeing the nodules. We're later in the course of disease. Patient may not be smoking anymore, and this is sort of the end-stage look of Langerhans cell histiocytosis. No biopsy is necessary. This is pretty classic. Here's another patient, and again, sort of this typical appearance on these multiplanar reformats. You can see the upper lobe and mid-lung preponderance of these stellate, irregular nodules, and irregular cysts. So notice that these air spaces are not always nice and round. They can be irregular looking, especially in more end-stage disease. So again, a typical appearance of Langerhans cell histiocytosis. Clinical presentation. All of these smoking-related people look the same clinically: dry cough, exertional dyspnea. Occasionally, they'll have fever and weight loss. About 15% will present with pneumothorax, and the age at onset, 20 to 40, and males involved equally as females. So if we look at the clinical findings, often the patient has no clinical findings. Occasionally, they'll have digital clubbing. PFTs can be anything. It can be obstructive because more of the air trapping is predominating. It can be restrictive because of more fibrotic process, or it can be mixed. But as with these other diseases, the DLCO is impaired. Another disease that has gotten some attention more recently is this concept of combined fibrosis and pulmonary emphysema. And the reason it's important for us as radiologists to know about this disease is that it's a confusing presentation to the pathologist. The pulmonary function tests are difficult to interpret. Because there's a combination of an obstructive component from emphysema and a fibrotic component from the basilar fibrosis, the obstructive and restrictive components sort of balance each other out, and yet they have a terrible diffusion capacity. So the pulmonologist doesn't really know quite how to put that together, and the CT can help with that. So again, dry cough and dyspnea, they all look the same walking in the door. The pathologist may report a combination of emphysema with either a UIP or an NSIP pattern, or they may just report out a combination of fibrosis and respiratory bronchiolitis because they're seeing these smokers' macrophages. On imaging, we see emphysema in the upper lobes, as typical, and we'll see lower lobe fibrosis with preserved lung volume. So although the lung volumes might be large with emphysema alone, small with fibrosis alone, they balance each other out, and we get sort of normal lung volumes. So the prognosis is better than the dismal prognosis of UIP, but it's worse than if they just had emphysema. And it's worse if they also have pulmonary arterial hypertension. The risk of lung cancer is very high, and as with some of these other diseases, the diffusion capacity is severely reduced. So this, again, confusing on the basis of PFTs alone, and the CT is pretty straightforward. You're like, what's your problem? This is sort of obvious. So here's an example of one, chest X-ray. You can see that although we can recognize this fibrotic pattern at the bases, the lung volumes are preserved. Most of our patients with a fibrotic lung disease, you're going to see shrinking of those lung volumes, those diaphragms coming up. And when we look at these multiplanar reformats, a typical appearance of central lobular emphysema in the upper lobes combined with a fibrotic pattern at the bases. And you can see why they balance each other out in terms of the obstructive and restrictive component on pulmonary function tests. So that's just one disease to be familiar with, even though it's really two diseases stuck together. Okay, I wanted to make sure we had a little time to talk about this new thing we're seeing, which is vaping-related lung disease. So this has the unfortunate name of EVALI, e-cigarette vaping product associated lung injury. And this just appeared on the scene this summer, but how many people have seen a case of EVALI at their institution? Okay, so many of you have seen this. This data is from the end of October when there were 1,600 lung injury cases, but many more have been reported since then. At that time, there had been 34 deaths, 70% male distribution, median age of 24, and about 3/4 of the patients had reported using products containing THC. One of the current theories is that these pods that patients are using they've put vitamin E as a filler to sort of thicken the stuff that they're vaping, and that may be the whole reason for this disease. But not all patients report using THC. So when you encounter a case like this and you think it's vaping-related lung disease, you notify, well, we don't, but somebody notifies the public health department. They go to the patient's house, they collect the pods, and they take that from there to figure out what is responsible for this. They're really trying to nail down the causative agent here. So this is when the disease started. So you can see that it trickle of cases in June really started becoming a national problem in July, and then going up through August, September, and at this time I did not have the more recent, but you can imagine this is an upward slope. Despite what's known, what's the media are covering, we're still seeing cases of this EVALI. So the symptoms are confusing. At first, when I had read about it, I thought, oh, well, they walk in, they're short of breath, they say, I've been vaping. It's going to be straightforward, but it's not straightforward at all because they have systemic symptoms. They don't just have cough, shortness of breath, chest pain. They have these systemic symptoms of nausea, vomiting, abdominal pain, diarrhea, fever, chills, weight loss. You think they've got an atypical pneumonia, that they walk in seeming like they have an atypical pneumonia. The symptoms may have developed very acutely over just the last few days, or could have been more insidious and coming on over weeks. But these systemic symptoms really take the clinicians down a different path. So when they come in the ER, they're going to initially think that this person is infected. Now we know a lot more about this, and so we're a little bit better. But in September, the CDC issued these guidelines for confirming the definition. They said that they had to have used an e-cigarette or vaping product within the last 3 months prior to the symptoms onset. That's a pretty big window. They have to have an abnormal chest X-ray or chest CT showing opacities. You have to exclude pulmonary infection. Because these mimic an atypical pneumonia, we need to make sure that all the viral panels, the influenza PCR is negative, all other testing for a respiratory agent is negative. And then you have to have no good reason to call it something else. And if all of that, basically they come in, you think it's atypical pneumonia, they start them on a broad spectrum antibiotic or antiviral, but they're not responding, you never recover an organism, but then you get that history of vaping. So I'm going to show you the first case we saw. So this was a 23-year-old woman, I think this was end of July, and she had fever, chills, myalgia, dry cough, increasing dyspnea, tachycardia, and she had this history of Juul use. This was her chest X-ray on admission. No matter which way I look at this, it comes back normal to me every time. I can't see anything on this chest X-ray. This is her CT 3.5 hours later. And now you can see these areas, these patchy areas of subpleural ground glass, maybe even more frank consolidation here. It has a pattern that sort of looks like an organizing pneumonia pattern to me, but this is acute illness. And so, as you can imagine, we read it out in late July as suggestive of an atypical pneumonia. The clinical pattern with these systemic symptoms, this chest CT looked like an atypical pneumonia. And this is just our multiplanar reformat showing you this very peripheral distribution of disease in this patient. This is 48 hours later. That chest x-ray has gone from normal to abnormal, and you can see now the corollary of what we were seeing on the CT. You could imagine now what was ground glass is going to be more frank consolidation with more of a basilar predominance. At this point, this patient's getting pretty sick and is being moved to the intensive care unit. And this is 72 hours after admission, and you can see she's intubated. We probably need to pull that endotracheal tube back, but she is very sick, and they're calling in the clergy and her parents and thought we were going to lose her. So she was very, very sick. And at some point, they start piling on the steroids, and the steroids are what's going to help reverse this inflammatory process. So here's the recommended management. Well, you have to treat for everything else you think could be going on, which is predominantly, you think about infection. And it's interesting that the physical exam is pretty unremarkable. Now that they're coming into the ER and they may not be as sick when they first present, they basically say you've got to admit if their oxygen sat is less than 95% because they could go downhill very quickly. Consider an empiric use of a combination of antibiotics, antivirals, or steroids. And then you want to follow up very quickly after discharge because they can have some other complications. So she comes back 3 days after discharge. I think she was in the hospital for about 2 weeks, and 3 days after discharge, she comes back with crepitus on her physical examination. So at this point, she was discharged with a pattern that was sort of a resolving ARDS pattern, but now she has pneumothorax, subcutaneous emphysema, and came back into the hospital to make sure that we could manage that. So you can see because of this sort of ARDS pattern, she had developed these cavitary and bullous type lesions, which rupture and give her the pneumothorax, and you can see her pneumomediastinum as well on this CT. This is just a multiplanar reformat showing you sort of a resolving ARDS pattern. This is almost 3 weeks after her admission. We brought her back in the hospital, discharged her again, and this is a week after that. Again, just sort of slowly resolving ARDS. Not sure what we're going to see down the road. My expectation is she's going to be like some other ARDS patients we have, end up with sort of an obstructive bronchiolitis obliterans type picture. So this is what she's looking like now. I would think her lung function will always be abnormal. So the pathology at that time, and we had our own pathologist read it, and we sent it off for expert pathologists. The path report wasn't that helpful. The differential is quite broad. That's always a bad sign. I can give you a broad differential. I need something specific from the pathologist. It could be anything, but they did add in this particular patient, since we told him she'd been vaping, it may be that vaping THC is responsible. So that was our very first case. This was the next case. We were smarter. This patient came into the ER, very similar picture. Could have been the younger sister of the first patient. 22, myalgias, fever, chills, nausea, vomiting, history of vaping. Chest x-ray, maybe a few little patchy areas, but again, hard to call. And then 2 days later, you can see her chest CT has these patchy areas of ground glass attenuation. Again, with the clinical picture, and with the CT, it would be perfectly reasonable to think this is an atypical pneumonia, but now we have to add vaping-related lung disease, or EVALI, to that differential. So CDC recommends a chest x-ray in all patients with a history of e-cigarette use and who have respiratory or GI symptoms, particularly when accompanied by an oxygen saturation of 95%. It's pretty high threshold, 95%. It's not that low, but you just have to have a very high index of suspicion when they come in and tell you. And be quick to go to CT. Even if the chest x-ray is normal, you want to be quick to go on to CT because it will show you findings that that you won't see on that chest X-ray, and will help keep, I think, the clinicians on top of the potential for rapid deterioration in this patient. So I was trying to figure out a conclusion slide for tying all of these together. Before I do that, let me show you this. This is one article that was published online in October. Travis Henry is the lead author, Imaging Findings of Vaping-Associated Lung Disease. It's going to show you some more examples, and some of these were obtained really before the epidemic and probably are related to the vaping itself and not necessarily to this more recent THC-associated injury. And also the very similar slide collection is on the website for Society of Thoracic Radiology, thoracicrad.org, so if you want to look at some examples. And they report that there are many imaging patterns. Again, the ones I've seen sort of look like organizing pneumonia. I think lipoid pneumonia is within that, acute lung injury, diffuse alveolar hemorrhage, and even a hypersensitivity pneumonitis has been reported prior to this sort of THC phase. So here's my conclusion. Smoking's bad for you.